coordination platform. What that means is one comprehensive care coordination platform that really spans and optimizes care delivery across the orthopedic or musculoskeletal space. We start with preoperative coordination, which includes all the coordination and getting all the different people aligned for preparation for surgery, and also, of course, the scheduling piece. We provide full clinical communication solutions, obviously HIPAA compliant, and then post-operatively, once you discharge a patient, how do you track an episode of care management solution? All of this is lightweight, web and mobile-based. We plug into EMRs, and we basically are able to longitudinally track each patient regardless of institution, regardless of EMRs, and we can talk a little bit more about that as we get into it. Let's talk specifically around the COVID-19 outbreak and what the challenges are that has raised. If you look at, first and foremost, not surprisingly, what we're seeing is a massive cancellation at a large scale of surgical elective surgeries. They basically halted, whether it's canceled or rescheduled, and it's just not. It's really halted. This causes obviously an instantaneous backlog of surgical cases and clinical cases, unprecedented. We've never seen anything like this, and I'll show you some data to represent that. At the same time, when we talk to a lot of our surgeon clients, customers, what everybody's dealing with is having to potentially do some significant reduction in force or furloughing employees so that they can weather the storm. And this becomes the perfect storm, right? You've got all these surgeries that are in backlog, and now you don't have the resources. So what are you going to do? How are you going to remobilize and activate these patients when the time is right? And that's really what our solution is intended to help with in this time of crisis, providing you a surgical back booking tool and schedule. A little bit more about the product before I get into the specifics. So docspera has two core solutions, one around the preoperative care coordination. So think of it as from the time of surgery decision, often in the practices, our platform is used by hundreds and thousands of surgeons to really book patients and coordinate that care preoperatively, everything that is required. And then post-operatively, we track those patients after discharge, and we provide alerting and monitoring, and ultimately with a goal of providing improved outcomes and from an effective cost. So think of longitudinally 30 to 60 days preoperatively, all the way through to 90 days post-discharge. Our platform is tracking each of these patients and providing you visibility and performance. Let's talk a little bit about what we have seen with regard to the platform and what's happening with surgeries. We today have processed about 300,000 to date. We've processed about 300,000 surgical cases and over 1 million clinical lives through the platform. And so when we look at holistically, specifically around these clinical cases, what you're seeing, around elective surgery cases, what you can see is starting in last month, we've seen a significant drop in terms of the volumes of cases. We were seeing around 10 to 15,000 elective cases on a monthly basis. That's basically come to a halt. And when you look at what the reason for that is everything's been canceled. Everybody's had to put elective surgeries on hold for now. And you can see historically, we're seeing about 18% cancellation rates. But now we're seeing upwards of 60%. So pretty significant. Obviously, this is a problem for our surgeon community, not now, but even poses a bigger problem as these cases need to start to get rescheduled and come back online. How are we going to do all this? Not to mention the impact that this is having on the patients. A lot of patients who were waiting for surgery maybe are in pain. So the need for us to be very nimble and quick in getting things back up and running when time is right and being able to prioritize the right surgeries, the right patients at the right time is really what our platform really helps to accomplish. So let's talk a little bit more about that challenge. Let's assume you've now canceled your surgeries, and we know, given how quickly things went offline, we know that the return is not going to be exactly orderly, and it's going to require a lot of work. So there's a couple of things that we need to do. One is, how do you keep your patients happy? How do you make sure that during this period of time you're not losing patients? So what are you doing in terms of communicating with them, keeping them engaged, and serving their needs during this period of time? And secondly, it's around operationally. How will you manage all of this against the demand and the capacity that's going to come back online when things ramp back up? So imagine a case study around, things are starting to come back. The ASC contacts you and said, hey, I've got a 2-hour block on next Tuesday. What are you going to do? How are you going to find which surgery you should be doing, which patients should get prioritized? How can you be nimble about all this? It's difficult to do manually, and that's really where what I'd like to address through this presentation and talk about how docspera's scheduling and coordination solution can help with a lot of this rebooking and the complexities that are involved in this. Where in fact, as a side, we're in the process of deploying this at UCSF as well. So let's talk about the scheduling optimization more specifically, and what our platform actually does. What's the goal? The goal really here is, how do I get the right patient at the right time in the right OR slot with minimal effort and maximum productivity? And so to do that, there's a lot of different factors you got to look at and to try to optimize, to figure out what is the right way to reschedule a lot of these patients. Is the patient ready? Have they gotten their medical checklist clearance completed? Is clearly one that you need to make sure that you have a handle on. What about the complexity of the case? Let's assume that if you have a revision that is more complicated, you certainly don't want to put those back to back. So having some rules around how you want to scatter these more complex cases throughout your schedule is important. The OR allocation, what type of OR room is it? Can it handle a revision or not for the case that you want to do? Discharge disposition. Does the patient need to stay overnight, depending on the complexity of the case? It's certainly in this pandemic world, last thing you want to do is do a surgery on somebody and have to send them into a nursing home. And so taking that into consideration is an important one. Urgency of the case. Maybe you have patients that have been waiting for a long time, or they're in pain. Maybe you tag them as medium or high priority versus others that are lower priority. So taking that into consideration is also important. And then finally, patient's availability. Maybe they have already done their clearance, but they, on a personal level, need a caregiver to help them. And so maybe they're not available. So really understanding what their needs are. So what our platform basically does is it takes a number of these kinds of inputs, by the way, that we call them business rules, configurable for you, the way you want to prioritize each of these items, and then provides you an algorithm and a recommendation and a real-time communication that provides you, here's the optimal scheduling that needs to be put in place. Here are the patients that should get prioritized based on the constraints that you have and the inputs that you have defined. So that's at a nutshell what the platform does and the algorithm. To talk more specifically now about our platform and how this works, I want to talk about a few different areas. How do we get this platform deployed and set up at different locations? That's number one. Number two, how does it facilitate around your workflows? How do we configure it around the workflows that you manage? How does the booking, we talked about this a little bit, how does the rebooking management actually work in the platform? How do you coordinate things across broad range of people? One of the great parts of this platform is, again, it's not specific to your practice. You can self-configure who the broad care delivery team is. So the surgeon and the care teams in the practice, the OR staff at the ASC or the hospital, the medical device rep that wants to that participates in this, the anesthesiologist. You can define that care delivery team, and everybody unilaterally gets communicated when there's a rescheduling, when there's a cancellation, and with all the relevant information so they can manage it. So how does that actually, we'll get into that a little bit more. And then what type of visibility, metrics, data do you need to really manage your specific practice? So I'm going to just flip through each of those briefly and give you a little bit more information of the platform. First and foremost, what we do is when we deploy at a location, what we'll do is we'll connect into the EMRs. We work with all the different EMRs, practice EMRs and large-scale EMRs, and we do a plug-in through an HL7 connection or a direct database. But ultimately, it's around getting the right relevant information from the surgical case and from the patient, and from a patient information perspective, and then being able to unilaterally share that with the right care delivery team, so that everybody is notified around the case information that is coming up. Secondly, it's around, for each of these cases, I talked a little bit about a communication platform. We've got a text-like messaging around each and every one of these cases, so that care team can really collaborate, can talk about, if you need to make sure that the rep is bringing a certain implant size, that can get communicated, or if the rep has some questions, they can communicate, or if the OR staff, it's a unilateral platform where you can collaborate and discuss around that patient, around that the schedule, and so forth. So it's all integrated around that scheduling. The third part is really around this, what I already talked a little bit about, around this rule-based rebooking solution. As we discussed earlier, here you have the opportunity of tailoring or configuring all the different inputs that you want to look at, whether it's the patient risk, or it's the clearances, or the patient availability, the discharge location, the OR capacity. All these factors go in, and then the system, as you can kind of see in the back of this, it's recommending different patients, red, yellow, green, as to who's ready for that slot that you should be prioritizing. And then finally, from an interface perspective, I already talked about, it's highly configurable, so you can define who the key stakeholders are for each of these surgeries, and making sure that you configure your care team along those lines. And then there's the power of having all the data in one place, highly flexible from a UI perspective. You can effectively have one person manage many different schedules at the same time. And of course, in this period of time, that's an important factor or functionality. It's just a simplified way for sequencing cases, managing the backlogs, and providing real-time visibility to these cases. And then, of course, the messaging features, alerts, and notifications that allows everybody to understand, hey, this schedule got rescheduled. Everybody gets notified. Everybody confirms, and so all that coordination happens all in one place. And then finally, the data and metrics that is worth maybe going through a little bit. On the back end of this, I showed you some data around cancellations already, but for your own practice or for your own group, you can have a set of dashboards and metrics that gives you the health of your business. What kinds of volumes are each surgeon's doing? How many cancellations are you seeing? How many reschedules? What are the lead times? We provide a lot of the analytics on the backside, so you can really manage your practice and make sure that you don't cancel a patient and then never go back to the backlog and be able to reschedule them, for example. So lots of different ways to use this data. And then finally, just to wrap up, in terms of the overview of the platform, I want to talk a little bit about the docspera platform broadly, a little bit more broadly with you. Obviously, we're in trying times, and we're working to present you guys with lots of different opportunities and provide our technology where it's most useful. At the end of the day, it's really about figuring out a way to solve these pain points for you guys, for surgeons, but also for the patients who are at pain and waiting for care. I spent most of this presentation talking about our scheduling solution specifically and the algorithms there. But as a platform, we've got docspera's deployed at several hundred locations already across the US. And we provide more than just scheduling. We certainly had talked a little bit about the episode of care management, but we also have a number of partners. Because we're a large platform, we have a lot of third-party partners that we evaluate and we plug in as an extension of value-added services that we provide as a company. So on-demand physical therapy referral programs, certainly at a time now where people are in pain, could be really valuable for people to be able to have access to and have a physical therapist come to their home to help them. Claims management. I know there's been several discussions around video consults. We certainly have an embedded partner that we provide for consultations through video visits integrated into our scheduling solution. And then we work with a number of patient engagement solutions where we can continue to have, or you can continue to have, a dialogue with the patients during this period of time. So with that, I'm going to pause, and Dr. Bini, I'm going to turn it back over to you, and maybe you can help with fielding some questions.
Absolutely. I'm going to just come up on screen with you and share. Thank you. That was a great run through. It's remarkable what we can now do, right, with these platforms by connecting various elements of it. You all start out as a primarily means by which to connect between the clinicians, the reps, and the operating room and then as that built out, you added more functionality.
That's right.
That's how it came out. Let's talk a little bit about one of the greatest features of this is if I have 6 schedulers in our office who are scheduling surgery, 5 of them are using just our paper for the most part, books, and those are not searchable. So if it's a cancellation, they're just trying to figure out who's available. And one of the great features of something like this is if it's searchable.
Yes.
Yeah. Talk to us a little bit about all the what makes the search function so effective.
Yeah, I mean, search is an interesting part. I mean, I would broaden the question a little bit. In fact, when we go in and we work with a number of different practices, what's really interesting is people are all over the place in terms of how they're managing their schedules. Some people are just relying on their EMR and they're using that to optimize. But most cases, there is a second way to really manage the cases. And your example of paper is certainly we've seen whiteboards. People have whiteboards where they're tracking and things. There are a number of different ways to manage it, but the power behind this is one, yes, that there's a searchability ability, so where you can actually put in some configuration and be able to get back results in terms of based on certain criteria which patients are most ready and available. But the other part around this is this eliminates the need for double entry. Whether you're writing things in a notebook or you're using another system to manage this, there's 2 key value propositions. One is it's all integrated. So it's all pulling it directly out of the EMR. So you have at your fingertips a cockpit where you're basically navigating all the different schedules, surgeons, patients, all in one place. And I think at the end of the day, that's one core value proposition. The other core part is today your practice has one EMR. The ASC may have a different EMR. The hospital may have a different EMR. What we do is we stitch it all together. It's agnostic. It doesn't really matter. We're basically, you're able to create your own care team. So everybody's getting notified at different institutions around one schedule. So yes, it's about the scheduling piece. And it's about the searchability, but it's more broadly, it's about one unilateral platform that really manages it across the board.
This is an interesting point because you're able to, if you've got 3 or 4 units, 3 or 4 hospitals you're working in, each of which working through a different EMR, if you're trying to schedule using the EMR as your primary scheduling tool, that means you're basically having 3 different entry points. Whereas what you're saying is that surgical scheduling platforms like yourselves can access all 3 of them and bring great visibility into each of those three, but also allow you to schedule from one entry point into 3 different electronic health records.
Yeah, so think of it this way. Many of our surgeons that we work with, they're in private practice. They do surgeries at 2 ASCs and a hospital. And all of those are on different systems. So how do you actually manage that? So what happens is the scheduler figures out the schedule at the practice, and then starts faxing and calling the different locations to figure out, is the room available? Can we coordinate it? What we do is we try to eliminate all of that. And we just say, look, if you have one lightweight platform that sits on top of all these EMRs, it can become the conduit of coordination of that care across all those institutions.
And I can imagine if you've just canceled 200 cases and you're trying to reschedule them, and you don't really care where you reschedule them, you're just looking for time. If you had been previously loaded on this platform, it'd sort of be easier than trying to do this manually.
Yeah.
So this is one of those tools that we felt was useful, and in the context of addressing and solving the problems caused and brought to us by this epidemic, which is something we were really expecting to have to do. You wouldn't imagine that your drop-off of surgical schedule would have dropped off that much last December or last November. I'm just looking through the notes that I made. Let's work through deployment, because there's going to be a fair number of questions about how to make this work. I'm just looking through the questions that are through here. The platform is a standalone platform. You don't have to integrate into the electronic health record for you to be able to manage patients, correct?
Yes, we provide the platform as standalone solution. We see the most amount of value when it's integrated into EMR, because it eliminates a double entry, and we pull automatically all the data from the EMR, so it auto-populates the schedules for you to the extent possible, and then you can complement and add things to it. So yes, it's standalone, but higher value with EMR.
Excuse me. So yeah, you answered the next question, which was there's an integration piece. Now I know we've been talking about this. Are you officially on the Epic Orchard for those systems that are on Epic? And on Cerner, is there a similar Orchard in situation? I mean, let's get into the little bit of detail, because if somebody is on those platforms, if you're not in the Orchard, of course, it's more challenging to integrate. The integration piece is not super easy. I mean, it's easy, but it takes a little bit of work.
Yeah. So first of all, we like to be at the ground level. So wherever the surgery is being scheduled, at the first point of patient decision around a surgery, within orthopedics, within the customer base that we have, we see a large percentage of our customers are really independent or private practice. When you look at private practice, they're not on Epics or Cerners. We work with a large suite of EMRs, most, if not all, the EMRs that certainly within orthopedics that are being used out there, with the GE Centricities, the Athenas, and so forth. So we work with all those. We have done integrations with all of them. In many cases, we're part of their marketplace already, which means we can turn things on very, very quickly. But we work with every single one of them, and we have a library of all the different EMRs and what it takes to actually turn each one of these guys on. We do work with Epics and Cerners as well, but again, the majority of the time that we're spending is with the other EMR companies, because they're practice-based EMRs.
Okay, so the smaller system is great. So just say that I am a 20-man practice in Kansas, and this may actually be a good time to transition to practice, because it's kind of quiet. What would that look like? Walk us through that.
Yeah, so once we agree that the platform is a fit for you, we do all integrations remotely. We don't even come on site. We can contact your IT person within your group, and our technology team, and they work together, and they do the plugins. and we're able to, through again HL7 or depending on what EMR it is, we will do the connections. We'll identify what fields in the EMR need to be pulled. Often that can take, depending on who the EMR is. If it's Athena, we can be up and running in a matter of a few days. And in some cases, it might take a little bit longer. The actual work is not significant. It's just getting all the mapping done for any custom work that needs to happen. And then once we believe that that's connected, then we will run some cases and make sure that we'll do the QA work to make sure that the cases that we're getting on our system reconcile back with the EMR cases, and then we turn the lights on and it flips on. And then once we do that, there's the second part, which is not integration related, but it's setup. It's really configuring. You have a 20-person physician group. Okay, you probably have 50 or 60 care team members or more. How do you want to configure? Who has the rights to do what kinds of things? Again, all of it is, we can handhold you through that, or you can do it yourself. You can basically go in and say, Dr. Beanie has these rights, his care team have these rights. Here's the extended care delivery team. Oh, by the way, Dr. Beanie works with Stryker and J&J, so those reps need to also be connected into that broad care delivery team. So everybody unilaterally, when the next case gets scheduled or canceled or rescheduled, everybody unilaterally is getting notified through their mobile phone or through the web to be able to access and understand what the upcoming cases are.
And last question for me, then I go to the audience, is how do you then bring your you got 200 people already on your books. That's all manually ported over one by one. Each patient has to be manual. At some point, you gotta merge the two, right? The historical platform or mechanism into this new one.
Yeah. So again, if it's already in the EMR, typically when we go into the EMR, we don't just start from day zero. We go back and pull all your historical surgicals that are still pending. So we get all that into the system right off the bat. So right away you'll get a pretty populated schedule. If you're doing things outside of your EMR, we have to understand where those are, what systems those are, whether they need to be manually entered. But I imagine most everybody's using some sort of an EMR, and that second set of tools that you're using, whether it's paper or whatever else, is in addition to what's already in the records that are in the EMR.
Okay, so a question from Scott Ashwork. This seems like an excellent solution for us, but how is this to integrate immediately, and how much time, effort, cost from surgeon staff? And there's another question around cost and time. Want to take that one?
Sure. So cost and time. Time, we started to talk about a little bit. It really depends on what EMR you're up and running. We can get things up within a matter of days. If it's an EMR that we are on their platform and a part of their marketplace, on a longer tail, it might take a couple weeks, 2-3 weeks to really get a practice set up and running. In terms of cost, look, we are in we are in trying times, and our goal is to figure out how we add value during this period of time. There's a lot of patients that need scheduling, that need surgeries. There are a lot of physicians that are struggling because of the everything kind of halted. So what we try to do is deliver the platform at the lowest cost possible. Obviously, there's two parts to that. One part is how do we support and maintain the platform on an ongoing basis? That's what we charge. Then there is the EMR costs, where the EMR say, hey, look, if you want to connect into this, there's a one-time fee upfront for doing that. So what does that all mean in terms of cost? You're talking about maybe a few $1,000, $2,000, $3,000, $4,000 to set up and get everything up and running.
Okay, that question, excuse me, that question was there as well. There's a question about a patient prioritization coding for the search algorithm. I suppose that, well, you want to take that? Is there a patient prioritization coding within the search algorithm built in already? In some ways, why don't you take the, I won't answer for you.
Well, I think the factors that I talked about, maybe I don't fully understand the question, but the factors that I talked about really effectively become the prioritization, right? Where's the patient relative to urgency of having to have surgery? Have they passed the clearance? Do they need a caregiver to manage them? Are they going to get, where's the discharge location going to be? All these factors come into our algorithm. If there's something beyond that the question is, I'm not sure. I know.
Yeah, I think that, let's just say that I decided that I wanted to prioritize patients with active or second stage infection surgery, or who have specific comorbidities, and I could create a set of criteria that would then identify the 10 patients in my backlog that meet those criteria.
Yeah. So one of the things I talked about is the factors that I talked about are the generic factors that we look at, but they're all business rules and they're all configurable. So to the extent that the data exists, we can work with you to say, okay, this is the algorithm that you really want to be able to use to be able to prioritize patients. And so we can configure those algorithms as inputs to our prioritization.
So the next question has to do with platforms. A number of companies started in one spot, but then grew out. Force Therapeutics started with the perioperative care platform. Now they offer physical therapy. The physical therapy platforms offer operative care. You guys picked at the beginning the interface between the hospital, the vendor, and the clinician have grown into a platform. The question is, how is this platform different from, say, Force Therapeutics or Ready Surgery, and there's several others that could be listed there?
Yeah, I mean, look, I'll talk about what we do, and rather than comparing us to others, because I think everybody's got their own views as to what their platform is and what it's intended to do. We started off, as you said, around at its core around becoming that core platform for preoperative care coordination. Over time, we went from pre-op to post-op and really taking a look at the entire journey of that patient from, as I said, point of surgery decision all the way through to discharge. Our focus as a company has always been around surgeon first. Not administration first, not necessarily even patient first. We don't directly communicate a whole lot with the patients. What we do is we try to drive a care coordination platform that brings all the different care delivery team members, the surgeons, the anesthesiologists, the OR staff, the medical device rep that you referenced. We certainly work with a lot of the companies to really provide one platform that you can use to manage that care. Because we've been able to deploy that across a number of locations, and we have several thousand surgeons on the platform, we now have lots of third-party companies that we work with to augment or add on additional services above and beyond our core platform. So when we talk, I reference, we have a partner that provides on-demand physical therapy. Again, if that's we look at every one of these opportunities, we say, how value add is this in terms of the value that we're providing to the surgeons? And if it is, then we add them as an integrated part. So now you imagine you're going through and you're doing a clinical visit, and in there you can just press a button that says on-demand PT. As the patient's driving home, they get a call from a physical therapist. Hey, I'd like to schedule some time in the next 24 hours, come to your house and help you. So that's an example of how we are leveraging the large install base and our software solutions to add on additional services to that are valuable.
Yeah, I think it's fair. And as someone who's a good chunk of my time is spent trying to identify solutions for our problems, I actually approach this problem first. What is a problem that I'm trying to address? What is a pain point I'm trying to address? And then I look at the solutions out there. They're all excellent, but they each have their strengths. And so then I focus on the solution that seems to be addressing the specific problem I have. And the other thing is that one doesn't necessarily have to work with just one solution. There's elements of any one of these platforms that we can deploy, and others that we simply choose not to. For example, should I already have, say, Force Therapeutics working with us, or Joint Academy, or any of these other companies that have been mentioned working with us, then I would just simply not use your physical therapy provider. or I can choose to use all of them. It's becoming more plug and play, wouldn't you think? It's becoming a little more. Originally there was this idea that I have to have one platform for everything because it was easier for the technology, the team managing the technology. And by the way, it's not just the smaller companies. These big big companies like Zimmer Biomet, Stryker, Johnson & Johnson, each have their own platforms that they're offering and making available to their people. So it a little bit depends on looking at what your problem is that you're trying to solve, looking at the options available to you, figuring out which integrates better, what the cost proposition is, and then making a decision. But these are all terrific solutions. They just each have their strengths, I would argue.
Yeah, I mean, I think the way we always talk about it is our platform is integrated, but also modularized. Right? You need to be able to have it. It has to be able to stand on its own. Maybe you just want a certain feature or certain functionality because that's the core problem that you're trying to solve. Or you can say, hey, I want the entire platform, and the platform provides me these things. And then when I need these other factors, I can add on.
Okay, we have 3 more minutes. Let me see if there's any other questions. So we answered the question of this variance. Prioritization. I think we pretty much covered everything. We talked about the fact that, maybe we didn't really quite say it. I think the question is, does each practice have to pay with integration into the EMR, or is it the part of the cost of the product? And I think you said that you consider a separate add-on cost because it varies a great deal. Is that?
Yeah, I mean, look, the good news is we work with all the different EMRs, and so we have a pretty good rates in terms of the integrations. We don't make money off of that. We just do a direct charge of whatever we get paid or whatever we get charged to do that work over to the group. And then on an ongoing basis, we will charge a nominal amount. Really, the point here is how do we actually deliver a platform that solves these points? Because again, goes back to what you were saying. Let's understand what your pain points are or what the problems are that you're trying to solve. Then we can tailor the solution and effectively the pricing around those. But to get in and start using it, we try to keep that bar very, very low.
And in conclusion, I also want to say, I think I heard you say that you're taking into account the fact that a lot of small practices in particular are hurting right now financially. And it's hard for them, even though this would be the ideal time in many ways to deploy the technology because the staff has time to do this for all the wrong reasons, but unless it is true they've got time, if they reach out to you guys and maybe consider a payment model that might be reflective of the fact that they're in trouble right now.
Yes, the reason I'm here, the reason we're having these conversations is because of the challenge that we're going through as a community, and so we wholeheartedly understand that, and we want to be here to help everybody get to the other side of this. Remember, one of the things that we talked about is you may have downtime. You may even not have as many resources that you had before. So the value behind this platform is to automate all the manual things that you're doing. The automated workflows that we provide fundamentally address a lot of the resourcing issues.
Sai, thank you very much. I am delighted to have had you on the show. You've definitely expressed what many people need to understand. There are tools available beyond virtual visits that we can deploy to help us manage the COVID-19 challenges that are addressed and actually manage them and address and just solve them actually in many ways. So thank you again.
Thank you. Appreciate your time.
To learn more about what we're doing at DOCSF, the Digital Orthopedics Conference San Francisco, I refer you to our website, www.docsf.health, docsf.health. And with this, I'm going to turn the schedule over to my co-host, Shauna, who is over in the other room with Jamie Edwards from Cloudbreak. I think you'll really enjoy that session. We'll hear more about platforms and writ large, big platforms. And with that, I'm going to call the broadcast to an end. Thank you very much, Sai.
Thank you.
Bye now.
Bye.
Hi there. I'm Shauna Butler. I am the host of welcome. I mean, it's COVID-19, the orthopedic response. This is being produced in partnership with DOCSF, the DOCSF team, who has a fantastic conference that we produce every year in January. And our partners in that are UCSF. We're excited this year for this program to be joined by the American Academy of Surgeons. And they've really worked with us to be a global convener to address and rapidly respond to this dramatic change that we've seen within healthcare, that we've seen for our patients, for our communities. And we're really grateful to have a global audience help us think through how do we reimagine and reinvent in real time orthopedic care. So today, I'm really excited to have Jamie Edwards join us. And Jamie is this, he's on a mission to humanize healthcare. And the way he's been doing this is approaching telehealth as really, truly a way to democratize health and to remove the disparities. I first met and fell in love with Jamie, I have to be honest, fell in love with him with his focus on addressing the language barriers, the language needs. So many of us have been in a situation where we're taking care of somebody that the language that they are comfortable with and that they know is not the same one of the care team. And we all know how frustrating that is, even in your own language, when you can't communicate your needs and you can't communicate as a health professional to understand what's going on and how we can actually help. So Jamie, you have a lot of experience in this, and you've been working with thousands of institutions. And can you give me the volume of contacts and interactions that you've had through a telehealth platform?
Yeah, absolutely. Shauna, you keyed in on something really, really important, which is that communication is really the number one diagnostic tool that a provider has, but more importantly, the number one empowerment tool that a patient has. And so that's been a really core part of the mission here. And right now we're delivering that mission at over 1,200 hospitals, over 85,000 times a month on over 10,000 video endpoints nationwide. I think we're in 44 plus states right now.
I want you to, that was a lot of numbers. Can you say those again I mean, that's huge.
Absolutely. So 85,000 encounters a month, 1,200 hospitals nationwide, plus federally qualified healthcare clinics and urgent care centers.
So you're touching a lot of people.
Yeah. I mean, it's pretty amazing. You go and you stand in the middle of our language center and you hear the people being helped every day in, 50 plus languages in video, 250 in audio. And it's, you sit there and that's what gets me going. Whenever I need that little piece of rejuvenation, I just hop into one of the call centers and, perk myself up, if you will, knowing that those folks are on the front lines of care.
And when you said languages, let's talk about what those languages are.
Yeah, the languages, the top languages right now spoken across the United States, we have Spanish, Arabic, Cantonese, Mandarin, American Sign Language is obviously one that's critically delivered over the platform, Russian, and then you've got, languages from the folks that we serve in Hawaii, the Marshall Islanders type of languages. I mean, it really runs the gamut.
Well, I have been aware of the language barriers as a clinician from the standpoint of when I was working at Georgetown University Hospital. And so in DC, you have people come in and, oftentimes when I think people hear about what Cloudbreak Health is doing, they think about languages. Oh, I'm working with people who are in Italy, or I'm working with people. No, actually, the hospitals that I've worked in, we have to service people in 40 different languages.
That's right.
And for the last year and a half or so, I've been living in the Netherlands. I became keenly aware of, let me put it this way, I have been humbled. That's probably a better way to put it. And very mindful of how difficult it is when you can't get people to understand you, and also how difficult it is when you're trying to help people and you don't understand them.
Yeah, so, Shauna, right? Like you think about a hospital, it's scary enough when you speak English and your doctor's talking to you about.
And then they come in with the medical lingo.
Myocardial infarction and, all these different types of things. And you're like, whoa. So imagine being in an ER. Yeah. You don't speak the language and people are rushing around, putting in lines, doing whatever it is, and you can't communicate with them. It's absolutely terrifying. And by the way, it's scary for the doctor and the nurse as well. You're sitting there trying to take care of someone and you care about this patient. You're trying to do the right thing, but they can't communicate with you to tell you where it hurts and what the issue is. Yeah. And so that causes a lot of anxiety.
And many of these words, sometimes you can pick up and they sound a little bit similar. But my favorite example of, do you know what the word nurse is in Dutch?
No, I don't.
I'm going to butcher it, but I'll give it a shot. Verpleegkunde.
Okay.
Doesn't
sound like nurse to me.
Yeah, I wouldn't have gone there with nurse. So anyway, you've got a great presentation because to help us from the standpoint of this dramatic change that we have seen with COVID-19. And in the orthopedic space, we're having to reinvent this all at once. And communication is key, and being able to use these new tools. So let me have you go through your presentation, and
great.
Let's hear what you've got.
Yeah, so thanks to everyone who's watching right now. It's very honored to be a part of what DOCSF is trying to do here, which is bring people together in a time of need and help solve problems for everyone. And I think this is exactly the type of thing that we should be doing. So I'm here today to talk to you about telemedicine in the time of COVID-19. It's kind of like love in the time of cholera, but this is a critically important thing that we're doing, and telemedicine has clearly taken a center stage. So the interesting thing to note is the market was evolving pre-COVID-19. Our place-space relationship with our medical providers was already changing. The four walls of the hospital was breaking down. People were focusing more on value than they were on fee for service. And this shift was underway, but it was happening slowly. Healthcare is intrinsically a risk-averse environment, and there's a lot of revenue at stake for hospitals, et cetera, and the system itself. And so that change sometimes takes a little bit more time. And if COVID has taught us anything, it's that there's a catalyst to this innovation now that's really, really underway and affecting a lot of change very, very rapidly. And so, we're dealing with our hospitals all across the country right now on helping them solve what's in front of them and being very tactical, understanding that the tactical decisions we make now are going to have long-term benefits as we make this move from a digital transformation in healthcare from analog to digital. So I think the other important thing to note just at the bottom of the slide here is as patients become more engaged, on-demand healthcare is becoming an expectation. We're used to getting our food in real time. We're used to getting our audio and our entertainment and everything else on demand. Healthcare now is no different. So just to level set everyone, I've structured the presentation so that I'm going to kind of stay at 30 or 40,000 feet, but there will be instances when I dive down to provide some very, very tactical advice. But what is telemedicine? So telemedicine is the remote diagnosis and treatment of patients by means of communications technology. And there's a broad variety of those technologies that people use. And we will make sure to go over those technologies and show you what they all are. But one of the amazing things about it is really one of the benefits, allowing a clinician to practice and or a patient to be treated anytime, any place, and on any device. That is really what is going to make telemedicine work well, is again, this shift of the place-space relationship, but furthermore, the convenience, the satisfaction, and all of the benefits that it provides, or the externalities that come from using telemedicine. And we're going to go over those in just a little bit. So I always get a kick out of this slide because we have a doctor seeing a patient over telemedicine, and at least the Jetsons thought that he was, needed the mask. And the great thing about telemedicine, and one of the things we can talk about is, there's a huge need right now for masks, PPE, and those things. So this became particularly relevant for this presentation. But those masks can actually be saved using telemedicine. And we have a use case that we've launched as a business that I'll go in later around telequarantine that actually protects frontline healthcare workers, reduces the use of PPE, so that we can keep those very, very scarce and important resources available for when they're needed. The other important thing just about this discussion is that telemedicine has been around for a long time, 30 or 40 years. Our first instance of telemedicine was picking the phone and calling our doctor. And then we started using email. But now with video and audio, and I'm going to go over the different types of telemedicine in just a second, we can deploy solutions to patients where they are and see them on their terms. So what happened? Along comes coronavirus. And with coronavirus, one of the things that really happened was the catalyzation of this digital transformation that we're going through right now. So first off, we had social distancing, and social distancing mandated that we really not be within 6 feet of each other. And while you can still communicate within 6 feet, in a clinical environment, it means something totally different. And clinical environments really aren't using social distancing, they're using what we're calling clinical distancing. And you can clinical distance by having telemedicine in a room and doing as much as you can for that patient remotely, without being in their proximity and subjecting, our frontline healthcare workers to risk of infection. And then we had shelter in place. And what shelter in place really drove in the healthcare system was people not going to the hospital. And so how do we see patients when they're not in the hospital? Telemedicine is obviously the perfect tool to do that, solving a real problem. And if you take a look at folks like American Well and other big providers of telemedicine networks in this country, their volumes have leaped 4 to 5 times over where they were before. We were talking to the team over at Ascension, and Ascension is doing thousands and thousands of teleconsults a day. And the team over there has done amazing work in onboarding thousands and thousands of physicians to see those patients. So there's a lot of change happening in a very short amount of time, and it's all triggered by what's happening with COVID, especially things like this. And we've all seen the memes as they go online. How do we protect those frontline healthcare workers? And this message of staying home, there are pros and cons to it. And one of the things that we're trying to look at right now is let's listen to the clinical advice of our leaders, which is stay at home. Most COVID cases are mild or moderate. So let's save those hospital resources for the people who have more of the moderate to severe cases that require physician intervention and ICU intervention. And so this messaging has really started to take hold with patients, and we realize that patients are listening because hospital volumes are actually going down as it currently stands. And the part of the hospital that's truly overwhelmed is the emergency department for these COVID patients and then the ICUs. But the other med surg part of it has all been shut down. There's no elective surgeries happening in hospitals today. All of that pre-surgery and post-surgery and all the thing that was happening before, it's simply not, all that stuff has been pushed off. And we worry about the patients who need chemotherapy and how we're going to deliver on that. And all of these, again, externalities that might happen from people saying, well, I need to stay home and I can't go out. But what about these patients that really need care? So telemedicine as an industry has been evolving. Initially, telemedicine 1.0 and 2.0 were really proving out use cases, especially in the B2C market. The B2B telemedicine market is very vibrant. I'll go into that in just a little bit, but uses like telestroke and telepsychiatry are being used nationwide every single day to save lives. But back then, hospitals were making very independent telemedicine decisions on their platforms. So they'd go out and they'd acquire technology through grants. They'd apply it to one specific use case, and no one was really thinking platform. Well, today in 2020, which we kind of ascribe to be this, the year of clarity, right? We're going to use the eye analogy on 2020 vision on what we can do here. People are moving to platforms and away from single use case solutions. And you want a platform because you can take and everything that a healthcare system has to offer and put it on a platform and bring that to bear and surround a patient with their care continuum. So that is the direction that things are going. It's telemedicine integrated as a routine part of care for the thousands of specialties that exist. So what does that landscape really look like? Well, there's different types of telemedicine, and this chart for me really sums up the whole market. You have asynchronous telemedicine, which is allowing people to time shift care the same way a DVR time shifts how you consume content online. You can take a picture of a mole and send that mole via text or email. You can, in a B2B environment, this would be the sharing of films by radiology groups for subspecialty reads. That's the asynchronous B2B aspect of this. On the synchronous side, it's real-time audio, real-time video. On the asynchronous side, it's AI and chatbots and things of that nature. So there's a lot of opportunity in a lot of different modalities out there, which I'll talk to in a second. The B2B market in our country, again, very vibrant. Specialists have been using specialty consults for a long time to serve underserved communities who weren't able to get that neurologist, who weren't able to get that psychiatrist to work at hospital A or live in that community. And so as a result, what do? You beam them in over telemedicine. And so that's been in use for a long time. There are a lot of companies that have built significant businesses serving that. And again, one of those things is language interpreters. It's what we do, in our service. And so we beam those certified medical interpreters to the point of care, and that's a great B2B use case. The B2C market is the one right now that is undergoing by far the highest volume increases and the most change. And again, that is very COVID driven. So in terms of modalities and tech stack, telemedicine is made up of a lot of different things. In our minds, we classically think about it as a telephone call or an audio visit, but it's actually made up of chat, AI, email, audio, video, image, and data sharing. And around that, you just can't have that video meeting room that we think about with GoToMeeting or WebEx. It's got to be something more. You've got to build a workflow around it, and you've got to make sure that telemedicine fits the workflow of how a clinician practices and how a patient wants to use it. So over and beyond that, there's things like remote patient monitoring as well that allows us to do things that were never conceivable before prior to this, including doing pulse ox and almost ICU level type of monitoring in a patient's home.
Jamie, on that point, I think it's interesting. You mentioned remote monitoring, and I think that we've thought of these two things as separate activities. And really, this is an integration where the monitoring then feeds into. So the workflow, I mean, I think what you're describing has been, we've had a workflow that says we might do a virtual visit. And then we've had a workflow that is, let's remote monitor. This is where we need to have an integration of the remote monitoring and the virtual check-ins.
Absolutely. And like one thing leads to the other, right? If we're doing our job right, and we're talking to a partner right now who wants to roll out a strategy where they can basically do almost like ICU observation at home, and use that to trigger a telemedicine call if a patient's, if the patient's data reaches a certain level and crosses a certain threshold, it triggers that telemedicine visit. So those are the types of things that you can do. And yeah, the walls are breaking down not only amongst all these modalities, and we're combining these solutions into the daily practice of how doctors are providing care, but the walls are breaking down between physicians, between hospitals, and everything is now kind of gray area, where before we would say, well, no, so-and-so can't do this because of XYZ reason. We're saying, no, they actually can. And we could have a care team that we set up around a specific patient's comorbidities. So you might have a patient that has COVID, congestive heart failure, and diabetes, and that requires a certain skill and a certain team to be able to service that patient. And we can now set up those care teams remotely. And it might be a dietitian from NYU and a pediatrician from Children's Hospital of Orange County, all surrounding this patient who has a specific set of issues. But now you've got the best people in the country who can help treat that patient with the right knowledge and the right skill set at the right time. So what does it take to make telemedicine successful? From our experience, it's all about keeping it really, really simple. The UI UX, very Steve Jobs approach from our standpoint. Use what people already know and keep it simple. Allow them to push a button and get the resource that they need. While single specialty platforms are good, multi-specialty platforms are better. And the reason is a patient and a provider don't need to learn multiple systems in order to be successful. They can log into one app and they can get, an ortho consult, and they can get, that urgent care consult that they need all in one place. And that's really, really important. The more apps we have on our phone, the less likely they are to get used and the worse our adoption rate. So the more we can centralize these services in one experience, the better off that we'll be. And the same goes for our physicians as well. If they can do multiple specialties, if they know that they can take that, late night call from a patient on the same platform that they're also providing that B2B telehealth consult on, they're going to adopt that more into their workflow. One of the other things that we've tried to do is you want things to be private labeled, but the amazing thing about telemedicine is what gets measured gets managed. It's an old Peter Drucker phrase in the management world, and that's important because telemedicine, you've got start time, end time of calls. You're logging the chief complaint. You can actually do facial sentiment analysis on the provider and the patient to see how they're feeling at any point in time. And Shauna knows this better than anyone else from her exponential medicine, kind of background. There are real things that we can do to have the technology measure things, including having AI go and do a lot of this filtering around the different statistics that we're all tracking, and have it provide value to the physician as a clinical decision support tool. So, our goal is keep things simple, but what gets measured gets managed. Make sure you're tracking all the right data that you need to. Any device, anywhere, anytime is critically important now. We're in a world of bring your own device environments. And as opposed to us going out and pursuing proprietary software, we have decided that the iPad can do a lot of this heavy lifting for us. And it's, again, already a tool, the iPhone, the iPad, your Android device, already a tool that people are familiar with and know how to use. So we're seeing platforms move in that direction. And as opposed to coming out with proprietary closed-end platforms, we're seeing open-end platforms where really what we're trying to do is increase access to care. And we're all now walking around with supercomputers on our hips with these smartphones, which wasn't possible before, but now we can. And that smartphone can do a ton, and I'm going to show you some examples of what it can do a little bit later in the deck.
Jamie, while you were just on there, I was just going to comment that one of the reasons why this part is so important is that we oftentimes focus on the practice and the clinician setting this up and forgetting that on the other side, we have to make sure that we can't ask a group of individuals or patients to make sure that they've got this particular device. So
Correct.
Are you Apple? Are you Android? Are you wearing it on your wrist? Are you looking at on a screen, on a laptop? So this part of the any device, anywhere, anytime is critical for the adoption rate for our end users, our patients, our beneficiaries.
Absolutely. And one of the things, it presents a real UI UX challenge, right, Shauna, to be able to make sure that you are viewable on every screen. But those are the types of things that telemedicine platforms are currently trying to address. It's not about putting up limits and saying, this is how you have to interact with us.
Right.
It's now companies saying, we're going to go to the patient where they are and interact with them on their terms.
Yeah.
Agreed. So again, workflow here is critically important. You don't want to be using a platform that forces you into a certain workflow. You want a platform that molds to yours, because as doctors, we really don't want to, you don't want to be commoditized. And so you want to be with a platform that actually supports your ability to practice the way that you practice, because that's what differentiates you from all other providers. And so having it happen in your brand and look and feel so that patients are familiar with it, having the workflow match what you do and what you think differentiates you. Again, critical part of the process. What you see here are two different companies with two very different workflows, but you can see that it's very easy to walk through them, and there's a step-by-step process. So there are certain things from a workflow standpoint that can be managed, but different use cases can be managed on one infrastructure, just with different workflows and different looks and feels. So what can you do with telemedicine? This is kind of the cool part where I highlight some people who I think are doing great things in the space. If you take a look at a company like CaptureProof, which is a company that's built a core competency in differentiating themselves on a computer vision standpoint and in asynchronous telemed, and as well, big player in the in the orthopedic space. These are the types of things that you can do, and hopefully the motion's coming through pretty clear on screen. But you can do range of motion analysis. You can do wound care. You can do all sorts of different things using AI and computer vision, just using your smartphone, and then putting that information in the cloud and letting the cloud do the heavy computing. So CaptureProof has been very, very successful in building out these types of asynchronous use cases, and they have multiple computer vision types of applications. You've got a company like PureWell, who is talking about prehab and getting people in better shape prior to surgery and walking people through a bunch of different protocols that prepare them to actually have a better outcome on the other side. So this type of prehab and rehab now being done via smartphone. And then companies like Buddy Healthcare who really navigate the entire surgery life cycle. But it's pretty incredible. And I think when I take a look at this computer range of motion analysis, or things like being able to do gait analysis and shoulder symmetry and track those things, I mean, it is a brave new world in terms of what the technology can do to help us treat patients remotely where they're most satisfied, where they feel safest, and save them travel time and all sorts of different things. The other thing, again, previously uncharted data. Telemedicine will give you the ability to track more data than you've ever tracked before, and now we can layer AI over conversations to track the metadata from that and do a lot more than we've ever been able to do before. Again, very, very exciting times from that prospect.
So quick thought on the data that you mentioned.
Yeah.
I think we run the risk of we get a lot of data, we can be drowning in it. So
Correct.
How do we move from data to insights to actionable insights so that because I do hear a lot of clinicians say, oh my gosh, like I'm inundated with it. So can you speak to, just real quickly on that, because obviously previously uncharted data, like, okay, so how do we make sense out of it and use that to drive how we provide care?
This is a long time big data challenge, right, Sean? I mean, I think it's an incredible question, because when I was an investment banker early in my career, someone would show me a spreadsheet, my eyes would glaze over, because you're like, well, there's a lot of data here, but what am I looking at and what's important? Now with the technology, you can actually surface data that's important to that specific clinical decision, and that can drive the insight, right? And the AI can then help drive what that insight is by coming up with pre-filters over if patients' pulse ox reach X, do Y.
Right.
And so it's about filtering that data down to something that's actually consumable by a human, so that we're not just showing people, 1,000 data points on one page, but really getting it down to those critical 3 or 4 that they need to make that decision. So we're constantly working on our reporting tools to make sure that that's exactly what we're doing. It's about taking data, creating an insight, taking an action off that insight, and then going back to what gets measured gets managed, measuring it and creating this feedback loop that is continually making that decision better.
Yeah, and I was just going to say, from the standpoint of where I've seen this work really well, is when you have data that actually surfaces up not only who needs to be seen, but when they need to be seen and why they need to be seen.
Right.
So we become much more efficient in how we deploy the limited resources that we have to take care of a very wide, a broad swath. I mean, if you've just had somebody come home from surgery, like, where are they in their progress, and who needs to be spoken to today about what? And then it also allows us to target who needs to be doing the talking to them. So is this a surgeon call? Is this the nurse call? Is this the PT call? Is this pastoral care? It is really interesting how you can target what needs to be done and by whom.
Yeah, and also to whom, right? So a lot of times we direct.
Yeah, is it the caregiver? Is it the patient? Is it the adult parent? The adult child?
Yeah. Why are we giving discharge instructions to a patient that just had heart surgery when they're not the one who's going to be performing anything post-care? It's going to be that caregiver. So being able to come up with telemedicine support for that caregiver and show them recorded videos of those discharge instructions so they can go back and revisit them. Because let's be honest, I'm talking fast now, but doctors sometimes are ready to move on to that next patient. So we give those discharge instructions, or the nurse does. It's like, great, you understand? And the patient's like, yeah, sure,
like
I do.
You're caught in the headlights. Sure.
Sure, I do. And then they get home and they're like, oh, I don't remember what the doctor said about X, Y, and Z. So telemedicine, again, can help provide that support infrastructure, that caregiver needs to be successful. So, but an incredibly important point to whittle this data down to what's important. All right, so what is telemedicine? I mean, we refer to it as simply the new medicine. Again, I have a digital transformation slide coming up, but this is just the digital transformation of healthcare accelerated right now under COVID. And I think the interesting thing is there are so many benefits. You can, it's going to be integrated into how each specialty practices. It's cost effective, it's collaborative, it can be, it can shift to the changing demands of healthcare. It's measurable, it's simple and scalable. All these things are really going to support telemedicine, hopefully not being called telemedicine anymore and just be called, hey, it's medicine, but can we set up a video call?
Well, you make that point, but I keep asking people, when do we refer to it as teletravel, telebanking? So we don't, we're still in that telehealth. So we don't, it's just going to be health. And this is an integrated part of how the care continuum looks like, the patient journey, the provider journey.
Yeah, absolutely. And it's pretty amazing, right? We're starting to get so much better at design than we've ever been before. And you talked about those journeys, Shauna. Those were things that we really didn't think about. It was like, hey, we have this cool tech. How do we get it into people's hands? As opposed to being like, you know what? How do people actually do this? And how can we make the tech support what is that journey? And that's the mentality that a lot of companies have now is, look, we need to support the patient journey. We need to support the physician journey. And we're going to do that through design thinking. And we're going to, right?
Yeah, when you bring that up, I think another point is, you bring them out as discrete streams of activity. And at this point, with this collaboration tool, it doesn't need to be the nurse journey, the physical therapy, the surgeon journey, the outpatient experience. We can actually have a journey that is a coordinated care, where care coordination has been one of our biggest challenges. So this is a place where, this opportunity that we have, this moment where things have been thrust upon us and we've been forced to change, we actually get to redesign how we might like that system to work, learning from all the things where there were challenges, where there were deficits.
Yeah, and to that point, we've heard a lot of people, Shauna, talking about the fact that, the system needs to be more patient-centric, right? I hear patient centricity a lot. Patient centricity is really important, but so is provider centricity. So is X-ray tech centricity. So is, we need to treat these as one ecosystem as opposed to your point, different experiences. And I think those walls are really breaking down. We're starting to take a look at what is a holistic healthcare journey and what that means from the different stakeholders within it. And that is a much healthier approach to how things are currently getting done. So couldn't agree with you more. And there's so much waste in the system that something like telemedicine can help solve. How much time do we spend waiting in
parking. You show this big thing up here, and I'm thinking about how much time people spend trying to get to and from the parking lot. So
yeah, parking, to and from, waiting rooms. In business school, they taught us that that's inventory, and that inventory is really waste and inefficiency. So I'm not going to talk about a human
unless,
being
of course,
that way
you need
per
a
se.
stockpile of face masks. At which point,
right. This brings up.
It's not an either or. It's a both.
Right. And Shawnee, it's really interesting. So if you take a look at kind of what's happening in the country right now, like one guy's view is that we had this whole country set up on just-in-time inventory, and we thought that was the most efficient way to do it. And while we go through exercises at all of our healthcare facilities about how to prepare for a pandemic, no one ever thought it would be like this, right? Like, we don't know what we don't know. And I'm betting what we're going to see in the future is people's par values on ventilators and masks and gowns and visors all changing, and there will be stockpiles of this stuff around the country for the next time. So interesting things happening there.
So we have a lot of audience questions. Are we good to, have you shared what you wanted to share in the presentation so that I can grab some of these questions from the audience?
Yeah, you know what? Give me 2 more minutes to fly through some of these slides, and then
You're going to need to fly. So
I will fly. So one, telemedicine was already here. There are closed systems out there like Kaiser that were already doing north of 50% of their telemedicine consults, of their visits in telemedicine. That's an important point. People said that there were going to be a lot of challenges. How do we bill for it? People aren't that tech savvy. There's a lot of legal and regulatory issues. Well, clearly COVID has knocked that all out of the water. And the preferences side of it, like healthcare really preferenced the in-person visit, right? We put a lot of weight on that. And now we're putting a lot of weight on the telemedicine visit. So while that water was choppy, it can be navigated. And now this is about how you implement practical programs. And a lot of it, Shauna, rests on human behavior. It's not about the technology. Yeah. Right? It's about human behavior and our willingness to change that behavior. And I think COVID's provided a pretty incredible catalyst to that. And from a technology standpoint, let's not go for the sizzle. Let's go for things that are practical, because that's what's really going to be adopted quickly and be very intuitive for folks. Research has shown, and this just to your point, Shauna, before, research has shown that this is really effective. One, people tend to be more honest with some physical distance. They're not there's no fear of being judged when you're in the room with the doctor.
Or shame
about an STD or erectile dysfunction, whatever it might be. Like Roman has proven and built over $100 million business on the fact that there are some things we don't like to talk about in person, and that we're actually more honest with some sort of physical distance. And that distance doesn't need to be social distance. It can just be physical distance.
Yeah.
Patient satisfaction is equal to in-person care. Travel savings, the VA did this study on the fact that they saved 3.5% of their budget by not having to reimburse for travel savings, and so much more. So the research supports that telemedicine is a very effective way. We need to be thinking about return on these investments. And right now, by the way, we're offering our platform for free to market. So ROI isn't kind of a thought process.
It never gets any better than that price.
That's right. Nothing gets better than free. So
unless you want to pay me to use it,
Well, yeah, there you go. We're doing this type of stuff because it's the right thing to do, and the contribution to helping flatten the curve here is critically important. But we need supply chain.
Humanize healthcare.
There you go. But what we really need people to do is to ensure that hospitals are thinking about things in the right way, and not just thinking about cost savings, but thinking about value creation. So that's an important thing when it drives ROI. And these are how people need to be thinking about it. There are 3 main vectors in a hospital: efficiency, quality, and customer service. And you can go down and see what increased patient flow, less waste, and greater efficiency, better outcomes, mitigating risk, improving quality, creating raving fans of the healthcare system, and the fact that healthcare can be fun. I'll say it, telemedicine platforms can be fun to use. And when you make something fun and engaging, people are going to use it more. So a lot of benefits here to calculating what ROI is. And I'm happy to offline answer any more of these questions that might be about how you really construct a good ROI for your telemedicine platform. So what's the opportunity? It's to lower costs for patient, provider, and hospital. It's to match cost to acuity and eliminate waste. It's about providing the right care at the right time. Specifically with COVID, it's about reducing healthcare disparities, saving PP&E. And the one thing that's just environmentally people don't talk about is the fact that we can lower a lot of our carbon footprint in healthcare and decrease this $3.2 trillion of GDP that we spend on lowering and using telemedicine and everything that comes from using it. So COVID use cases have been on the rise. This is just an important piece to just understand how people are using telemedicine in a COVID world. One, telequarantine. So doing clinical distancing of our providers actually in hospital. It's not just about staying at home. It's about people not having to go into that COVID patient's room and treat them, and mitigating the number of people that need to do that from a care team standpoint. It's home virtual visits, it's tele-ICU, it's infectious disease specialty. But one of the things that people haven't really taken into account is these COVID patients are isolated. And can we do televisitation with their family members to make them feel more connected? These are the important things when it comes to humanizing healthcare that are key. So digital transformation is underway. There's a lot of exponential technologies that are out there that people really consider revolutionary that could be implemented right now, but right now people are really focused on what's revolutionary from an evolutionary standpoint. And a lot of these simple technologies that we already know how to use can be set up so that we can actually create revolutionary outcomes on the evolutionary tech. All right. How was that, Shauna?
Well, to your point, from the standpoint of, is this fun doing it in a telephonic way or in a video way? I'm having a great time. What about you?
I'm loving this. I'm loving this. Yeah. And by the way, I know we're on a time limit, but I could do this for hours.
Oh, I was gonna say, and you're good at it. And I think that this is another skill that we are learning, how to be present. So when you were talking about, we need to be physically distant, but virtually connected. We say, we're saying stay home, but let's say stay home and stay connected. And these are great tools and technologies. There's one question in particular that there's a lot of questions on. How does an orthopedic surgeon accomplish a legitimate physical exam on telemedicine? They want to know the tips and tricks. And before you answer that, I know Stefano has been talking about how he's been doing that with his clinic. So I'm going to invite Stefano to make sure that he puts something in the chat box to answer that. As the orthopedic surgeon, let's hear it from the telemedicine platform person, the guru who's humanizing healthcare that way. And then I want to hear from the surgeon. What he's been learning as far as how do you do those legitimate physical exams. And you've got 2 minutes to do it, and then we need to say goodbye.
Okay. So legitimate physical exams, there are a bunch of tools out there, whether they're from Massimo or a company like Capture Proof, that can help show you, again, degree inflection. You can take vitals remotely. There's a lot of different things that can be done. And Stefano, doing this for a living is going to give you probably some of the best answers. So I'd keep an eye on that chat. But, you can actually see an eye dilation over telemedicine. You can actually instruct the patient on what to do and say, could you touch does this hurt when you touch, your rib here? And so a lot of it is learning how to better communicate when you're not the one doing the work, when you need to have someone else in the room do the work. And in B2B, that's true too.
Surgeons and their communication skills?
Yeah. It's a new skill set that we all need to build. It's Shauna, you're the nurse in the room. Would you mind palpating here? Or if you're at home, patient, would you mind just apply a little pressure here? How does that feel? It's learning a new skill set that is communication driven. Yeah. And so that physical exam is still physical, but it's just not your hands. It takes some training and some experience.
Great. Well, this has been so much fun, but we were trying to be really helpful, and I feel like we've been really helpful. Jamie, Cloudbreak Health is just a great global citizen. So thank you for all of the work that you do. And you've got, I know it's not just Jamie, you've got a remarkable team, and I have such great love for so many of them. You're out in Los Angeles. You guys are starting to ramp up.
Yep.
Stay safe, hand washing, get extra hour of sleep, be good.
I will do that. I just want to remind everyone, don't give up the ship, right?
No,
this is not the time.
We got this.
We're going to navigate this. This is going to be big. Anyway. And thank you everyone for being on and listening. And if anyone wants to reach out to me out of band, feel free.
Okay. Well, thank you guys. I'm your host, Shauna Butler, and I'm looking forward to having you join us in other sessions. We're so grateful to DOCSF, for UCSF, for the American Society of Orthopedic Surgeons, and all of their joining us and to convene such a fabulous audience and such great talent in helping us respond to and rise to the occasion and the challenge of COVID-19. All right. See you guys soon.
Bye, everybody. Thanks, DOCSF.
Hello and welcome to COVID-19, the Orthopedic Response. It's a production of DOCSF and UCSF, and I'm your host, Shauna Butler. And I am so pleased that the American Academy of Orthopedic Surgeons has joined us in being a global convener to help address and rapidly respond to the dramatic changes that we're all experiencing as healthcare providers, as patients, as communities in these interesting and challenging times. And so we're grateful to have a global audience joining us. And today I'm so thrilled to have Jamie Cayouette. He's an orthopedic surgeon. He practices at the Hoag Orthopaedic Institute, and you have a private practice, right, as well, in Newport Beach in California?
That's right, Shauna, Newport Orthopaedic Institute.
Great. And one of the reasons why we've invited you here is to really help us think about the changes that have happened in private practices. I mean, there's a lot of stuff going on with academic institutions and with great big huge hospital systems. But then we've also got this enormous segment of our healthcare that are private practices. And I think you've had to change pretty rapidly. Things are not quite what it was 3 weeks ago. And so what we've invited you today to do is to help us understand how you're responding and how the practice management is working in the private practice segment. So have you got a set of slides that you want to share with us?
I do. So let me click on those. Are you able to see those?
Not yet.
Okay.
We've got this great comment that people are, we have our own little art gallery here.
All right.
You let me know when you got it.
There it is. Got it. Are you able to see those?
Perfect.
Okay, good.
That's great. All right. So if you want to go ahead and get started with your presentation, love to hear what you've got for us.
Okay, great. Well, thank you, Shauna, and welcome from Southern California. And before I get started, I also want to thank Stefano and all of the team that have put this together and worked so hard to do this. It's been really a unifying event for all of us around the world and helped to create an even tighter sense of community. And so I'm really grateful for all of that. So let me go to my first slide. We're in a private practice, and for those of you around the world that are not familiar with that, we are essentially small business owners, and so we enjoy the benefits and the freedom of being a small business, but we also have the risks of being a small business. And at this time, we are dealing with those risks front and center. Right now, as with all businesses across the United States and around the world, we're facing a threat both to our personal health and our financial health as an industry and an organization and a small business. So we're having to adapt very quickly like everyone else around the world. It consists of about 30 physicians. We have over 150 employees. In part, we have more employees than a typical private practice because we also run a management services organization to manage other specialty practices. We have multiple offices. We are also owners in joint venture with our community hospital, Hoag Memorial Hospital, in Hoag Orthopaedic Institute. We, along with our other large groups like the OSI group and other small practices, are owners in Hoag Orthopaedic Institute. It's a 70-bed specialty hospital, and then we have multiple surgery centers as well. So if we look at the talk today, I tried to keep it very basic, and I'm going to cover these 4 topics, and obviously, Shauna, feel free to jump in and ask questions along the way if you'd like. But essentially what I want to focus on today is how you can continue to practice and serve your community and serve your patients in a safe manner, how you, as a surgeon, stop the bleeding, the financial bleeding that's going on in your small business, how you tread water during this time of change, and finally, how you prepare to start. So first off, I think our number one priority as physicians and in healthcare is to provide a safe environment for our patients. And so we have because of the shelter-in-place order in California that occurred on March 19th, we have reduced the number of office visits in our practice dramatically. Essentially, anything that is not urgent or emergent is not coming into the office, and the same is true. So our office visits are probably down by 75%, and our surgical volume is probably down by 90%. And so because of that, we are able to reduce the patient visits and spread people out and reduce the risk of infection. In our office, we have only one entry and exit for the building right now, and we have a checkpoint at that entry. We're doing is goes through a questionnaire with regard to their travel history and their health history, and we take their temperature, and then as long as their temperature is below 100.0, they can be admitted to the building. So we're trying very hard to protect everyone, both inside the building and our patients as well.
Hey,
We've really
go ahead. Yeah, when you're doing that, there's already whenever you go to a place and there's added layers of security, it makes people feel uncomfortable. And our healthcare environments are always meant to feel really safe. And so when we add these layers of things that might feel like you're not welcome until, or we're checking because we have high levels of fear, how are you guys doing this in a way that feels fun and friendly? I mean, when you go to Disney, they have security check lines. They're checking your bags, but somehow or another, they bring the magic into it. What are you guys doing to make that feel not so intimidating and elevate the fear factor?
I think that's a great question. And what we have tried to do is actually interject into the discussion when we see the patients at the front door that what we are trying to do is to keep everyone as safe as possible. We know that we're here to serve you and take care of you during this time for your broken bones or your infection, whatever it is. But we need to do it in a way that's safe. And our idea is that by providing that level of rigor at the front door, we actually are creating a calmer environment when you come inside the building, because everybody's going to feel safe that we're taking every step possible. So yes, it is an added step, but we're actually hoping that the psychological effect is that we demonstrate to the patients that we take this seriously. We're here to keep you safe.
Yeah. I'm thinking where we need to take a page out of the playbook is over in the children's hospitals, because they're so acutely aware of the anxiety, and they turn everything into a game. And so I think that's where we need to be. If we're looking for the masters at reducing anxiety, it's definitely over in the pediatric space.
Yeah, there's no doubt about that. And so I think that part of our job throughout this entire process is to be compassionate and to be aware that everyone is stressed, everyone's anxious, and our job is to help calm people.
Okay, sorry for the interruption, but thank you. I was going to say, when you're going through that was what was spinning around in my head.
Yeah, no problem. So let's see. I think the only other thing I want to mention is, in the hospital environment, we're very used to hand hygiene, gelling in before we go into a room, gelling out when we come out of a room. We have tried to instigate that same level of safety here. And so all of our medical assistants and staff are doing the same. And then with the exam room itself, we're actually teaching our staff, or have taught our staff, that we want to terminally clean the room, just like we do an operating room between surgeries. And so we wipe down every surface, every keyboard, the door handles, everything between patients. And we make sure that people coming in and out of the room are gelling or washing their hands every time they come in and out of the room. And that adaptation has occurred very quickly in our office. So in moving forward in terms of the business aspect, we've talked about how we're going to keep our patients safe and our staff safe. We need to keep our business safe as well, and that means keep it alive. And so it's important to understand that in private practice, we don't have, just like a small business, we don't have a large corporation or a health system behind us that's going to backstop us financially. It's just up to the physicians. And in a typical private practice in the United States in orthopedics, the office overhead runs somewhere between 40 and 50% for most practices. And so that means that you have a large expense burden on an ongoing basis. And the two major elements of your expense burden are your employees and your rent. And so what we did very quickly, our administrative staff focused on those two key elements right away in terms of the expense side of the equation. And we immediately contacted all of our landlords in the various offices that we have to look at either a freeze on rent for 90 days or a significant rent reduction. And we were fortunate to achieve all of that. At the same time, the more difficult part, I would say, is the human side of the employees. And that's a very challenging aspect for the physicians and the administrative staff to have to reduce the number of employees that are currently working with us. We chose as a group to furlough our staff rather than actually lay them off. And I think it's important for doctors who haven't come to this step yet to understand the difference. If you furlough your staff, you as an organization continue to pay their health benefits and their benefits. However, they are now able to apply for and collect unemployment. In California, that means that they should be able to collect approximately 60 cents on the dollar for what they were being paid. So it's not perfect by any means, but if we can maintain their health benefits during this time, and then the state can help to pick up a portion of their salary, we hope that that'll be enough to help see people through. In addition, our employees have a paid time off bank that they can use. And then there are rules around sick leave as well that you can look at drawing down some income from that. So there are several things that the Department of Labor has put in place. And at the end of my talk, I've got a nice link for people that'll give you a lot of information on the basics of that. From the revenue side of the equation, the first thing that we did was that we stopped for all the partners, all the physicians in the group. We are not going to be drawing a salary, a bonus, any sort of distribution for at least 2 months and possibly longer in an effort to preserve cash. Our administrative staff has also accepted a reduction in their pay, and they have withheld the payment of their bonuses for last year until we get back on track in terms of our finances. And we're doing all of this as a way to remain open and to be able to continue to serve our community and to keep a business that we can bring all of our employees back to when we get through all of this.
You know, Jamie, when you were mentioning this, I'm reminded of Simon Sinek's work about, you know, his book that he wrote, Leaders Eat Last. And we heard yesterday from some of our friends and colleagues in New York how important it is for leadership to be physically and visually present. And the way you've described this is not any one group of the team disproportionately impacted. It is a shared experience of we're coming together as a team to address this. And a couple of the practices that I've spoken with, some of the things that they've done is with their staff, they've really turned this inward to say, okay, all of those things that we never had time to do, as far as our internal work, our internal practices, how we think about our relationships with our vendors, our website presence, our compliance, that they've taken them from a clinical role and they've put them in more to an administrative role. Have you been looking at that, or how is that something that's working for you guys or you're considering?
Yeah, absolutely. That's actually a perfect segue to my next slide, where
we did not rehearse this. We're just
so we have gone through what I'll say the triage phase right now as a surgeon of trying to stem the bleeding and stabilize things by going through our first furlough, and that's a difficult thing. But then we need to keep doing things once we reach the next phase, which I'm calling treading water at this point. I had a couple of my boys played water polo, so I'm very familiar with that. But we need to keep the business going, and we need to come up with creative ways to do that during this time. So we, as you mentioned, Shauna, we have relative time on our hands right now that we didn't have previously. And so this is, for all of you who are in private practice, this is a great time to sit down and reflect on your business and your business model. And I think that we're seeing and you've had speakers earlier on today talking about telemedicine and telehealth. I think that this is going to be a permanent change in how we deliver care. We've been talking around this at the edges for years. I've been fortunate to be going up to DOCSF since inception and looking at all these technologies. And this has become a catalyst for us to adopt and adapt our practices to these technologies now and look at ways that we can start to change. So I would use the relative amount of time on our hands to make these changes right now, and to actually look into every single aspect of your practice and ask the question, how can you do this more efficiently? One of the things that Joe Bosco touched on yesterday from the Academy is that this is probably a moment where you're going to start to see some both horizontal and vertical consolidation across the healthcare delivery industry. In the private practice world, that likely means that practices that were previously possibly considering coming together will now have an impetus to do that and to come together. With
people
telehealth,
who are once competitors are now going to become collaborators.
Yes, exactly right. And I think we're all looking at if telehealth really becomes as profound as we think it will be, we will not need as much real estate as we currently have taken down. And that means that we can bring groups together and start to share some of the real estate footprint that we have in our companies. And so there are lots of opportunities in this crisis that we need to focus on. Obviously, we need to continue during this time of treading water to look at how we can reduce costs and reduce our burn rate as an organization. But we also need to be thinking forward, given that we have the time on our hands. And I think that one of the keys throughout this entire process is communicating. Obviously, that's what Stefano had in mind when he put this together, but we need to be communicating and committing ourselves to communicating both with our patients and our staff, and quite frankly, with others in the community that are also struggling. We're a resource as physicians for our community, and so we need to be looking at what can we be doing to help our hospitals and our clinics or in our community during this time. And I think that'll make everybody stronger as we move forward.
Well, to amplify that, we have heard there's not been a single presentation and beyond this conference that we're putting together where that theme of communication hasn't come up. And what's been very key is that not only who communicates, that's been a big piece. Who's doing the communicating? Is it a trusted source? Is it consistent and reliable? Is it instilling, is it honest? It might be like, we don't have the answer, but that's an honest answer. And so it is, communicating, being consistent, being reliable, and making sure that all those people who are communicating the same message. So I think that you would probably, what you've said, I'm wondering, is there something you've learned from that? Do you agree with that? Is there something you want to add to that?
I absolutely agree with that, Shauna. I think that we need to, and we've worked on this within our group, which is to make sure that we are communicating consistently. And so the way we have approached this, both in our group and then also at the hospital, I'm on the leadership side at the hospital, is to make sure that we have a single source of communication going out to the medical staff and to the all of the staff, the working staff, the nurses and medical assistants and everyone else. And that prior to that source of communication going out, we all huddle twice a week on the phone, and we talk through the various issues, both from a clinical standpoint in terms of We get our infectious disease expert on the phone, and we look at the trending data throughout Orange County and Southern California, and then within our hospitals. And we apply that trending data to our communique within our hospital. It also helps within our group, because one of the next things we need to be doing is looking at, based on the trending and where and when we flatten the curve, what does that mean in terms of starting back up operations?
And that's one of the comments and the questions that's coming up is thinking about as we reinitiate and re-engage. So it sounds like you're using this communication and this instant data to really inform an evolving situation.
That's right. Like I said, we have 2 standing calls every week that goes through the leadership, both on the hospital side and the clinic side, our Orthopaedic Institute. And in those calls, we have a variety of topics, but we are looking at real-time data. We take the data from the hospital from the midnight prior to our call, and that becomes the basis of our discussion and decision-making in terms of our planning. And so we're trying to be as current as possible with our information.
All right. I'll let you get back to your slides.
Not a problem. So again, you without a prompt, you gave me a perfect segue to my last topic.
That's what
here.
a good host is supposed to do.
Yeah, you did a great job. So that's, we talked just a moment ago about using this downtime to start thinking creatively and to really assess your business of your private practice and your how you're taking care of people in a clinical fashion. You need to start thinking about what you're going to do when you start back up. And I touched on this previously, but are you going to now practice the same way you did before? Or are you going to start to incorporate some of the technologies that you've heard about in this meeting? I was able to give a cameo appearance yesterday during the discussion by Todd Johnson on Health Loop. We've been using that, for example, extensively not only during this crisis, but during the last 5 years. And that's a great tool that you can incorporate that actually does reduce the phone and communication burden in your office. At the same time, telehealth is going to definitely reduce the number of office visits and streamline how we perform this. If Medicare maintains the changes that it is currently made to the payment model for telehealth, it is likely that the private insurers will have to follow that. So currently in our practice, we have all different types of payer models that we work with, both Medicare, private insurance, we work with full risk contracts, we work with HMO contracts. So we bundle payment, we do all the different stuff. And I anticipate that we're going to see some consolidation around the use of technology and the realization by the payers that everyone's better off if we can start to use these technologies. And in order to make that happen, we're going to have to see payers pay us the same way when we use telehealth as if we're having a physical visit, which CMS has now agreed to. And I think that's a great change that's been made. I think also you're going to need to look at your employees and whether or not they need to be on site. Currently, we've got a large portion of our staff that's working from home, and it gives you an opportunity to look at many of the different tasks that you use in your office and determine whether those tasks can be performed remotely and just as productively. Again, these are things that we've been doing for several years, but now it's really paying dividends to have staff that are working from home and able to continue to do so without missing a beat. And I think that we will incorporate that more and more in our practices across the United States as we go forward. So I think that we need to stay positive, not only for our staff and for ourselves, but for our patients as well. I think it's important to send that emotional message to them that we're here, we're going to help take care of you, things are going to be okay, we're going to come out the other end of this. Everyone asks the same question 50 times a day, which is when will this change? When will this be over? And the honest answer is the virus has its own timetable. We don't know the answer to that. We can watch the trends, and then we can start to change our practices to minimize the risk of infection. And that's what we're doing. So finally, I just wanted to encourage everyone to take a screenshot. These two, I've combed through quite a few different websites to look for the most concise and simple sites. The top site is one with regard to all of the various labor laws, looking at furlough versus layoff, paid time off, all of the laws. And I would make sure that you recognize that these are state dependent. They are not necessarily national. And so you need to look at what's going on in your individual state, and then you can go from there. And then the other resource is, I think, a very good resource with regard to the Small Business Association and the loan process that is out there for doctors that are in private practice. This applies to, and you heard about this yesterday from the Academy, this applies to groups that are smaller than 500. And so the vast majority of practices in the United States are smaller than 500 employees.
Yeah. And the Academy had a lot of really great resources and help on that. And that actually, there was a question in here from Lou Sean. He wanted to know if, and maybe you know something about this, is there an interest-free loan program that can be initiated to get your valuable staff through a personal cash crunch? I mean, you go ahead and answer, and I'll tell you what I've seen.
So with regard to the legislation that just occurred, the answer is I am not aware of an interest. There is a 6-month interest-free loan that you get from the Small Business Association if you qualify for the loan. And I can just kind of run through that loan very quickly if you'd like.
Yes, please.
That loan is a fixed rate, a 4% fixed rate loan. There's no prepayment penalty, and you get 6 months of interest only on that loan. Again, as I said previously, if you have fewer than 500 employees, you would be eligible for that. And the phrase that they are using to qualify is that your business has to be substantially affected by COVID-19. So you need to be able to put together the bullet points that demonstrate how you've had to change your business during this crisis in order to qualify for the loan.
I think that one simple sentence. We had to cancel all our elective surgeries.
Yeah, we're down 90% in terms of our surgical volume and 75% in terms of our clinic volume. So that pretty much says it in a nutshell.
I don't think that this is a hurdle that's going to be difficult for most of our orthopedic practices. Yeah.
No, I think I honestly feel everyone in private practice should be able to qualify for this loan. It's a 10-year loan. The amount of the loan is 2.5 times the average cost of your payroll that was over the past 12 months, up to $10 million. So the maximum amount of loan that you can take down is $10 million. You can use the loan for your payroll, for your employee salaries, mortgage, rent, utilities. And so this is I think the lion's share of what you're going to need it for in private practice. And then finally, a key element of this is the forgiveness. And they will allow up to 8 weeks of forgiveness on this loan in terms of the expenses, provided you can document the expenses for an 8-week period. So you may be able to have that portion of the loan forgiven altogether, which is amazing and very needed at this point in time for all the small businesses across the United States, not just private practice in medicine.
Right. You know, and one of the things that you'd mentioned about the time frame, because operating in a situation, I don't know if you're familiar with the phrase a VUCA environment. It's a military term, VUCA, volatility, uncertainty, complexity, and ambiguity. The military used that an awful lot when, post 9/11 to be able to try to address that. And actually, when we think about a VUCA environment, one of my former professors he was talking about it, and he said, VUCA, as a leader, we need to think about this as vision, understanding, clarity, and accountability. And I actually, I'm thinking about that as really as agility. We need to be able to be very agile in all of this. So, there's the VUCA environment, which we are clearly in, but as leaders, how do we apply the vision and the clarity and the accountability? And I think another C could be confidence. And when we talk about, we're on the timeline of the virus, but as individuals, we have a lot of say and a lot of actions that we can take. I mean, we just start out with the personal hand hygiene, the physical distancing. And in the physical distancing, we need to have that message of staying in communication and connected through the tools that we have. And I think, your description of how do we create the calm, not only for our patients, but also for our staff and our teams, and knowing that we've been through hard things before. We have.
Right. Yeah, I think those are great points. I think as physician leaders across the United States, projecting calm is something that is critical. And again, as surgeons, this is something that ideally you do in the operating room under stressful circumstances.
You're masters. Masters at projecting calm.
I think that many of us have had practice in this over the years, where you'll be in the middle of an operation and something will happen that is unanticipated and potentially life-threatening for the patient. And the worst thing you can do as a surgeon is to start screaming and running around the operating room. The best thing you can do for your team.
Can I have you say that again, just so that all of the staff who work with surgeons, to remind us again what
I will guarantee that there are some surgeons who scream and run around the operating room, but I will tell you that the best in those situations are the surgeons that can literally put a lap into the wound, hold their hand on the bleeding vessel, and take a deep breath, and just count to 3, take a deep breath, calm yourself, and then start to deal with the situation at hand. And so I think we have to do the same thing here. And that's why, quite frankly, in my slides, I kind of went at it like a triage surgeon, where you need to take that deep breath, hold your hand on the bleeding vessel, and recognize that things are only going to get worse if you panic as the surgeon. Things are going to get better if you stay calm. You're going to project calm to your team. Everybody's going to work better in a triage situation. And so I think throughout the office, we need to be doing the same. We need to be demonstrating that it's going to be okay. And that's part of our job as physicians, is to be able to calm people.
I was just going to say, in my ED and trauma experience, it's always take your own pulse first, take a deep breath, and then you can help others be calm. So we need to wrap this up. There's one question that I think is an important one to answer as we come out on the other side of this, and we are, and in part because of leaders like you, Jamie. I really appreciate you're helping us walk through very detailed steps on this, because that's what we need. Is high concept is really great, and in this moment we need the details. That's where all of this lies. Right. So what challenges are you anticipating in meeting the pent-up demand, so that as we think about re-engaging and bringing things back to I won't say, a lot of people are using the word the new normal, but let's think about the new optimal. When we're back up and running, and there are a lot of people who have not been seen, who need to be seen, what steps do you see in reinitiation to mitigate some of the challenges where people have been waiting a long period of time?
So it's interesting. You should once again ask the right question. We had a meeting about that this morning, actually, and we talked about the startup and what would be involved in that in terms of pent-up demand. We feel that it's important from our practice standpoint that the office look at, we have always had expanded office hours, evening hours, and things like that. I think we're going to look at formally going to 2 separate shifts, and starting early in the morning going later into the evening. If we are able to use telehealth effectively, that should free up a lot of our medical staff in order to accommodate and populate 2 separate shifts. In terms of our surgical volume, we have already been preparing the staff, even the staff that has been furloughed, for the fact that we will be coming back, and when we do, be ready for working 6 and 7 days a week and long hours. And so what we're trying to do is to send 2 separate messages. The first message, obviously, is to give people hope and say, we are coming back and you better be ready. I mean, I think that sends a fundamentally positive message to the staff when we do that. And then the second message is, enjoy the time you have right now.
Rest up, because we're going
right.
to be in a sprint marathon when we get going again.
When we get started, we don't want to hear anybody complaining at that point about how tired they are. We're all going to be working hard, and we're going to make up for the time that we've had right now.
So, well, this has been just fantastic. And again, I want to thank all of our very engaged audience for joining us here at COVID-19, the Orthopaedic Response. And I want to thank the American Academy of Surgeons who have been joining us in convening this global set of problem solvers and solution finders. And thank you for being a lead in all of that, Jamie. And stay safe, wash your hands,
Thanks.
Get extra rest, and be
Right.
the leader that we need. Thanks so much.
Thank you, Shauna.
Bye-bye.
Thanks so much. All right. Bye-bye.
Five,
It's loading.
4, 3. Welcome to COVID-19, the Orthopaedic Response, a production of the Digital Orthopedics San Francisco DOCSF team and the UCSF Department of Orthopedic Surgery. I'm your host, Stefano Bini. I'm a professor in the Department of Orthopedic Surgery, and we're thrilled to join by the American Academy of Orthopedic Surgeons as a global convener to address and rapidly respond to the dramatic changes to healthcare patients and our communities. And we're grateful to have a global audience joining us in this discussion. And I'm super pleased and delighted to have the honor of welcoming to the session Dr. Tad Vail, or Thomas Vail. He is a chairman of our department, the James L. Young Professor and Chair of the Department of Orthopedics, past president of the Knee Society, the American Association of Hip and Knee Surgeons, and the Eastern Orthopedic Association. He's also past director and vice president of the American Board of Orthopedic Surgery that oversees the licensing requirements for orthopedic surgeons. So we're extremely happy to have you here, Dr. Vail.
Thank you, Stefano. It's great to be here.
Awesome. And we're going to hear about the impact of how COVID impacted an academic practice. So I'm going to turn over the podium to you and bring up our decks, and look forward to hearing your presentation.
Excellent. Are we good to go?
Yes,
Slides
sir.
up.
Slides are up.
All right. First, thank you, Stefano, to you and your entire team for putting together a fabulous program over the past few days in a very brief amount of time. I know you all have worked really hard, and this conversation that's occurring internationally is exceedingly important. And I think my comments will help show you why. In our setting, it's called the title Complex Patients, but it's really a sort of a complex environment. And just to give you a sense, as Stefano alluded to, I'm talking to the University of California in San Francisco. I'm the chair of the department there and also on the executive committee of the health system. This is a big university. We have 6,000 students. We've got 43,000 jobs, and we have a big economic impact on the area. There are 2 children's hospitals associated with us, a trauma hospital, university hospital, et cetera. So you get the picture. Turning on a dime is not easy. Nevertheless, and all of you on the phone call have experienced, starting in November of 2019, life changed dramatically. And for us in San Francisco, we were running at full speed and really had to turn course instantaneously due to an unprecedented threat that we were experiencing. And some might feel that we should have reacted sooner. I think there were indications from groups around the world that we were at risk for something like this to happen, and before the virus came along. But now we are experiencing what you see from the Hopkins screenshot on the lower right, that this virus has pervaded communities around the world. The global awareness is exceedingly important, and the experience of our colleagues has shaped our response. And I want to frame that a little bit, because what we are experiencing now is very different than what we've seen in the past. Remembering SARS in 2002, the Middle East respiratory syndrome from 2012 were devastating medical issues, but they didn't have the impact that the new coronavirus has had on us. So starting in November of this year, of 2019, we became aware of this in China and the impact that it was having in Wuhan, and that sort of started the timeline that's impacted our decision making. So I'm going to go through some of these main events, and then we'll get more granular and talk about how we've reacted at home. But just to set the context for those of you from outside the country, what's happened in the U.S., the CDC confirmed the first case in the U.S. in January, late January, on the 21st. A couple weeks later, we admitted a patient to the university hospital, and that began the chain of awareness of this virus in our community, and looking at what happened in Wuhan, having to react quickly. We were using Department of Public Health testing mechanisms that quickly became inadequate from the standpoint of scaling, speed. So on March 9th, we began doing our own testing. We started a command center. We began to restrict meetings and access. A milestone for the ortho community was when the AAOS canceled its annual meeting on March 10th. On March 11th, the World Health Organization declared a pandemic. And for those of you from Italy, to say thank you, because we were looking at what was going on around the world, and we were hearing from our Italian colleagues that you can make a difference. And that's an important message that I'd like to convey here, that we've heard from our international colleagues, and we believe that you can make a difference if you intervene. And that message was heard loudly. The President of the United States declared a state of emergency on March 13th. About 2 weeks ago here in San Francisco, we went into shelter in place, the mayor declaring this order, and then for the whole state, the governor created shelter in place on March 19th. So give you a sense, these are the things that were going on in the world. Meanwhile, this is what was happening with the global cases. So you see in the blue, now, as of today, the last time I had a chance to look, over 1 million cases, and in the United States, about 250,000 cases globally. So this reflects that while we were taking some action, that exponential growth in the curve globally had already occurred. But there's more to it than that is important for our individual planning. And this reminds me of something that George Rutherford said, that a pandemic is really a collection of epidemics, and these have different trajectories. So if you look at the growth in cases for China, for example, in green, for Italy and the United States in orange and blue, you can see very different trajectories, very different experience in different localities. And this is not normalizing for population. So you can appreciate the burden in Italy, and we've seen it and we've heard from our colleagues about that. Another point illustrating the value of our international conversation is this article that gained a lot of attention here from the Imperial College in London, talking about how immediate action can impact the surge. And this really has had great importance at our institution in terms of taking action and taking action quickly, isolating people, closing public gatherings, even home quarantine. So you can see that it makes a big difference compared to doing nothing. So what was the local response? We really focused on safety, security, and capacity or treatment. The safety has to do with the healthcare workers, the public, the appropriate availability of personal protective equipment, surgical masks. We can touch on this more because there's been a lot around surgical masks in the United States. Who wears a mask, what type of mask, in what setting? And I would say gradually it's become more with greater use of N95 masks in certain clinical settings. Security really means screening. Early in March, we started screening people entering the hospital and entering the clinics and limiting visitors in the hospital. This is very difficult. People want to be with their loved ones, but it makes a big difference. And it makes a big difference not only for the sake of the patients, but the maintaining the workforce. The other important aspect of this is planning for capacity issues. Looking at the projections of cases, how they would occupy the hospital. This impacts every service, every surgical service, the orthopedic service, making beds available, making ventilators available, and keeping track of our capacity. We don't have time to get into the ethics of this, but it really, the idea of how do you allocate resources when they're scarce is exceedingly difficult. And we've had a lot of conversations around how to maximize benefits, save the most lives. And there's an excellent reference here from the New England Journal for those who want to read more about this subject. So on to the local response. You see here listed in orange are the total cases in the US and then what was going on in the US after the CDC confirmed the first case. We admitted our first patient. We froze the operating rooms early in March, stopped international travel, started providing updates to our community, canceled meetings, and then the online meeting really began to explode. There were things happening also out in the community that added to the gravity and the attention. One, of course, was the crash of the stock market, the financial impact. Another was when the NBA suspended play, the National Basketball Association. It may sound silly, but it got people's attention that this was serious at a time when the World Health was declaring a pandemic, and you'd think that would be enough, but the popular culture really has an impact. We ramped up telehealth. We started screening patients, eliminating visitors in the middle of March. We adopted the so-called Singapore model, and I think you've heard this alluded to from others. That is the idea of duplicating services and not overlapping so that you wouldn't have a complete team unavailable, say, to do hand cases, emergent hand cases, or trauma. Separating people. This included residents and faculty. And again, as I mentioned, confusion about PPE, who would be wearing a mask, and a lot of conversation and moving target on that over time. We opened a new ward for COVID patients. We opened a new hospital that had been shuttered and have that coming online in the next week or so for COVID patients. And several hospitals in San Francisco worked together to actually open a hospital's ICU that was shuttered to make more capacity. So a real team effort. We began requiring masks at the hospital for everyone. And in the community now, the politicians and public health people are recommending masks for people who go outside. So that's a change. And we've started to model the financial impact. Of course, that's taken a backseat to the clinical care. In California, in San Francisco, we really have three separate epidemics going on. You've got California Northern California and San Francisco, Southern California around Los Angeles, where they have 10 times the number of cases that we have in the Bay Area, and then the Central Valley. So three separate epidemics. During the course of events, you can see on the red line that our orthopedic surgery dropped, on the order of 90%, only doing acute cases. And you can see what's happened to the COVID cases in the blue line in San Francisco, gradually increasing on a linear basis. We haven't seen that exponential increase yet, and hope that we won't, that others have seen. And you can see in the green and the orange, fairly consistent in terms of numbers of hospitalized and ventilated patients. So we prioritized our patients, as I mentioned. We don't have time to go into it. Only the acute, urgent cases are being done: infections, dislocations, acute oncologic issues, etc.
So, Dr. Vail, real quick.
So finally, what did we experience?
Sorry.
Yeah.
I want to say that prioritization schedule that you showed us is also something we're using for when we cancel patients and we try and track them. We prioritize them as a way to afterwards. Sorry, I just wanted to, when the slide was showing, right? Correct. We're using that also as a tool to track patients we're canceling. Yeah. If I just go back to it briefly, although it may be at a different level of acuity, those that were canceled, and they'll have different needs in terms of how they need to be rescheduled. Is it a 2-stage that needs to be reimplanted? Things like that, versus those that show up in the hospital or the emergency room and actually have an immediate need to go ahead. But you're right, this prioritization scheme is going to be really important for all of us as we get to the point of looking ahead and saying, okay, how do we re-enter? How do we restart? And this will be important. I mentioned at the beginning, we're at various stages of dealing with this. Some are in the middle of the battle, and you heard this from Italy and China and New York, and some of us are anticipating, and some of us don't believe it's going to come. So we've got to get over that part of it. And what happens next, once there's a realization, okay, life has changed, the OR is closed, there's a real threat, getting out information to alleviate fear, alleviate stress, put misinformation straight. This communication is a really key part of the activity, and I spent a lot of time doing that and learned a lot in the process, and it's not perfect, but it's important. Following that, then there's this coordination, leadership, setting up lines of communication. I mentioned this command center that we have in the health system has a download every day that people can tune into, find out what's going on. This type of leadership is really important. And then determining the reality of the surge. So here in San Francisco, where we sit, using information that has been provided by others, using our best biostatistics and epidemiology, we're trying to predict what comes next. Are we going to be more like Italy, more like South Korea? Is San Francisco going to be like New York? This is what we're trying to sort out. And then, the reality is life goes on. People are taking care of their kids. We have to get up and go every day. A week ago, I had a grandson born in the middle of all this. Just reminds me that we need to carry on. We need to look ahead as best we can. But I would say right now, we're sort of right there in the circle that I've outlined here, between the reality of the surge, caring for the caregivers, managing stress, making capacity. And we're not yet to the point of re-emerging, although we're beginning to think about it. How do you establish trust for people coming back to the hospital, reinventing ourselves with technology? And I'll just end with the technology piece. There are a number of urgent technology needs, and I've listed some partners here, people who and companies who are working in these acute areas.
The guy in the mask there is Alan Dang, who's one of our own faculty, started a 3D printing process to make surgical masks. But the technology needs that are ongoing include things that have been discussed on this telecast and other settings, but communication tools facing internally and out to the public, the ability to work remotely, the technology, the security associated with it, just getting simple things like swabs to do testing, masks to protect people, and then the more complicated things like the respirators and so forth, the beds. Testing capacity, mentioned at the outset, scaling our testing capacity has been a challenge. Part of it is just having the reagents available to do the testing that we needed to do. And then decision-making. Some of this is exceedingly challenging. You're dealing with lack of availability, high demand, ethical considerations at every level. What operations are we doing? How quickly? How do we allocate resources? And then the treatments and the staffing models that go along with it. So thanks to the groups that we've partnered with, and there are others that maybe we can talk about as in the Q&A if it's of interest. And finally, just thank you for including UCSF and me in this presentation, the opportunity to hear from my colleagues around the world, and I wish you all best wishes as you deal with this challenge.
That was outstanding, and I certainly invite our audience to ask Dr. Vail questions. And Tad, thank you so much for that presentation and that timeline that was very instructive in terms of what happened in our personal experience and also how we responded to it. I'm going to just see if there's a question here. I'll just get straight to them, and then I'll ask some if there aren't any. So a lot of questions. We're a big academic center. What's our surgical volume across the service lines per year?
For orthopedics, you mean? Or?
Yes.
Yeah, I would say it's between 9,000 and 10,000 cases, something like that. And right now we're 10 to 15 a week, something like that.
Dr. Jaideep Liengar is an orthopedic surgeon. He's asking, for any eventual restart of elective orthopedic cases, are you planning on initiating mandatory pre-op COVID testing? That's probably not a Department of Orthopedics question. Have you heard anything from the university as to how they like to address this?
Yeah, hi, Jay. Good to hear from you. Well, you know what? If we had unlimited testing capacity, we would do testing. And there's a lot of conversation around this. You may have seen some guidelines from the Mayo Clinic talking about doing CT scans and testing and other screening, which is important to protect healthcare workers, because I think we're just beginning to understand the risk to healthcare workers, particularly in the operating room, particularly for patients who are getting intubated or having procedures that aerosolize the virus. So these are ongoing. Now, this is balanced with the notion that testing isn't perfect. If you test asymptomatic people, you're going to get false negative results. And that creates another set of hazards that need to be considered. So, yeah, I would say eventually we will do more testing, but I'm just acknowledging that that's not the only solution here.
Exactly. The lack of testing may not be maybe an option. In fact, we even had a call go out, I think, to the community for masks, and people were delivering masks to the university because we were short. Is that right?
Oh yeah, it's unbelievable. We've had anything from a one of those crates that comes off a ship with 500,000 masks to a kid riding up to the loading dock on his bicycle with 3 boxes and dropping them off. The response from the community, this has been very very heartwarming, and I saw it in New York on the news with people banging the pots and pans and wishing well to workers going off to work. So yeah, I think there's a lot of coming together that is should be mentioned, along with all the heartache that goes with this.
Excuse me. Sorry. Dr. Indeli, down here at Stanford, obviously he's got a long history of practicing in Italy, has a question he says, many of my Italian ortho colleagues are expecting a serious reduction in elective cases in the next year. Should we get ready to change our practice for a while? And I suspect it's a two-pronged question. One is the hospital as we reopen may be filled with people who have greater urgency than arthritic problems. But the other is fear of getting back into a hospital that may be still considered a place where people go to get sick. What are your thoughts?
Yeah, I mentioned that, the trust issue, and that's kind of what I was getting at. We have to be able to determine that where we're working is safe, and then how we're dealing with people who will have the virus. And there are, that will be ongoing for many months. Maybe we get past the surge, and that's really what we're focusing on now. But then the virus will be in circulation in the community, and we will have to have standards. We will have to figure out the appropriate testing and screening that makes people feel safe. So Pierre, yes, this is going to go on for many months. There's that aspect, and also just the workforce aspect. You cannot turn things on immediately once you've turned them off. And I think Rand Schwarzkopf alluded to this last night. There's a process that we're going to have to go through, and it'll be, obviously the quicker the better, but it's not going to be immediate.
I have a question about that, actually, but I get to your questions. How are the staff and orthopedic surgeons handling the new reality? What's people's emotional health? What types of support have you seen people need? Yeah,
well, I sort of alluded to kind of the transition of emotion that's occurred with this. I would say congratulations.
I'm hit one button station.
Congratulations are in order. People have reacted in a very positive way, but it's also very difficult. We are not trained to not operate. We're not trained to be on the sidelines. So we need to figure out how to contribute. And this has been very difficult for staff and faculty to manage, and not to mention stresses personally on their families and so forth. They're people like all of us. It's hard. And not that we can't handle it. Nobody's asking for sympathy, but I think we just need to recognize that as being true.
There's questions about stratifying patients and who we're actually operating on at UCSF. Can you give a little more insight to, because I know we are operating, we're just not doing a lot of surgery. What kind of surgery are we allowing to do at UCSF?
Yeah, in sort of broad brushstrokes, I would say acute infection, acute fractures, where particularly open fractures, not the borderline non-displaced ankle fracture that could wait. But you know what I'm saying, the type of things that really need attention. Neurologic compromise in a spine patient, somebody who's declining, epidural hematoma, epidural abscess, that kind of thing in the spine realm. In oncology, it would be it may be a patient who's in a chemo window, and if they don't have that surgery that was planned, it will negatively affect their, put their life at risk potentially. So these things that have a high degree of impact on patient well-being is how I would characterize it. Not the routine by any means.
When you were talking about we opened up these new hospitals, we worked with the city to find hospitals that were closed, and we needed to staff them. Tell us a little bit about how we were able to find the people to staff them.
Could you repeat it, Stefan? I'm not sure I understood.
Yeah, sorry. We opened several hospitals that were previously closed so that we could make room for COVID patients. But it's not just the building, the infrastructure. We have to staff it with people, and many places are reporting that they're having shortages of staff to people to staff the existing hospital infrastructure.
Yeah, no, that's right. So we've really we've reached out to the community, bringing people back who may have retired, looking for travelers and other people who are coming from other communities that want to be involved in doing things like this. It's a work in progress, and we don't know to what extent we'll need all of it. So we've gone about creating the infrastructure and the capacity, and are in the process of putting the staffing in place. But you're correct. It's complicated, and there's some attrition. You have of staff. People who get quarantined. What have you, that others have alluded to that you have to manage. So again, I think using the strategies that are people would expect in recruiting and providing opportunity, making people aware that we're doing this and that there's a need.
We had a talk from Dr. Center that was, we will repeat again this afternoon. We went live very quickly with telemedicine. And we'll speak a little bit to the fact that we had an infrastructure in place to do that, and your experience watching as the chair of the department, how we adopted to that new technology.
Yeah, I mean, I've used it myself. It's in some ways it's a compromise, but it's also really good. I think if you can look a patient in the eye and answer their question, and sometimes you have an image to look at, and sometimes you don't. You tell them, okay, well, I can't make a final decision until we look at this X-ray, and we'll make a plan to get one at the appropriate time, depending upon the acuity of the need. But I think not all problems can be solved in a remote visit, but many can, and many patients are grateful simply for the opportunity to have their concerns alleviated by a face-to-face conversation. If it's only creating a plan for the future, that's valuable. It may not be solving the problem completely. So we've used it a lot. Our practice is, we've got patients that come from many hundreds of miles away as well. So there's the convenience factor, and then there's the concern. Somebody's living in a rural community where they don't really see the virus, isn't really enthusiastic about coming to San Francisco,
right,
where we have it in our community to be seen. So there's some safety issues, there's some convenience issues, and I think there's some real reassurance that occurs using that platform. So I've found it to be very, very helpful.
I have a question here about the economic. Oh no, actually, I think there's a strong interest in having you answer this question. Do you think there'll be a large move of hospital-based surgeons towards outpatient facilities, because the expectation is they may get started earlier than the inpatient environment? Will we see an outpatient shift driven by this that may not otherwise have happened?
I think there will be some of that. It'll be managed in an appropriate way with patients who are appropriate risk profile for ambulatory surgery. But I can say certainly, we have an ambulatory surgery center. We're looking at, all right, well, what part of our very healthy population that we have moved more slowly with doing outpatient surgery in the inpatient setting, let's just move them over. Let's just say, okay, we're going to take these people and move them over to the ambulatory setting, because we've shown that we can do them in the inpatient setting. So yeah, I wouldn't say it's going to be a wholesale change, but this is something that started before COVID, and I think will be accelerated by COVID and will continue. So that trend that you're asking about, I think, is an important one that will only be furthered by the experience we're having here with this virus.
So last question, I think, before we may get two more in. There's a question from Gregor Rechnick, and his question is, what would the economic and health-related consequences be of not doing orthopedic surgery for a period of time at a global level? It's a broad question, but he's wondering if you have any sort of overarching thoughts about that.
Yeah, you know what? You have to advocate for musculoskeletal care here. Much of what we do isn't acute. You can delay some things, but it is to the detriment of the population. the skeleton isn't just a structure that you hang the organs on. It is important from the standpoint of general health, other conditions that people have impacting heart disease, neurological conditions. And then there's the acute problems that we deal with from the musculoskeletal standpoint. I think, as I was alluding to before, you have to prioritize. You have to balance what you can do with the resources that you have, and it'll be different from place to place, city to city. But the needs of musculoskeletal patients are important, and they don't go away because of this.
Right. Exactly. So as we wrap up our session, what would be your, no, there's one thing we didn't talk about. We're a big academic center, our residency program.
Yeah.
We heard from Rania, so would you talk a little bit about what we've done? You mentioned the cohorting that we did following the Singapore model. How about our educational?
That's really on the clinical side. The educational side, I'll have to say, I have been so impressed with the remote learning that's going on. I mean, the conference schedule has marched on, and it's been well attended, well appreciated. In fact, I would say it's even increased. So we're missing the hands-on learning when people aren't in the operating rooms. That's a challenge, and we hope to get back to that. But the didactic teaching, that has continued, and it's going great. And I think also there's some work afoot to really share among residency programs lectures and learning opportunities that would be outside of our normal curriculum. So some really good things happening there to counterbalance the challenges that we face.
Dr. Vale, thank you so much for expressing your opportunity and sharing that with us. I thought that was a really great session. We unfortunately are out of time, but thank you to the audience for participating. Thank you for providing us that insight. I am now going to quickly turn over to Shauna as she moves into our next session. And I'd like to remind everybody that if they'd like this content, they can see all of the prior lectures that we've had in the last 2 days and follow us at docsf.health, docsf.health. And be part of our community. We'd love to have you. Thank you very much, everybody. Have a great day. Dr. Vale, thank you.
Welcome to COVID-19, the Orthopaedic Response. We're a production of DOCSF, which is a conference that's based out of UCSF. I'm your host, Shauna Butler, and we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to help us address this uncharted territory and unprecedented moment in time. And I'm really thrilled actually to have this global audience joining us to help us think about all of the different things that we're challenged with. And I'm thrilled today to bring to the audience Dr. Vonda Wright. She is an orthopedic surgeon, and let me see if I can get her up on our screen. Vonda, we have your slides with us. Can you? Yeah, we can hear you. Great. So I'm going to introduce you just real quick, and we'll have your slides. And I'm sure that during this moment, we'll get you back on the screen so that we can see you visually. And if the audience is out there, if you can let me know if you guys can hear Vonda, that would be really helpful. So Vonda is an orthopedic surgeon. Amongst other things, researcher, entrepreneur at Northside Hospital in Atlanta, Georgia. And there she is the chief of sports medicine at the Orthopaedic Institute. Vonda, you want to run through that title so that we make sure that we've got that right? Okay, great. And the audience is letting us know that they cannot hear you. Could I get you to take just a minute and try refresh your screen, and let's see if that helps. Perfect. Great. And if you can bring your slides up for us again.
Oh, yes. Here we go. All right. I'm trying to hover over myself, and it's not coming. Oh, here we go. Did you get them?
You are a ninja. So actually, before we dive into that, let's talk a little bit. No. Like I said, we are a community of learners, and we have a group of people out there who are a very generous audience who are cheering us on, wanting to see us succeed. And I think one of the things that's really great at this moment in time is that it allows us to bring our real selves, the challenges that we have. And if we ever needed a moment to be humbled, I feel like, every day learning new things. And I think it's really great to be transparent in the fact that we are learning and we're learning together. So thank you for your patience. And you have a remarkable story. So at Northside, let's talk about the size and the scale of the department and the practice that you run.
So, Northside Hospital is, according to the Atlanta Business Journal, the largest hospital system by revenue in the region. And so they started out as one hospital, a community hospital, and really have grown to a health system that spans the entire northern wedge of the city. And so until 2 years ago, they were host to 147 mostly private practice orthopedic surgeons. And then they decided very wisely that they needed to invest in their own orthopedic surgery department. So prior to my arrival 2 years ago, they had a total joint practice, which has become very robust. And over the last 2 years, we have added to that in the Orthopedic Institute, the other subsections of orthopedics that everyone practices, with the exception of true pediatric orthopedics and the congenital type maladies that pediatric orthopedics takes care of. So for all intents and purposes, it's an academic department, although we're more close to a privatemic. We still function as a privatemic, although we're owned by the hospital. So we're 2 years old. We have 25 doctors. 21 of those are surgeons. 4 are non-operative sports medicine doctors, 14 PAs, and in 16 locations, with 6 of those being hubs, meaning that in those locations, there are larger locations. They're co-located with radiology, physical therapy, everything an athlete, an active person would need all in one place. So
that was 3 weeks ago, right? That was 3 weeks ago.
Well, that was 3 weeks ago, and I'll tell you what we're doing now. But
because what that looked like 3 weeks ago and what you've done in this incredibly short period of time is miraculous, Herculean. So I want you, I mean, that was why we reached out to you to talk about this literally pivot on a point and go from what you just described to what you are doing today. So let's talk about what you're doing today.
Well, and part of that, most of that, is having the right staff, both medical staff, clinical staff, and administrative staff, executing to pivot. So I just put up in this first slide that our COVID
let me go ahead and get your slides, enlarge them. So you go ahead and walk through, but I wanted to make sure that we set the stage for people to understand what you're going to walk us through here.
That's right. So basically, we have a large department and a wide geographic and number of offices. And so the first slide that I have up here is really our timeline, because I think the rapidity of how we made the changes is one of the very interesting parts of this. And I know everyone has done this, but so people who have not made this change yet, I thought it would be interesting for you to know everything we considered in getting this done. So March 10th, schools were closed in one of the main counties that we work in. And that night, March 11th, I did a deep dive into all the data and really coalescing and becoming a scholar of COVID, and really was convicted that we had to protect our patients and our staffs, that we still had to care for the urgent and acute musculoskeletal problems, but also conserve resources, because at that point, I did not know what our stockpiles of PPE were. So our staff is used to me texting day and night and knowing that it's just communication, not the expectation they're going to work in the middle of the night. But on March 12th, which was a Thursday, at 8 o'clock in the morning, because we had been texting earlier than that, we had the first administrative staff meeting, and the 3-phase program that I'm going to describe to you today was really brought from out of the back of my head, sifted through all of our administrative staff and off of a paper napkin, if you will, into a 3-pronged plan that was pretty detailed. Throughout the day Thursday and then Friday morning, we continued to develop that plan. But March 13th, we had a big kickoff, and I'm making a capital letter deal out of this, is because to build esprit de corps in frightening times like this, I believe that leadership has to pivot also from, usually departmental leaders will be strategic leaders. They will put together a plan and then ask it to be executed with the excellent people that you've hired to do the logistics in every day. But in a situation like this, in war, if you will, I truly believe that those in charge need to show up. And so we made a big kickoff, which I think is important. By March 16th, so March 13th was a Friday. We worked all weekend. By March 16th, is our line in the sand. That's when we're starting to count our financial changes, our practice changes. That's a Monday. By Wednesday, we were live with Telemed, 25 physicians. And by March 23rd, phase 3, which I'm going to show you, was up. So that is pretty rapid, because in many big systems, it takes time. So this is how we broke down the phases. Phase 1, we're going to make a plan to protect our patients and our staff, establish the COVID operational workflow, which I'm going to show you phase 1 in detail, and evaluate resource utilization and plan oversight. 2 very, very important parts of building a plan like this. Phase 2 is outlined there. It started on the first Monday, the 16th. Staff and MD education, telemedicine making it operational. And then we had to gather data, because this is a dynamic changing plan every day. And then finally, phase 3, which we launched into on the 23rd, was consolidation and long-term resource management. So if we look at phase 1, like, how do you actually do this, get it off the ground? These were all happening simultaneously. We had to minimize face-to-face patient interaction. So Friday and Monday, and even over the weekend, we called all the patients that were coming in the next 2 weeks on our schedule. It was all hands on deck. Everybody was calling our patients and asked them to voluntarily reschedule for 2 weeks in advance, because we didn't know at that point how long this was going to be going on and whether Governor Kemp was actually going to shut down the state, which he actually did yesterday. So we asked them to reschedule 2 weeks ahead. 41% of our patients voluntarily rescheduled for 2 weeks. So that meant that we only then had to ask our physicians to review their clinic lists for the remaining 60% and to determine which of the patients were appropriate for telemedicine and which really still needed a face-to-face. So that was happening. At the same time, we were developing our pre-screening and clinical distancing plan. So we have a 3-part pre-screening procedure we go through, both the day before, or at the time of appointment, the day before, and upon arrival, where they're not only given questions, but their temperatures are taken. We've also developed a clinical distancing plan for our staff. Normally in our offices, we may have 3 or 4 people sitting out at the front desk, but because volumes are lower, we took everybody away from the public that could and put them in back offices or phones that were distanced. At the same time, we were inventorying our PPE, and we found that we had used a lot of our supply and had not yet gotten the next normally scheduled set of PPE. So we had to plan according to how low our baseline supplies for, and then ask for staff availability, because our schools have been closed and we employ a lot of parents. So counting those as resources. At the same time, these are all going on simultaneously, we were making a telemedicine action plan. Fortunately, we had already engaged a platform, which I'll tell you about. I appointed a champion. It was my own athletic trainer, because she is our lead athletic trainer. What a champion means is she must know the platform better than anybody and serve as a resource for everybody. And then we scheduled trainings, which I'll get to. And then I think the last 2 points, oversight and the kickoff, are really important not to forget. In a strategic plan, sometimes you say things like point A must be executed, point B must be executed. For instance, here we'd said every surface must be wiped down every 10 minutes. We didn't stop with that. Every single office appointed a safety chairman who then put names to times and to locations, because remember, every detail matters. So this is how detailed these kinds of plans must be. So I know that Carrie is wiping down these surfaces with this material every time point, and everybody knows their job. It sounds very military, and actually it is very military. Everybody has their job and they know when to do it, and they're personally accountable. Yeah. Then I appointed or asked for volunteers actually for an MD task force. Even though I did a deep dive on November 11th, do not pretend to be a COVID expert. And so I asked my physicians, not only so that we would have more brains looking at this, but more buy-in. And we arranged an MD task force call every day at 4 p.m. because this was so fluid. And finally, multiple daily calls happened. And then we scheduled the big kickoff for Monday at 1 p.m. for everybody. So this is all happening simultaneously to set up for a big pivot. And then the big pivot happened on March 16th was the day, the line in the sand. So our telemedicine champion, our super user, had first a mandatory extender training in the morning. So if you're going to roll out something like this, I suggest that you train the extenders first. Then we had wave 1 mandatory physician training. It was a few hours. And then wave 2 and 3 the following day, so that by the 18th, which was Wednesday of the week, 25 doctors, all the sports medicine doctors and all of the total joint doctors were trained in telemedicine. and began seeing patients actually then on Thursday. The COVID plan that I just outlined for you was rolled out this whole week, and we decided that we not only needed this plan, but we needed to reconvene every day. So in every site, every day, we had a morning safety huddle. How's everybody doing? Taking their temperatures? What are the concerns from the day before? Because Shauna, as you like to say, execution is everything. If we're not checking on the execution, we're not going to get it done. And then finally, we had the PM task force calls, and adjustments were made every single day. And we got through the first week. And so here's just a little bit more tidbits on telemedicine. This is one of my doctors doing it from home. We are using the Amwell platform. It is a Cerner and Epic library platform that we had started to evaluate, because when we started, you actually needed a platform. And then Trump and CMS relaxed some of the HIPAA and rules surrounding telemedicine. And now you can use anything, Zoom, FaceTime, Skype. And here are some of the billing codes. I know some of the audience is international, but in the United States, these are some of the codes that our revenue integrity have enabled us to use. And our billing is largely by time spent and complexity. A few lessons that we learned is not a surprise to anyone that works with us day to day, is physicians are impatient, and it takes a little bit. And we had to, and changing habits is not that easy. And we had to do multiple tutorials. The first time our docs got on, our champion was on the phone with them. But the fact that we started out with a big kickoff and had a task force involved is we have such a esprit de corps. Everybody's working together. And I would really encourage people rolling out a big plan like that to do that also. So before
before you go into that, that point that you brought up about being impatient, in this, have you been able to identify the source of the impatience? I mean, what is creating the impatience? Is it, I want to be able to learn this fast enough? I feel like I'm not. I mean, have you got any insight into what are people impatient about? What's creating the impatience?
Well, I think it is truthful to say that whether we're in the operating room or whether we're in our clinics, having a routine and a workflow that one goes after each other, there's an efficiency in sameness. So the fact that this was a completely different workflow, here, I'll give you an example. So when I am seeing a live patient, I will do all my work because I refuse to chart in front of people. It's not personal enough for me, the way I see patients. I'll come out of the room and I'll dictate. When I'm on telemedicine, it enables me to have my iScribes person listening to the visit and write my note at the same time as I'm interacting with my patient, which is a new workflow for me. So surgeons get impatient when the workflow varies. Something's not there because efficiency matters to our patients, right? So there's an impatience of not understanding the system. Thus, our super user had to get on with each and every person when she was requested. There was an impatience as, this is not what I usually do. But I don't want to overplay. There was impatience, but there was tremendous esprit de corps. And literally everybody was proficient within the first week. But just for people recognizing it's going to happen, you're going to need to.
That's what I was just thinking, is that, you know, the way to diffuse or to mitigate impatience is to say, this is going to be disruptive. This is going to be learning. Right. We all need to just recognize our efficiency is not going to be what it was. So if we just take a deep breath and be patient with each other, that we're all learning together. So that was why I was asking, because that is some of the comments that I've been hearing, is that tempers are short and there's a lot of impatience, and they're learning something that's new, and they're used to looking very competent at what they're doing.
Sure. And I'm a surgeon too, so I get that. But I have encouraged my staff, and both on our mandatory surgeon calls, which we do, and our staff calls, that we have to remember what we're doing. We're protecting our patients. We're protecting ourselves. We're being good stewards of resources. These are unprecedented times. Let's just refocus so we don't turn inward and be me, which is what sometimes we do in the OR, right? So what are we doing? What is our why?
How do we act collectively, behave and act collectively?
That's right. It's not mine right now. It is, everything's gonna be okay together. And I don't mean to sound sappy, but that's the language I use. It's not only reassuring, but redirecting.
I'm going to give you permission. Lay it out there hard and heavy on the sappiness. We're going from me to we in this. So anyway, proceed, keep going. I didn't want to lose that point.
Got through the first week, right? We got through the first week. Everybody's talking. We have completely in 1 week changed our entire way we see patients. And then week 2 gets here, starting March 23rd. And we have not gotten our supply of PPE yet, but I have come to believe that all of our staff at all times must use masks. So how do we do that? So we're evaluating that as an input. How are we managing our staff? Who is calling off? Who has to be gone because of their children are out of school? Do we have someone sick? And then finally, we had to start, and everybody will have to start shifting roles. Just because you are a patient check-in person, during this time, you may be solely on the phones and reassigning those roles. But because we recognized that we did not have enough PPE to run 16 offices and all staff seeing patients, we started to make a plan in the beginning of week 2 to consolidate to our hub practices and ask, because of the decrease in volume, all of our clinicians to see their live patients, their remaining live patients in 1 day. Now, we have some pretty high volume doctors who needed 2 days to do that. But the point being, we're going to concentrate the live visits and minimize staff exposure and use of PPE. So we gave that power back to the doctors. I said, doctors, choose the day and choose the clinic, because most of our doctors go to 2 places. And they did that. And then using that data, then our clinical manager made a grid so that our hub offices were open 5 days a week, because we get a lot of walk-in patients. And we had made a relationship with our urgent cares that we would do the musculoskeletal urgent care. All they needed to do was send people over. So hub consolidation to consolidate PPE use and staff exposure. Every physician, if their volume, unless their volume mandated 2 days, saw their live patients in 1 day, and then they could do telemedicine all the rest of the days they wanted to. And this week, we not only made a plan for this, implemented it on Thursday of this week, of this March 23rd week, and then started working on our long-term plan.
That's an awful lot to get done in a short period of time. And it's so funny that how the time frame shifts. We're talking about short-term being on a day and long-term thinking in terms of a week.
Well, and even since I made these slides 2 days ago for this, we have now progressed. We've decided this phase 3 was a great plan. It's going to serve us probably the whole month of April. But now we're shifting to phase 4, which is we need an actual plan for, right now, our hospital has been completely flexible and generous in allowing us to keep all of our staff. And when the hospital has a need, we flex our people out to screen at the door of the hospital, for instance, or to fulfill the need of our hospital. But we need to have a plan in place just in case those circumstances changes. We also need to not ignore the fact that at some point we're going to get back to normal. And how do we do that? Because our surgeons have piles of surgeries to get rescheduled. And so I'm beginning to think about phase 4 now, to address both of those issues. And next week, we'll start talking to our clinicians and our staff about phase 4. So this is a time to be nimble, to put egos aside.
So the phases stay the same. It's the time frame that adjusts.
Well, we're in phase 3 right now.
Right. So
And
you've got each one of those phases, but when the phase gets activated, that timetable is what's needs to be nimble. But the phase itself, what you're going to be doing, seems to be a little bit more stable.
Yes, I think the progression of how we did it is highly functional, to go from normal clinic to COVID clinic. I mean, I think the phases we rolled out are really logical and rational. When you do it, depends on individual circumstances,
Right.
the day-to-day changes. And so
that anybody could take these phases and match it over to whatever time frame they are, wherever they are when these phases need to be activated.
That's right. Mm-hmm.
So you've created a roadmap.
That has worked for us, and it could be a guidance for other people who have not yet have to make these significant changes we have. Mm-hmm. So, but that's the last slide I had. So I don't know if you had questions or.
Yeah, let me go ahead and bring us back up on the screen. Yeah, actually there are. So very specific question. This is coming from Catherine, and she wants to know if you're using the standard outpatient E&M via telehealth with audio and video. So the 992, are you required to use time to code, or can you use the standard complexity requirements to code, which may take you less time?
Well, the hard part. Oh, go ahead.
And if you use the time, is a pre-visit prep, the imaging, the chart review, M&A to talk to the patient, is that allowable as part of the time documentation?
So the hard part about using standard E&M codes is that we're really not able to do a physical here. And some of those codes require detailed physical exam. So the way our revenue integrity had helped us get through that is to do it with time, because otherwise, I mean, I can't make up a physical. I frequently do have people show me their knees, but all I can tell from a knee is what I observe, which is range of motion. Is it red? Is it swollen? But I can't put hands on it. And so that's why time works for us. Interesting question about time for pre-prep. I do look at MRIs before I get online so that I know I like to have a game plan in my head, but I walk it through with the patient in real time. So, so those visits, if I spend 30 minutes with the patient, I will have gone through the MRI with them. I will have gone through all their questions with them. So I'm accounting for that. I'm not just accounting for the 10 minutes when I say, you got a meniscal tear, and when we come back, I'll fix that for you.
Okay. So Gregor has a question here. He wants to know, so he says that orthopedics in our institution have been calling patients for the last 2 weeks. The patients were universally very happy that we called, and it seemed that they presented with less disability, less complaints, less concerns. So when approached by the phone compared to a live visit, and he's wondering, have you had a similar experience?
They're less hurt when you call them on the phone?
Yeah.
Is that what he's saying?
It just sounds like that there are fewer complaints. It sounds like when you're preemptive about that and just giving somebody a call to check in, and he was curious if you've had a similar experience.
We're doing two kinds of calls. So that's interesting you said that, Gregor. In phase 4 that we're starting now, we are going to just check in. Even if patients didn't have an appointment, we're touching base with them as you would with a friend to say, just checking in with you. We want you to know that we're still open. You don't have to go to the ER. And so we're going through the thousands of people in our database. We don't expect them to be hurt. On these telemedicine visits, they tend to be more streamlined than in the office. In the office, we go on, and at least this is my style. But on telemedicine, it's such a new platform. I find that maybe this is what you're saying, that they're really to the point. They just need their information. They're sitting on their couch or in bed, and it doesn't continue on and on. So I don't know if they're less hurt, if it's such a new environment, they don't feel comfortable yet.
And Wayne Johnson wanted to know, what percentage of your patient volume diminution have you experienced transitioning to telemedicine as opposed to your pre-COVID clinic visits?
So our, that's a good question. the first time we asked people to voluntarily reschedule, 41% did it right off the bat. And then of the remaining 60%, we are seeing, the first week we did telemedicine, we were seeing about 30% of them telemedicine and still had a lot of people coming in. Now it's flipped. We're seeing about 30% live, just because we have to. There's some real there's some actual fracture and post-op happening, and new injuries. And then 60% is telemedicine. I suspect as we continue to progress, we're going to be nearly 90% telemedicine. So,
one of the questions in here, and I think that this is a nice segue into it, given all these changes that you're seeing, long-term plans. So, you said that you're grabbing a bunch of data, using that and incorporating that into your current plan. So is what you're seeing, let me ask it this way, based on what you're seeing right now, how does that factor in, and what are you thinking that your long-term plan is going to look like?
For getting back to business as usual?
Yeah, well, I was going to say, it's business as usual. I think that's...
I don't think we're going back to the old way.
Yeah, I don't think it's... We talked about this earlier, and we say return to normal. I think it's when we return to an optimal. But as we move through the high rates of transmission, and we feel like we've got the communicable nature of this at a place where it's safer for us to be interacting in person, when we get a vaccine, long-term plans for orthopedic care, what are you seeing that's going to look like?
So this is what I think is going to happen. I think out of this experience with changing what people perceive as urgent, meaning there are some patients where, and believe me, we are happy to see them, but that come in when their knee has hurt them for 2 days, versus the opposite side of the spectrum when people wait 6 months and we wish they would have come in 2 days. I think people having been forced to wait in the future, they may continue to think, well, it's only been 2 days. So I think we're going to see less of that, number one. Number two, our clinic, and this is part of our phase 4, will no longer just say, sure, come in. We'll say, would you prefer a telemedicine visit, or would you prefer to come in? Or would you prefer a phone call? Because now that we're becoming very effective at managing our phone time, and I've never billed my patients for my phone calls, but this is a new paradigm. Maybe we will adopt that in the future. Our patients will have multiple ways to engage with us. And I was just thinking about this today. I may, and check in with me next week when I've got phase 4 really going, but I anticipate needing to staff my offices differently, because when my doctors are really, really good at telemedicine, they're not going to need their staff sitting there to help them. And I may be able to shut down whole clinics because it's a telemedicine day. If it's not a hub where we're open 5 days a week, you can still be completely in business in a closed office. You know what I mean? I think it's going to really change the need for every office to be open 5 days a week, all those long hours. We'll still be able to see more patients with less staff, probably.
Imagine what that's going to do to the traffic in Atlanta. I like that one.
Well, there you go.
Well, when you were just mentioning that about a reduced amount of time, that also means reduced amount of face time within our teams, within our staff. So given that you guys are geographically distributed, working remotely and virtually, how are you coordinating? What's your communication method for teams?
So in week 1, we had 3 mandatory all-in phone calls. All 137 staff were on the same call, listening to the same messaging. We're going to have a couple big calls on Monday for phase 4. And we just think more is less. We don't want people to be afraid. We don't want rumors to fly. I think over-communicating is the best way to do that, and having leadership at all levels at the table, not the coordinators that they're used to hearing it from, but the levels above them. At this time, it's very important. So we do those mandatory calls. if other leaders out there find that their physicians may or may not read the emails you send them, I have established a text stream, and on that goes all the COVID information that I'm gathering. They've started contributing. They read this text because they respond. So it's enabled us to communicate maybe even better than we ever have. And I was thinking of actually downloading the app House Party that my teenagers use, where 25 people can have their faces on a screen. And I mean, that might be fun next week. We'll see if we do that.
Yeah. Well, this has been great. Thank you so much for taking the time to share with us the very detailed plan and the phases and the timeline and how you've responded, the data that you've been looking at. You've been very generous in going through. I think that this is an interesting moment where we haven't normally shared these type of operational details to really bring. I mean, at what point in time have we, as a planet, been facing the exact same problem at the exact same time? So it gives us an opportunity to work together in ways that we haven't done before. And you are a very generous contributor to that. I know that you are widely available through all the social channels, and I encourage people to reach out to you. And again, thank you for spending the time with us today on COVID-19, the orthopedic response. Grateful to DOCSF and the team at UCSF and our partners at the American Academy of Orthopaedic Surgeons. And I will see you online. Be well, stay home, stay connected, and see you next time. Bye.
Bye-bye.
Ladies and gentlemen, welcome to COVID-19, the orthopedic response. I am Stefano Bini, the chair of the Digital Orthopedics Conference, San Francisco. I'm also professor of orthopedic surgery at the University of California, San Francisco, with whom we are co-hosting this podcast. We're also joined by the American Academy of Orthopedic Surgeons as a global convener to address and rapidly respond to the dramatic changes to healthcare, patients, and our communities that we're seeing as a result of the COVID pandemic. We're grateful to have a global audience joining us for this discussion. And I'm super pleased to welcome Gianfranco Di Maira, il grande Gianfranco Di Maira, as we like to say, who works he's a senior partner and vice president at BTS. He's managing director of BTS Italy, and you may ask, who is BTS? So BTS is a global consulting firm which accelerates and improves strategic alignment and execution for business simulation. So welcome, Gianfranco. Now, the reason we're here is because you guys are in Milan and because you are an expert in understanding how we drive change and how we lead through change. So you're going to talk to us a little bit about what you've seen. Is that right?
Yeah, that's right, Stefano. And thank you very much for hosting me. And I'm very pleased to be here in your conference. It seems to be a great conference, actually. A lot of attendees, so I'm very happy. Stefano, I'd like to make a short disclaimer, a little disclaimer before starting. Actually, I have two. This is not my native language, as you know, and I am pretty confident with English, but it's not as fluent as it would be in my mother tongue, so apologies for that. Second thing is, I am not an orthopedist, as you said. I am not a doctor. So I'm looking at it from another angle. And indeed, one of the angles which I'm looking at it is definitely as a consultant, a leadership consultant and a strategy execution consultant, but also because of having been in the epicenter of the COVID-19 breakout in Milan and a little bit forerunner or front runner before many other countries after our Asian colleagues. So,
and just real quick, there's been some concern about echo. You wouldn't have a pair of headsets. I think the room is echoey. Do you have a microphone we can borrow? We tested it before, but it doesn't seem working. And while you're looking for that, I want to show I did something very special for those of you very attentive. I changed the picture on the wall behind me for an old map of our native country, Italy, that goes back quite a bit. You can see that they didn't quite have the proportions right back then. Sardinia, if that was a Sardinian who did the map. Very good, great. So let's see if this works a little better once you plugged in. Let's see how that works. Oh no, actually I can't hear you. I think your microphone is still on. Yeah.
I'm sorry for that, Stefano, but I think
No,
we have
we'll
to
just go ahead. It was worth a
Yeah.
try. Great. Why don't we get started? And I will make your PowerPoint large, and I'm sure we can handle the echo a little bit. Okay, here we go.
Okay. So, Stefano, as I was saying, I'm looking at it from this angle as a consultant. And as you were saying, this is the only slide I'd like to say about how we look at it when we look at it from our perspective with corporate leadership. And what we try to do is we look at how to help companies and organizations go through change and adapting to change and execute strategies or execute different strategies in a different way.
Right.
And as we look at it from a people perspective, what we believe is that an effective change or execution goes through three things, which are alignment, mindset, and capabilities. Now, what we mean with that is alignment is we all understand why, what, and how we are going in a different direction or in a certain direction. The mindset is people understanding and believing and wanting to go for that change and having that sense of urgency to go for that change. And then the capabilities is once the other two aspects are in place, do I have the right tool set or toolkit to act accordingly, to execute accordingly? So this is just a disclaimer to say we look at it from this angle and not from a medical angle, okay?
Correct. Now, on the other hand, we always talk, and DOCSF has always had this strong leadership component. We understand that technology is important, but you have to lead the change through it. And whether you're trying to deploy new digital health tools in the context of COVID and telehealth, or whether you're trying to manage any other aspect of leadership, these tools you're about to show us are really helpful, and we've always integrated them into the DOCSF conference.
Great. Now, for many of you, this picture may be well known. For many others, this picture may not be well known. This is Piazza Duomo of Milan. This is the main square of Milan, and I'd like you to, kind of bring you into the story with this square, actually starting from the square. In any moment in time during the day, in any day of the year, this square would be crowded with thousands of people. You would be seeing thousands of people in any moment of time. Now, in this moment, now apart from being 9:30 in the afternoon, in the evening here in Milan, but in every day since 6 weeks, this square, this is a little bit what you would see in the square, full emptiness. Now, in my whole life, Stefano and all the attendees, I have never experienced anything like what is happening in the last 6 weeks, never. And what we actually decided to do with our global leadership, as we were in the epicenter of the crisis before many other countries, and we were expecting many other countries to get into the crisis, we decided to pull together some of the lessons learned from Milan and to make them available for other leaders who would be going through that crisis.
This will be super valuable.
And so in a record time, we set up, actually, we prepared a program, and I'll try to get you through a little bit of some of the learnings and some of the insights that we got and that we try to share with our customers, but customers around the world, of what we can do in order to successfully, or let's say, be more successful in leading through the crisis of the COVID-19 crisis. So to bring you a little bit actually into the spirit of what has happened, I'll show you a little bit of this video. I know that many of you maybe are not able to hear the audio, sorry. But this happened actually a few weeks already in the lockdown of the country. And this was a little bit a way of sensing experiencing the sense of community and showing the sense of community of the Italian people and the positive spirit of wanting to go through the crisis. It's only a few seconds.
It was a very powerful moment. It inspired a lot of people watching from away, from elsewhere, showing the resilience of the population.
Well, I must tell you, it has been, and it still is. Today we are in our 6th week, for most of us, in our 6th week of full confinement and working from home. We are not even allowed to go out for a walk with our kids. If you're lucky, like myself, I have a big garden. If you're unlucky, like most of the people, you are just sitting in a flat and you're sitting there since 6 weeks working from home, right? So that resilience is really not an easy thing that, to come up with, but we try to be positive. So let me bring you a little bit and walk you through a little bit of the timeline of the events, what has happened in these weeks, or at least in the first weeks. And I'll try to give that also with a sense of stages, because those stages are incrementally more complex in the resilience of people and in the challenges for the people. So in February 21st, we had our first cases that became evident. And already on Sunday, the 23rd, the government decided to shut down 11 towns, 10 in Lombardy and 1 in Veneto, completely shut down. So people started understanding something particular and special was happening. We all knew about what had happened in China, but we started understanding that, my God, this is probably going to happen in Italy as well. But still, it was, confined in one region, in one area. Soon after less than a week or less than 10 days, all schools and universities were closed. After another few days, the whole of Lombardy and 14 other provinces in the north of Italy are in full lockdown. And in another 2 days, the whole of Italy is put under lockdown, and all shops and services are closed, except very essential services, grocery, pharmacies, drugstores, and very few others. In another 10 days, we get into further restrictions, and even all manufacturing plants, everything that is not strategic is put under lockdown. And that's the third stage. And the final stage, actually, and unfortunately, we are not there yet, but we have been looking at what has happened with our colleagues and clients in China. There is another moment which is going to be, or another phase which is going to be quite critical, is how are we going to get out of this crisis, right? And when things are going to run more or less smoothly, what is going to happen, right? Now, the approach we have in BTS is we believe that leadership is relentlessly contextual. So what we try to do is understand what are the pivotal moments that leaders are faced and challenged with, and what do great leaders do during those pivotal moments. And we try to isolate some of those pivotal moments for leading in a moment of crisis, and we try to make them available for leaders around the globe. So basically, we identified, there are many more, but we identified 5 pivotal moments. The first one, and that follows the stages, is confusion. People start understanding there is chaos. What is going to happen? What do I have to do? Do I work from home? Do I go in the office? So as a leader, you want to communicate, and you need to communicate to your people, and you want to say things, but you really still don't know what is going to happen. So what do you do there? First moment. Second moment is you start having clear instructions. You're going to work from home. This is changing the way of working. Although many of us are used to working from home, but one thing is working, 1 day a week from home, or 1 day every now and then from home. Another day is working every single day from home, with both parents there, maybe with kids around, with completely different cadences and structures and processes, right? Then the crisis goes on, and actually you start realizing that this is longer than you would expect, and you're working actually longer hours than you were expecting, and actually the business is completely disrupted, and tensions start arising, and it seems like you're spinning, on empty, really. How do you, as a leader, deal with those frustrations with your people? Then, another one is, this is going on for several weeks, and people start to go in that certain kind of state, mental state that we call meltdown. You must have been hearing about the meltdown, right? Now, how do you start dealing with your team members, your people that are getting into that kind of meltdowns? And maybe, in the beginning, you're seeing the things are in the news, but as time goes by, you feel that COVID is getting around you, right? And I'm sorry to be, to put it dramatic, but in the beginning, you read it in the newspapers alone, or you see it in the news. After weeks, maybe a friend, a colleague, a relative is directly or indirectly impacted. So things, put them all together, they create a little bit of pressure, right? And then as we get out of, and as we suspect we will get out of this crisis sooner or later, how do we get into the business again, with what kind of mindset, and with how do we get into our business relationship that we are going to deal with what kind of mindset?
So I just want to interject that this is phenomenal. And your Italian and your English is fantastic, by the way. But I want to say that for us, it's the patient. It's the patient who may not be comfortable committing to a procedure that may put them further out of work for a period of time. It may actually that we may not even have a huge resurgence. We're concerned about a resurgence of work to be done at the end of this crisis. Your point is that in our world, these folks may not be quite ready to commit to a prolonged recovery period. Just wanted to frame that discussion because this is really fantastic.
And Stefano, I'm sure that some of these insights are useful for you and your community and the DOCSF community around, because many of the challenges, you may frame them in another way, but they're going to be challenges for the medical system, but as well for as you deal with patients, right?
Yeah, absolutely. Great points you're making. Thank you.
So let me go on. So basically what we did in record time, we created this program, and what we tried to understand by talking to our customers and clients was, what do great leaders do in these moments of crisis? And what can we learn from that? And the second thing is, how as a leader can I gain empathy for what our people feel and practice ways to serve them better? This is what we tried to distill, in the program. And how did we do that? We did that with, actually, I'll get to that in a moment. We tried to identify the core motivations and needs in a moment of crisis. And we identified there are three main motivations and needs in a moment of crisis. A need for empowerment. People need to feel more in control of what happens to me and around me. People feel they have the need to add value and to be constructive and to have the capabilities to act in that moment of crisis. And finally, the need of community is super strong in that moment of crisis, more than it is before. And this is an incredible learning that we have. You know, when we're all in conference call all the time, you know, Zoom and whatever. Whenever now we are with our colleagues, you know, we dedicate some time just, you know, for a chat. We really feel, you know, happy to see our colleagues now, because we're connecting with each other much more than before, right? And that is happening to all leaders in all corporate world, and most likely this is happening to you and your community as well, or this is going to happen, unfortunately, in this moment of crisis to you as well. So basically, what we did, this slide is maybe a little bit, you know, too much wordings, but I'll try to talk it over. We created a program, a webinar, a 120 minutes webinar, where participants would be experiencing what it means to lead through those pivotal moments, and how to deal with those challenges and situations, and what kind of choices are the best choices that you should make as a leader in those moments.
I'm going to interrupt for a second because I'd like for you to define what a simulation is. I've been fortunate enough to be familiar with it, but what do you mean by simulation? What happens during a simulation?
So it's unfortunate, but you know, because of time constraint, I cannot show you, and I could not share, of course, how it works. But just imagine that we are designing a storyline, and we are making people to get into scenarios, which are those pivotal moments that we discussed before, and get them a feel of what is happening in those moments, and then they're confronted with different options and choices and trade-offs. And they're measured with different impacts, actually, and impacts and metrics, leadership index, employee engagement, productivity, sustainability of the business, and whatever kind of choice that you would be making, it has an impact on some areas more than others. Think of it a little bit like, you know, the flight simulator. I think the flight simulator is the best analogy. A flight simulator, it's a learning and training tool for pilots, not only for ourselves with a PlayStation or whatever kind of device we're using, but for pilots, it's a very it's a regular way of practicing the right behaviors in any kind of moment, which can be a moment of emergency or crisis or whatever kind of unknown moment. So we have leveraged that kind of methodology for leadership as well. So we put our leaders or leaders from our customers in the situations that are challenging, and we make them practice what are the best choices, the best decisions they can take and they can make in those moments.
So just to clarify, so what I heard you say is you put these leaders into a situation, they have to make choices. Based on their choices, they see an outcome. They then react to that outcome, make more choices. And so they can see what happens based on what decisions they make, but then they can repeat it and make different decisions and see virtually experience a cycle so that they're ready for the decision making when it actually happens because they've experienced it already. That's the whole idea of simulation, right? Like flying a plane.
That's right. That's right, Stefano. And think of it from this practice perspective, and think of it from this perspective of looking already to a future state and preparing for a future state. Fantastic. Or a possible state, right? And that is very powerful. That is the way. That is one of the distinctive methodologies that we use in BTS. And the name BTS comes actually from the original name was Business Training Simulations, and then Business Training Solutions, and then it's just plain BTS. Now, if you allow me, I'll just continue, Stefano. Yeah. So basically, the experience is not self-paced, but it's guided and led by a facilitator or a professional coach, so that after every of those choices and feedbacks that are provided by the simulation, there is moments of insights and know-hows that are delivered together with tools, leaders, to be able to apply those learnings back immediately and as fast as possible to their ordinary life as go-dos, as we call them, right? I'll try, Stefano, and for everybody here, I'll try to get you maybe a little bit of insights about some of those tools, and hopefully that those can be useful for you and for your colleagues as well, if that's fine for you. So if we recall, these are 5 of those moments that they would be simulating of course, with a storyline, and this is just a very short outline of it. And think of it that every one of those has some learning points. So in the first moment, remember, you are in chaos. You just got known that you are going to be in some kind of strange situation with the COVID, and your people are confused. What do you do? One of the outcomes is don't create, or one of the learnings is don't create false hope, and help people to lead in uncertainty. That is one important thing that we want to have with our leaders, or for leaders to be effective. What typically happens in any kind of state of our life is we typically have some things that we feel are under control, the zone of certainties, and some things that we are completely powerless against. I don't know if the fact that OPEC is raising prices of the oil or decreasing. I mean, we don't have any control of that. Now, what happens in a crisis like this is that the zone of powerlessness increases dramatically. So what we try to help leaders, and what we try to help leaders to do with the simulation, for example, is to enlarge the zone of uncertainty and to teach them how to lead in it, to be more comfortable with it. That is one insight that we try to give, or one learning that we try to give to people. The other one, in moment number 1, is, I don't know if you know the story about the research that was conducted by Harvard by Harvard some time ago. They asked people if they would find $20, would they prefer to find $20 at one, or $10 one day and $10 the other day? And most of the people said the second one. And as an opposite, if they would lose $20, would they prefer losing $20 all at once, or $10 one day and $10 the other day? And the answer there was the opposite, all at once. So another important thing in this first moment is how you communicate the information and the news to your people. Communicate as much as possible the bad news in a transparent way all at once. And because of the way our brain works and frames events into stories, communicate good news over time, and better yet, try to create a sense of empowerment with good news over time. So what can you do? For example, how can you help your customers? That was for our environment. How could as a leader, can you help your customers move solutions from face-to-face to virtual to digital, or whatever kind of hook you may have, your values, whatever it is, but try to hook some positive news there. I'm speeding up because I see that we are a little bit, maybe, I don't know if we're late or not, but I'll try to get it a little bit fast. As a leader, our role is to help people to feel able to lead in uncertainty. That is one learning and insight that people started experiencing in this first moment. Then moments 2 and 3 is things are locked down, and you have to help people to understand the importance of connection and to empathize with the frustrations and the emotions that people feel in the anxiety of the crisis. That was another takeaway that we learned that great leaders were doing in our customers' environment. What is needed for that? People need, what typically breaks relationships is how people see each other, what they hear from each other, and what they say to each other. In a moment as a crisis, people need to be seen. And it is much more difficult to be seen in a moment of isolation or in a situation of isolation compared to a moment of proximity. And tendency of leaders is to give guidance, to mentor, to give instructions, so to speak. But what people really need in a moment of crisis is to be seen, to be heard, and less to be spoken on. So create connection so that people don't stay isolated. Create a lot of connection. And I think, Stefano, these are takeaways for any kind of operator, even medical operators, not only leaders in corporate world. So
I'm going to ask you a quick question there. So I'm going to ask you a very quick question. You can answer yes or no. Are you talking, when you see seeing, are you talking that people want to see their leader, or they want to be seen by their leader? Who are they being seen by?
They want to be seen by the leader. So if I'm an operator, I'm having a problem, I want my leader to be close, even if it is not face-to-face, but I need him to look at me and to just listen to me and, to be comfortable to be with me, not just to giving me instructions on what to do and how we be rational, etc., etc., etc. Okay.
Thank you.
Then, as we're saying, we are 4 or 5 weeks into the crisis. People start getting into meltdowns. You know the story of trigger events. Trigger 1, trigger 2, trigger 3, trigger 4. They create stories in the heads of people, and people start going into crisis, frustration, anxiety, meltdowns. Those are the moments where you want to recognize emotions. And the learning point there is leaders, especially leaders in corporate business, in corporate world, are not comfortable with dealing with emotions. They're comfortable with procedures, processes, instructions, leading, as tough people, right? Now, the teams, they are feeling a lot of frustrations. What you want to do there is we learn from our clients, and we teach this actually. This is actually a methodology that our coaches use. We teach them to be comfortable with the emotions, or actually to deal firsthand with the emotions that the people are feeling. What are the issues? Dig into the issues, because by uncovering the emotions or making people feel comfortable with their expressing the emotions, you very often, as a leader, you understand what are the deep issues around the problem of a person, which is very different from another one, as everybody is facing different situations. From any home, it's a different situation. Then you start understanding what are the options, and then you start making choices. But firsthand, make yourself comfortable with dealing with emotions and become resourceful by applying this ETC sequence. I know this is going very fast, but I wanted to share with you just a few tools. And then the last one is, as we are stepping out of the crisis, and this we learned from our Chinese colleagues who are stepping out of the crisis. I just got a video this week from our colleagues back in the office, and they were so happy being back in the office. So we hope this is going to continue this way. The world is going to be very different than before. We all are aware of that. But that means we also have to change the way we are going to think and talk and act with our customers or whatever is our stakeholders, our patients, whatever it is. So I don't know if you know this one. If you look at this picture, I think everybody of you, Stefano, what do you see there?
Oh, sorry, ice cream.
Ice cream, exactly. So this is, in neurosciences, this is the way our brain works, right? We take shortcuts, and that's helpful because shortcuts help you to go faster in your decision making. The shortcuts is the way our brain creates patterns of certainty in decision making, right? Now, when we are young, I mean, think of it, this is drops of experiences that we make in our life. And we are, as children, we are very, very, very flexible to take things as they come and to be very creative. As life goes on, we start creating what we call rivers of thinking, right? So we start being a little bit more constrained. And as those rivers of thinking and we become more experienced and we become, more, confident of how things go in life, this actually constrains us even more. So basically, as we come out of the crisis, we are all very confident that things are not going to be the same. This means that we have to rethink the way we act as a business, as an individual, as a person in our society, as a medical operator, as an orthopedist, whatever. But most likely, things will not be as before. So pulling it all back, remember these were 3 of the core motivations that we identified in a moment of crisis. Now, this is a little bit, a recap of the learnings that we try to provide leaders. And actually, we are very happy because this week we started delivering those seminars around the world. We had our first seminars already in the US, in Australia, in Europe, and there, people are paying us a tribute for thanking us for giving them already kind of a fast forward of what is happening in the crisis. And that's it for me, Stefano. I hope I have not been too tedious for yourself and all of your attendees.
I think tedious is the wrong term. Everyone's riveted to their screen listening to your speech. I thought it was outstanding. I know I want to go and review it again because some of the graphics were so powerful. The whole question around the role of the leader in a time of crisis and how it's turned upside down was phenomenal. Let's talk a little bit more about the leader that's uncomfortable with the empathy side, the leader that's much more comfortable with numbers and spreadsheets and negotiating advantage against some other company, as opposed to turning around inwardly to their organization to speak and hear, probably most importantly, or feel like be heard to their people. Tell us a bit more what you teach your leaders in that context.
So this is a little bit, that aspect of getting out of your comfort zone as a leader. I mean, think of it. And I'm dealing with corporate leaders. So most of those corporate leaders think of, that kind of image of the Gordon Gekko, successful people, I'm not going to cite any company, which is of course unfair, but think of, for example, the bankers, the bankers are, and I have huge respect for the bankers, but think of them, being very used to lead out of authority, out of, successful way of leading through their life. And then this happens. And the most important thing when this happens, Stefano, is take away that mask, take away all that certainty, and take away all that that comfort that you had from knowing your processes and your instructions and your spreadsheets and whatever, and getting into the understanding the feelings of the people and what they're facing in the moment that they're working, both from home, maybe 12 hours a day, in anxiety. Maybe some of the cousin or a nephew is in hospital in intensive care. Both husband and wife, they're working, one in the living room, the other one in the kitchen, children around. They're super frustrated on conference calls in those conditions. It's not important to say things to people what they have to do. You have to get to the feeling of the people and understand what are they sensing. I'm not hearing you.
Sorry. Let's take that one step further. And you talked about a meltdown. So you're about 2 weeks ahead of us in the United States. And even in New York, it's still the 2 weeks into being locked.
I think it's even 3.
3 weeks ahead of us. So this is new. I don't think, and maybe I haven't been listening, but I have not heard of this concept that happens as it's completely obvious if you think about it. But there's a moment where we go into a meltdown mode, and then you move the way.
It may happen. It doesn't necessarily, but it may.
Yeah, and then what's the trick if you see that happen in your organization, your hospital system, in your group, and you want to address it as a leader? How would you do that?
So typically what we would do is, you are the leader and a person in your team is going into a meltdown. You would immediately go into the rational area, right? And say, hey, no, but look at this. I mean, the things are, and blah, 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 right? In that person, I mean, the way the trigger events happened for that person created a story, which is, of course, self-sustaining and is giving the confidence to that person that something is worse than what it really is. Now, before getting into the rational part, you first have to make that person vent their emotions, make that person feel confident in getting out of that anxiety zone first, okay, the frustration. So that's why we say the ETC, the emotions first. And typically, if you help that person, if you step and dig into that a little bit, and you start understanding what that person is telling you, and you rehearse or you speak it back to that person, what you're hearing, perhaps that person autonomously understands that the way you're framing it is probably different than the way he or she has really framed it in that trigger, with those triggers. And only in that moment, Stefano, only in that moment, you're muted, only in that moment, what happens is the person starts really rationally understanding that he or she has more choices that he or she was thinking of.
No,
so
I think that's
this is a deep
very, very helpful.
Yeah,
very helpful.
Sorry.
So last 3 minutes is I want to talk about the concept you brought back, which I thought was very interesting. That the assumption is that when a lot of people have this in their mindset, I think, and maybe I count myself in that group until I heard your talk, that when this is all over, it's kind of back to a version of normal. Whenever I say nothing's going to be normal, the assumption often is we have to catch up. But your point is, no, not so fast. This environment may be not ready to return to normalcy because of various issues relative to their ability to be, they don't feel ready for normal. Can you talk to that a bit more?
Okay, I'm as a person, as an individual, as a leader for my organization as well, I wanted to make myself also a personal opinion, not only what the government says. So I've been, I have a responsibility for the people I lead in Italy. So I needed to research and I needed to understand what was going on. And you have very different researches and scenarios that are being identified and crafted at the moment. So I'm not a credible source, but we all agree that life probably will not be exactly the same as before. Now, how different, we don't know. But some scenarios depict that probably we have a weak chain in our society. We have some weak chains, and most likely, if you look in the last 10 years, we had 3 pandemics. This is the 3rd major one, actually the 4th major one. We had the SARS, the MERS, the other one, I don't remember how you call it in English, and then this one, COVID-19, in 10 years. And somebody is saying probably we have to live with more coming up in life. So who says that maybe we are not going to learn on maybe a little bit more of social distancing as a normal way of? Or who says that people are not more confident now with making even more teleconferences and working more from home? So many things in our work patterns, in our life patterns may be disrupted. Now, in any case, we are going to go after this crisis. The direct consequences of COVID is going to be most likely a world global recession. So that is not going to be very normal. But even though we're going to go into a normal way of living, most likely some things and perceptions are going to change and are changing already. That's what we are seeing here. And this is my little contribution.
Listen, Gianfranco, we are very grateful for your contribution. I found that to be an extremely instructive, thoughtful, extremely well positioned and put together segment that I think will be very useful to all of the people listening to this symposium, because no matter where they are in the world, the issue is fundamentally a human one, and what unites us as humans, we tend to behave similarly, and thus I believe that what you've taught us today is widely applicable, and I suspect that it'll be widely shared, even if for people who may not be in leadership positions with their leaders. Please go and watch this video with Gianfranco. I think it's going to be really great. So with that, I want to thank you.
Thank you all. Thank you very much. Very kind, and thank you for inviting me, Stefano. It's been a real pleasure. Now I'm going to open a bottle of wine, and my weekend is going to start, hopefully.
Arrivederci, Gianfranco. Grazie.
Andrà tutto bene. Everything will be okay. Ciao.
Hashtag. Ciao.
Hashtag. Ciao.
Well, welcome. How is everyone? Welcome to COVID-19, the Orthopaedic Response. This is a production of DOCSF in partnership with UCSF. I'm your host, Shauna Butler, and we are so thrilled that we are joined by the American Academy of Orthopedic Surgeons as our global convener in bringing together a global audience to really help us address and think about this rapidly unfolding pandemic and all of the interesting challenges that it creates for healthcare, for our patients, for our communities. And in this particular instance, we're going to be focusing on the interesting challenges that it creates for our professionals, our healthcare heroes, the people who are on the daily interaction in helping us to manage those folks, support those folks who have been diagnosed as COVID positive. And I am so grateful to have Shoshana Ungerleider here with us. And so Shoshana, I just want to say hello and say have you say hello to the audience. And by way of introduction, you are an internist. You have a focus and a practice in palliative care. And where I fell in love with you is all of your work on the Endwell project as the founder of that, and thinking about this bigger, broader global conversation that we need to have that we're not having on how to reimagine and redesign end-of-life care and end-of-life experience. I don't know that we have ever seen a moment where we're hitting peak end-of-life type of situation, and we are seeing a set of circumstances that is this perfect storm of situations we never imagined, and I don't think that we were necessarily prepared for. You recently wrote a piece that was published in Time magazine about end-of-life decisions in the coronavirus era. Can you go ahead and share with us what your thoughts were about that?
Well, thanks so much for having me. This is I don't think I've ever spoken to a group of surgeons before, so I feel really honored, and I just want to say thank you. Yeah, I mean, absolutely. As we all know, this is an unprecedented moment in history, I think, for everybody, and for sure in medicine. And so I am trying to do what I can as an internist and somebody who's, I guess I consider myself an advocate around serious illness and the end-of-life experience, not just from the healthcare side, but also sort of thinking about it, culturally, the stigma around talking about death and dying, our own mortality, normalizing hard conversations, not only among healthcare professionals with their patients, but society at large, and just how important that is now more than ever. So the time piece, which, gosh, we were so thrilled. I co-wrote it with a psychiatrist colleague of mine, Jesse Gold from WashU in St. Louis, really talking about the need, the urgency right now for everybody, including healthcare professionals, to be talking about their own wishes related to end of life, to fill out an advance directive, to assign a healthcare proxy in your own life that could speak for you if you can't speak for yourself. We're putting our lives on the line every single day, as we've been called to do, when we've signed up to do as physicians. And so, what does that mean? What should that look like? What are the questions that we need to be pondering for ourselves, and then sharing with the people that we love? And we talk a little bit about this idea that potentially, with limitations in beds in the ICU and ventilators in staff, are we going to need to be rationing care? Something that I can't even fathom doing. I, of course, was never trained in how to think about that from an ethics perspective, and what are the protocols we can put in place if we do in fact have to do that, to take some of the burden off the individual providers and create standardized protocols around it. So happy to dig into any of that with you now, Shauna.
So we've got a pandemic of a deadly virus, and we also have a pandemic of anxiety and fear. And there is the fear, the public, the fear that they're experiencing, institutions having anxiety, our leaders trying to manage that anxiety. And my experience as a clinician, we always think about, let's talk about our patients first. I think in this moment of time, we need to talk about our care professionals first. And you have spent a lot of time. What I so appreciate about what you do is you give a language and a vocabulary to help us have difficult, sensitive, tender conversations. And so can you, within the work that you're doing, and particularly with the psychiatrists and the folks who are really helping us to manage our emotional well-being, what are some of the things that you're hearing that care professionals are experiencing? I mean, on the levels of, first of all, their personal safety, their families, their colleagues, the people that they're supposed to be taking care of, and then the community. So talk through what those emotions are and what you're hearing.
Yeah, for sure. I think I would first, want to call out the fact that, all of us know, but we don't talk about the fact that medical education, no matter if you trained 40 years ago, 20 years ago, 10 years ago, or even you're just now out of training, that there is an institutional culture around being strong and tough and really suppressing any emotions that would indicate vulnerability. And especially, I have to say, among surgeons, So I think that it puts us at a very unique disadvantage right now in a moment in time where everyone is scared. I don't care who you are, how old you are, if you're a man or a woman or something else, you really, everybody is feeling incredibly scared to go to work every day, to be in contact with their families, to see patients. And again, I think we need to call out the fact that this is absolutely unprecedented. We are absolutely, in every respect, completely unprepared for this moment in time. So what do we do about that? I think, I can speak for myself and for my, professional colleagues and friends in medicine. We've been discussing on Twitter, on Facebook, over, FaceTime, that we are all so scared. And we put on a brave face every day and go to work. I'm lucky right now in that I'm getting to do telemedicine from home. My colleagues and many of you are having to truly be out there face to face with patients right now. So for me, I think it's incredibly important when I have those feelings of fear and anxiety that well up in funny ways, where I feel like, oh my gosh, am I getting short of breath? Do I have fever right now? I'm checking my pulse to see if somehow I have been, infected and thinking, could this be COVID right now? And it's actually, at least in my experience, it was anxiety. It was this feeling of fear that I had stuffed down because I'm a tough doctor and I got to be strong for my family. And so I think, first and foremost, trying to name, some of these feelings, I think is truly the first step here. And then I think, of course, being that there is so much fear out there, the question right now is how do we channel that fear, that anxiety, maybe some of those feelings of betrayal from the system, and anger into being productive, and showing up for our patients, which we're being called to do, whether we signed up for it or not, but we're in the situation nonetheless. It's reality. I think that, it's just a very unique moment in time for us as a profession. And it's, again, what we do with those feelings that are really gonna matter right now.
So you've named that it's really important to name it, to say, this is happening. And this is a feeling that I've got that it's legitimate. I listened to an interview earlier today with the former Fed chairman, Hank Paulson, who led us through some terrible economic times. And one of the things that he talked about was, in order to get through it, he said that the people who did the best were those people who stayed busy, who confronted what those fears were. And so what are the action items that you recommend to colleagues to help? I mean, once you've named it, you've said this is normal. It's not me. I'm not weak. Mm-hmm. What are the actions to take to manage the fears? Mm-hmm.
Well, I think also challenging for clinicians is to reach out to our friends, our colleagues, maybe our families, if it makes sense, to share how we're feeling. And
we do not have a culture where we say, put your hand up and say, right, I'm not doing okay.
That's right. No, exactly. Although I would say that right now, that is so critical for us to support one another. Often, clinicians don't feel comfortable taking their work problems home and talking to their families. It's on all of us to build communities of support and networks, because we're all going through this. We're all having these same emotions, whether we're naming them and talking about them or not. I think that is really, really critical. I mean, for me, I have channeled a lot of my fear and anxiety into journaling, into writing. So I want that's how that time piece sort of came out, was I just sat down one Saturday and I'm not a writer. It just poured out of me. And then I called up my friend Jessie, who happens to be a psychiatrist, who's very comfortable talking about her feelings, and said, let's flesh this out a little bit more. And, how can we share this perspective with the world? Because we think it's really important. And so for sure, I understand not everybody's going to sit at home on a Saturday and write something. But I think that can be really effective. And I think, the tools for managing, personal stress and anxiety, whether it's playing music, whether it's trying to spend more quality time with family, whether it's yoga or meditation, exercise. I got to tell you, I'm using my Peloton bike at home now more than ever. I love getting to tune out and watch those instructors kind of yell at me and listen to loud music. It's truly therapeutic right now, given that I can't really leave the house. So it's ideas like that, and really, recognizing that even if it isn't, in your nature necessarily to take a pause from your work as busy surgeons, that the time, right now it's so critical for us to do that, to take these moments for ourselves, even if it's, just a few seconds in between seeing patients, of taking a breath. That you're going to need that to sustain you. We're at mile 1.5 of a 26-mile marathon here. And as you all well know, this is, we're not anywhere near kind of the peak of this. This is going to be months and months and months. And so trying to build things into your day-to-day life that ground you are so critically important right now.
So one of the things that we've talked about over the last couple of days in talking with a range of orthopedic professionals, people who are in the musculoskeletal segment of care, is many of them are small business owners So in addition to, I've got to take care of patients, I want to keep them safe. What does my clinical practice look like? They're also employers, and they're dealing with the emotional stress of their family, their practice family, their professional family, and having so many people rely on that as their livelihood, as their connection to a broader community. So there's the clinical concerns and the clinical fears, and there's very much the business continuance, being able to, how do we stay in business so that we can support our community, our patients that need us, and the people that we employ. Are there, those are a specific set of concerns and fears and anxieties. Are you hearing from colleagues about this, and what's your conversation with them like?
Yeah, great question. I think, for me, I'm lucky as an internist that, people are continuing to need primary care. I've shifted to telemedicine, to telehealth, which I would imagine some surgeons can do, although, your physical exam of patients is probably a little more important than mine in terms of the more hands-on. Yeah. But in terms of triaging people, I think that can be a really effective way to figure out, does this person, need to see me in clinic, and sort of without having to come face to face to increase infection risk. But absolutely, and even my friends and colleagues who are business owners outside of medicine, of course, are trying to deal with the weight of the current, economic situation. I keep turning back to this idea that, while of course we have to keep the economy going and think about ways that we can stimulate growth and think about the future, we can't do any of that unless we can get this virus under control and figure out the ways that we can build a public health infrastructure through sharing of data, of testing, of thinking about isolation versus mitigation strategies that we're hearing about. And so, it's really tricky. And again, this is an unprecedented time that clearly I think we will learn a lot from as pandemics will continue to come. I think I keep getting back to this idea that we will get through this. The world's going to look a lot different, and I think we actually are going to be better for it in the end. But it's going to take a lot of creativity in the coming months and probably years to get, especially clinicians who rely on elective procedures to stay afloat. And it just speaks to more of this need to connect with one another and wrap around each other for support right now.
One of the difficult parts of these conversations, and like I said, we're not good at having these conversations. A lot has been shared in the social space, and what's interesting about the social space is that it's not too close. Somebody can put it out there and you're not really too close, but it is about our individual clinicians thinking very clearly about their own advanced directives, about what their end-of-life wishes might be like, making sure that they have their wills and their financial matters in place, thinking about contingency plans. And I don't know of anybody better in helping guide us in those really difficult conversations that nobody wants to look at that. What's the script? How do we get into that?
Well, as you pointed out earlier, the fact of the matter is that when we show up to work, when we're seeing patients face to face, we are putting ourselves at risk. And unfortunately, with minimal PPE right now, and so the concern is absolutely founded that there is a possibility that one could become sick from COVID. We've seen this across the world and potentially die from it. And so, to me, as scary as it is, this conversation about our own mortality is right in front of us, and it behooves all of us to reflect on that, right? And then, and think about what, how should I be preparing in this moment, if not for me, then just for my family and for my colleagues to be ready just in case, right? I'm going to take every precaution to be safe. But in the chance that you do become sick, you need to have somebody who can speak for you if you can't speak for yourself. And if you are somebody that would want to forego, an ICU stay or a ventilator, it's important to make those wishes known now. And there's a number of great resources out there. The Conversation Project is wonderful. It's one that I often turn to. The 5 Wishes is also an advanced care planning document you can find online. But what truly, I mean, obviously as clinicians, we know the nuances of the medical realities, so that we could talk more directly about that. But when I'm talking to the public about this, I think this question about what is quality of life, what does that mean for me?
Right.
What trade-offs am I willing to make or not for a chance to get better? And I think that now more than ever, this is just such a critical conversation to be having. We're learning so much about this virus and how it presents, the pathogenesis in young people and older people day by day, honestly. There's so much we still don't understand about why someone survives. Why does a young person become ill within a matter of hours and then succumb to this? So what are those predictive variables? And, in this very odd situation of uncertainty, maybe the one thing that we have choice over is our own, goals and values around the end of life. And so I do encourage folks to have these hard conversations, first with themselves and then with the people that they love. And then, of course, with our high-risk patients, if you are encountering people of older age, in your practice, and the question about whether to operate or whether they might want a ventilator, I think that it behooves us right now to be thinking about this in terms of outcomes and who is likely to survive an ICU stay right now, and bring those really hard conversations to the forefront with our patients, with our parents, with our grandparents, if they're still alive. This is really critical.
Well, and so let's shift over into that, because we have this this moment where we have asked people who are at high risk to shelter in place. They know that they are
Hopefully we've asked everyone to shelter in place at this point.
Well, yes, I was going to say, we've asked everybody. Thank you for, everybody needs to be sheltering, stay home.
Yeah.
But we've asked those groups of folks who have underlying conditions, our elderly, who are at the greatest risk, that what we're seeing. There's another part of that conversation that needs to be extended. The reality of this is that, okay, what are your end of life wishes? What does that end of life care look like? And we need to be better at having that conversation now, fast. We don't have a lot of time to be able to ramp up. And because we've got people coming into the emergency department, or coming into our hospitals, let's put it that way, coming into our care facilities, and this work hasn't been done. And a lot of times we're seeing really young folks, and it's a rapid deterioration. In that instance, and we're going to be calling upon a lot of people, how do you do these conversations at scale, and also in an urgent moment, and also in a moment where the outcome is really unpredictable? Have you, I know that people have been reaching out to you about that. So what are you sharing with them about that?
Yeah, so my friends at an organization that's been around for a long time called Vital Talk have put out an incredible resource. Obviously, it's online, and hopefully we can share it in the comments, but it is the COVID Vital Talk Palliative Care Guide. This is not just for palliative care providers. This is for any doc to broach the conversation in a quick, efficient manner. It essentially gives you a script almost. In a really thoughtful, caring way, right? For any patient to be talking about, I wish this weren't the case, but here's what I'm concerned about as your doctor. Let's talk about if you are unable to breathe for yourself, would you want X? Or it's just it's really a phenomenal resource. They've gone above and beyond and put this out weeks and weeks ago. So I encourage every clinician to just take a quick peek at it. It's not super long. It really, any physician, nurse, social worker can sort of engage quickly with the script that they've put forward. And I think it's so critical that we do that no matter the age of a patient. So for sure that resource, I think, it comes to, top of mind for me. And then I think, this conversation about the potential for rationing care and what that might look like in your institution. It's pretty wild to think about. It's truly hard to wrap your head around the enormity of that situation.
So Jim Fick posed a question that I was going to go to next, and I'm so glad that he brought this up. He says, isolation is a huge multiplier of fear. So how does one mitigate the isolation and fear while many of the surgeons are less active? I mean, that was one of the things that we talked about, is that as our orthopedic surgeons, and many of our surgeons aren't busy doing a lot of the same, they're less busy that they have been. Mm-hmm. How can they be helpful in managing the isolation, and then also just the additional stress on the rest of their healthcare colleagues?
Yeah, for clinicians who specifically are feeling isolated, either because they're in quarantine or because they're not working right now, it's really tricky for people who are used to being busy and fixing problems and being out there in the world. I mean, this is a very hard time. I think the more that we can rely on routines, so getting up, going to sleep and getting up every day at roughly the same time, refraining from substances, trying to build exercise or movement if you can't leave the house, into your daily routine, and connecting as much as possible with friends, with people you went to college with who you haven't caught up with in a long time, family members who don't live with you. I think that really, stretch yourself to be connecting with, at least one person a day that you haven't talked to in a while, because it's nice to just check in on them too. But the feelings of isolation are real and are very much anxiety producing. And so again, I think naming that is really important.
So one of the things about isolation that I find particularly hard in caring for people, mm-hmm. and particularly in people who are sick, hurting, and afraid, we have lost the ability to experience human touch. Mm. Have you got any thoughts about a surrogate or some other way that can provide the physical and the emotional comfort? How can we replace physical touch? Is there anything that can replace the comfort that comes from just holding somebody's hand?
I guess, my answer would be no. Unfortunately, I think, the other things that we can do, or we're getting creative with using technology, is what comes to mind. I would love it if folks out there have ideas about this, because I'm constantly, we hear more stories of specifically patients who are very sick and dying in hospitals where they're completely isolated and alone. Maybe have one nurse coming in once a shift. But what are the ways that we can provide comfort for those people, and of course for ourselves? For me, it's been trying to do a whole lot of video chat, no matter how silly my hair looks or how bad the lighting is. It's trying to find some, like you're saying, surrogate for that in-person experience. Yeah,
I was thinking about Yoko Sen, and thinking about that the last thing that we understand is sound. Mm-hmm. What are the last sounds? What are the sounds that are of comfort to you? And when people have been asking me about it, what I've been suggesting is, what are those songs that bring you comfort? Is it Amazing Grace? Is it Prince? Is it Let There Be Peace on Earth? Is it the Star Spangled Banners? What are those songs that, what are those sounds? So I don't know if that's something that's helpful. The other thing that I've been thinking about, the emotional toll, I've read from several nurses, particularly the ICU nurses, that the way we're cohorting patients is that there's an ICU room or a place where people who are COVID positive are there on their own, and they keep the nurse or the team in there. Mm. And they are the only emotional connection. And they are there providing the clinical care, but then also the emotional care, and then also being the connection to the family. Mm. And they talk about themselves feeling isolated and also feeling overwhelmed by the responsibility and the enormity and just the gravity of grief. Yeah. The way they have to wear that. And when they walk out of a room, just needing to just decompensate. I think that that's just fall apart. And I'm thinking that when I've talked with colleagues about this, they feel like they just want to fall into somebody's arms of comfort. And I'm thinking that how do we as a team, we're all in this together, what are the ways that we can be that soft place for somebody to land when they need to fall into an embrace of comfort?
Yeah. Well, I thank you for bringing up this conversation around grief, because I think that it's much bigger than grief for just, our loss of health and loss of lives. For sure, of course, it's grief for people who are dying and loved ones that we're losing, but it's also grief for all the changes that we're having to go through. The lives that we were living 3 weeks ago or a month ago are not.
Our lifestyle, our economy, our social interactions, our church and faith-based organizations, our proms, our graduations.
Absolutely. Grief for the lives that we thought we would be living, in the months ahead. So I think, high level, I think leaning into this grief and letting yourself feel it if you need to, letting yourself cry or scream or stamp your feet or whatever you need, and making space for that, I think is really important. It takes me back to this idea of journaling, if that's your thing, or even seeking professional support, leaning on your friends and your family for emotional support, because I think that grief is all around us. And frankly, grief is all around us all the time. But I think now more than ever, it's just, in our faces, it's palpable. I think for clinicians, I don't want you to forget about the fact that most institutions have palliative care teams. Granted, they're spread very thin right now. And as you know, palliative care is an interdisciplinary specialty that focuses on the relief of suffering for patients and families facing a serious illness. And in this new era of COVID, really, ideally everybody who comes in the hospital who's beyond just, a medicine ward should be receiving a palliative care consult. In reality, that's impossible given that we're already spread very, very thin. But a lot of palliative care providers have taken to telemedicine, even in the hospital, to try to see more patients virtually, to provide that comfort and support alongside curative treatment, right? This is not just for people who are at the end of life. This should really be thought of as a modality that can help support the patients, who are on vents and talking with their families on the phone if needed. And more specifically for providers, helping providers cope. These teams have chaplains as a part of them, social workers, people who really are trained in how to think about debriefing difficult scenarios and talking about the weight of all this. And so I would encourage you to look to those resources if you're in an institution that, most do have palliative care as a source of support through this time.
The other group that gets left out oftentimes is no patient comes in as an island. They have a circle of concern and a family around them. And these situations that we're seeing with end of life, where oftentimes the person that you love, that you lose, you are socially distanced, physically removed from them. There's not a way for you to gather as a family. That bereavement ritual, we don't have those. I mean, what we're seeing in Italy, where you can't even have a funeral, you can't have those gatherings. What are your thoughts on how we think about bereavement right now and supporting the people who are surviving and struggling? And I think about that from the standpoint of the clinicians that are here. They've got patients that they may be losing. That doesn't mean that they don't have support and that they want to extend to family members who are now isolated, alone, suffering, bereaving. Is there some suggestions that you have for this group?
Yeah, it's really hard. Grief and bereavement are, if they're not already all around you, I suspect they will be, both in your personal life and your professional life. I think, doctors and especially surgeons always want to be able to fix things, to provide a solution. And I think when we talk about grief, for our colleagues and our patients and their families, there is not a quick fix for other people's grief, for their sorrow. I think there's no specific way to provide any kind of solution. I think holding space and just being there for people is critical. The grief is going to take whatever timeline it's going to take. And especially now, I posit that we're actually going to have very prolonged episodic grief throughout time, because we aren't being given the chance for families to witness the death of a loved one, which is the start of the grieving process, to keep them from, being in a state of denial that it happened, which often happens psychologically. And then the next step being, they can't possibly have a funeral and gather and put dirt on the body or into the grave and start saying goodbye there. They can't have rituals like a Shiva, but we have in the Jewish tradition, or others where you gather afterwards for days and weeks to provide comfort and food. And so all of the things that we think of that have been created as these wonderful community building coping around grief and bereavement are gone. And that's going to, I think, create a lot of problems around complicated, prolonged grief, around depression. And so I think first, knowing that to be the case, how can we get more creative with solutions? I'm in a group of a bunch of interesting entrepreneurs who are trying to disrupt the grief and the funeral space right now, and think about how can we have virtual funerals, places of connection. How can we look to our mortuaries and places that provide the hands-on service for the body to be doing things differently. If you have a cultural tradition around burial and preparation of the body, how can we get we still can have those happen without putting more people at risk of infection? So it's there's stuff happening there, but it's a tricky space right now.
Well, I was gonna say, on the things that I've been doing on a personal level, is that I set aside a time each day to just feel it, to just say, this is just sad. It just hurts. And during that moment, I think about the people that I'm grateful for. I think about the people that I'm concerned about. I mentally go through and say their names. I make sure I go outside to make sure that I've got a connection with nature. I'm working on trying to get more sleep. I think it helps me to just manage the weight of all of it. I reach out to friends. I make sure and tell people I love them without any feeling ashamed, unabashed, to just say, I love you.
You just told me about an hour ago that you love me.
And I do. Yes. I love you. I love what you do. I love how you do it and how you show up in the world. And
I love you too.
Thank you. And like I said, I am feeling and holding a very special place for people I don't know and I haven't met, but their stories are universal, and the fear is something that we all experience. I think it's, like you said, it's really good to name it. And I also have a lot of hope, because they're good, smart people who are working really hard on all of this. And so I just wanted to say thank you for your time. Thank you for your writing about this, for giving us a language and a vocabulary, a place to go and talk and how to think about all of this. And I am confident that we are going, like I said, this will be our finest hour, and we will do things better than we have in the past, because of people who are leading you, like you, who are helping us to think about these things in the right ways and in safe ways. So I am going to close this session off with a great deal of gratitude and admiration. Stay safe, stay connected, and I will see you again.
Thank you.
Thanks.
Welcome to COVID-19, the Orthopedic Response. I am Stefano Bini, and I'm the host of this conference, and I'll be host today anyway, and part of the DOCSF team, Digital Orthopedics Conference San Francisco team at the University of California, San Francisco. And we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to address and rapidly respond to the dramatic changes to healthcare patients in our communities. We're grateful to have a global audience joining us in this discussion. And I'm extremely pleased to invite Dr. Michael Blum from UCSF. He's the Associate Vice Chancellor for Informatics and the Chief Digital Transformation Officer at UCSF. He's responsible basically for UCSF's strategic design and implementation of informatics and digital health capabilities in support of the clinical care we deliver as clinicians. He's also a professor of medicine and cardiology and passionate about wellness and the prevention of heart disease through a heart-healthy lifestyle. And Michael, it's so great of you to take time. I actually know exactly how crazy your life is right now, so you taking time out to speak to us is a real honor. Thank you.
Sure, Stefano. Thanks very much. Pleasure to be here with you all. I actually see some friends sending hellos already.
Awesome.
Yeah. So again, thanks for allowing me to be part of this. It's a great event. Stefano, we've been doing this since the first DOCSF.
That's right.
Event.
That's right.
Yeah. And it sounds like it's grown tremendously. So congratulations for that.
Thank you.
So I guess just to do a little level setting, let me talk a couple minutes about the Center for Digital Health Innovation, and then we can kind of segue into the current crisis and where we are, if that's all right.
Absolutely. So actually, Mike, before you start,
So
for the audience, just to show, okay, just for the audience, because they don't know what we asked you to talk about. What we asked about is a challenge that you're going to have, or you have as an enterprise, to deploy technology very, very quickly within the context of a crisis situation. And you're at the forefront of that. You're leading that change. So I want to hear the challenge you've had in that context. And we're going to frame it, we'll hear about CDHI, which is this amazing infrastructure you've built. And also, so we're going to see two parts of it: what you'd recommend for a smaller group, and how you see the challenges for a larger institution like University of California looking at these technologies. So now back to you, and I'll get out of your way.
No, I think that's great, because I think those are all tied together, and it'll make a little bit more sense if we kind of go back a couple of years. About 6 years ago, we started the Center for Digital Health Innovation. And you can think of it as kind of the enigma of running a startup in a huge university. So we're about a $10 million a year business running inside a $7 billion a year enterprise. And as most of the folks know, big academic centers are very slow to move, very slow to change, and to adopt new technology is very difficult. So we take that responsibility at the Center for Digital Health Innovation of how do we drive out these new technologies. And we work with partners all across the technology space. We work with very large, very traditional partners like GE and Philips, all the way down to startups in the space that we've worked with, several of them to implement new technologies at UCSF and help them do that beyond in the Bay Area. Our model is that we started with a small startup funds from the Chancellor's office. And since then, there's been no ongoing funding from the university. Everything that the center creates is off of partnerships with industry and licensing deals from technology we build. So we work with internal innovators to find technologies, build them out to proof of concept and pilot in the clinical environment, validate them, and then spin them out and have external partners build them out and market them globally. And we've licensed technologies, again, out to GE and out to smaller companies like Volt, who does hospital communications, and all across the spectrum. So we've done that. It's been really interesting and really exciting, and we've learned a lot over the 5-6 years. And I think that we're at a point now where that really the timing is good coming into this crisis, and especially to talk about how we come out of it. The other piece that has happened just the way things always happen is, coincidentally, we were finishing one of our strategic plans, our 5-year strategic plans at UCSF, and beginning the next 5-year strategic planning process. And the environment recognized that digital and digital technologies had become incredibly important to the future success. And digital transformation actually became one of the 3 pillars of the UCSF 5-year plan. So embracing digital technologies, digital transformation, innovation at scale is all part of the 2020 through 2025 strategic plan at UCSF. So I co-lead that with our CIO, and it's all about how are we going to transform our business. It's called digital transformation because that's the sexy thing now, but it really is about business transformation using data, using digital technologies, and how do you do things at the speed that consumer organizations do now. If you think about it, no one goes to rent a DVD anymore. Everyone streams everything. Banks were first with moving to ATMs. There aren't even ATMs anymore because you can do everything online. How do we get healthcare to that point is a big part of our mission right now. We also do a lot of AI development, and we've just successfully licensed one of the first on-machine chest X-ray apps to GE, who's deploying that across the world actually to look for ICU critical conditions like pneumothoraces and things like that. So we really span a broad spectrum of innovation. I think that the issue of digital transformation is particularly important, and it plays into this discussion really nicely because everyone thinks of it as just putting a bunch of digital apps in, moving things to the cloud, and those are certainly pieces of it. But what's critically important is that you build a different operating model and you build the infrastructure in your organization to think differently. You can't think of every new vendor who comes in as putting another project in space. You have to start transforming your thinking to product-based thinking, as is done in much of the consumer world. And you really have to change from how do we put things in that work for our ORs, work for our schedulers, work for our clinicians. You have to start thinking about product and how does that work for the consumer? How does that work for the patient? How does that work for the family? And look at those as end-to-end consumer journeys, or sometimes they're called consumer stories. And the whole thing broadly is called user-centered design. And you combine that with agile technology, so we get out of the old slow builds that we had with the EHRs, and we move into contemporary technology stacks and contemporary builds, so we can change things up much, much more quickly. Example, in the current crisis, the Department of Health came in one day and they said, there's COVID running around here. You now need to screen every employee who goes into your building for potential COVID exposures before they can go into the building. So the organization did what everyone does, came up with a list of questions that we had to ask everyone, and then we asked everyone all the questions as they came to the front door to go to the building. Well, not surprisingly, that made lines of hundreds of people trying to get into the building. So using our new infrastructure and capabilities, within 5 days, we had built and deployed an online screening tool that all the employees could do at home or on their way in, do it on their phone, then just kind of like a TSA pre-check, show their phone to the screener, and away they go into work. Those are the kind of things that historically took weeks and months to plan and do that we were able to stand up in a week in the middle of a crisis. Go ahead.
Let's talk about that infrastructure required to make that happen quickly, and what part of that could reflect the lean methodology. So for those people who may not be aware of what that actually is, but I think that sounds like a great story to tell, so people understand what an organization that has been planning and putting in place infrastructure can do in a situation like this. Of course, that being a lesson for the future for people who need to start thinking about putting those things in place. So what does that look like? How does that play out?
So I kind of alluded to some of the pieces of it, and some are vendor pieces, which I'll touch on. But the first thing you have to do is you have to get out of the thinking of, okay, this is occupational health issues, so let's go ask the occupational health people, and then let's get the regulatory people who know what the algorithm needs to look like. Let's get them together and ask them, what we should build. And then you get a project manager who starts working on it and does all the technology stack. That's the old way we would have done it. The new way is you have an agile team, which is interdisciplinary, which has technologists on it, has user-centered design folks on it, and then it grabs the people who are the subject matter experts and brings them all into a room and says, okay, describe the user journey for me. What is this all about? And in this case, what it's about is an employee trying to get into work and needs to answer a bunch of questions. And that data for the ones who have specific answers needs to flow into the occupational health work streams so that they can deal with it. And you start with it from, okay, that's going to be the user journey. What's the problem we're trying to solve? And the problem isn't, occupational health has to find these patients. The problem is people need to get to work. People need to get into the building. And so how do we get them through those pieces? And so we had the tool, we had the muscle, so to speak, in place that we knew how to get those teams together. We knew exactly who the people were. We had the designers, we had the UX experts, We already had the stack with the cloud that we could stand up and proof everything immediately. And by the end of, day 1.5, we already had pilots running, prototypes running. So the other piece is then you need someone who's going to, be able to deploy it, support it, and scale it to multiple locations. And in this case, we were already working with a vendor around patient-reported outcomes who had a lot of experience. And as we built and prototyped, they were able to move, to port that to their platform so it could stand up and have the performance that we needed to go ahead. So shout out to Conversa, who's a young startup. Am I allowed to do that? Can I do shout outs to vendors here? I'll keep it small. So they were fantastic, and we had the whole thing stood up in a week, and it's been up with essentially zero out time. We went from the thing not existing to screening 3,000 employees going through the doors a day. They were taking about 2 minutes, 3 minutes to go through the screening process initially. Now it took 8 seconds for them to go through the screening process. So I'm not hearing you, Stefano.
Thank you for saying that. I muted myself to avoid the background noise for you.
I thought it was supposed to be a lip reading.
Yeah, well, that's next gen. So what I say is that the way it works on mine as an employee is that I have a questionnaire, a chatbot questionnaire that comes through, basically runs me through the COVID platform. I then hit done, and then it puts a screen up on my phone, which I can then show to when I walk in the door. Right. And the screener just looks at it, 8 seconds, you've gone through the screening session, boom, you're done. And this, of course, is recorded in the cloud and tracked. And so that was the idea, right? How do you solve this? Is design thinking. And you may not know, IDEO is in the process right now, and soon after we're done, we'll be doing exactly that kind of protocol process to try to design think around some solutions like that. It's fantastic. The fact that in a day and a half, you guys had a prototype running, and again, to just remind people of what that process looked like, you brought all the key stakeholders in the room who had the appropriate knowledge base, took all other responsibilities away from them so they could focus on that task, gave them a whiteboard, gave them the time and the resources necessary, and they just went to town and came up with a solution and tested it, right?
Yeah, and it's been really a fascinating journey because, 3 years ago, we were just like everyone. We, bought stuff from vendors and followed their instructions to put it in, and we sat there and tweaked. The concept of product managers, not project managers, design experts, design thinking was all relatively foreign to us. And it's been a real fantastic learning experience combining the lean methodologies along with design thinking, how much more quickly you can stand things up and how much less rework you have to do as you go through these things by starting with these interdisciplinary teams and knowing what, understanding your goal. It's really fantastic, and it's been a great change for us. It's been interesting also to watch as these people who know very little about healthcare actually go out into the healthcare space and are immediately told, you don't know what you're talking about because you don't know healthcare, and no one wants to listen to them. And then as they build the relationship and people start to say, oh, well, that is interesting, maybe that is a better way of doing things, or they start asking questions about why do you do it this way? I don't understand why you would make your patient sit there and doing nothing or re-enter something. All the things that patients and consumers complain about, they start poking at those, and it's just incredibly refreshing. The other piece that is relevant, to this discussion is, so we built this thing and we just built it out of our own need, but now we're looking at how do we deploy this around the Bay Area to our affiliates and get them out of this mess. And it's gonna, the other UCs are looking at how do they take it up, and then the company is building it into their is already built it into their platform and gets to offer it globally. So it's nice to see these things that we just build out of immediate, quick need can then get disseminated without everyone else having to try to redo it.
Tell me a question, because I'm curious now. How has that impacted the perception of the work the CDHI is doing at the university level? Has the fact that you're being so successful now opened doors for you that perhaps in the past were maybe a little bit not fully open?
Yeah, I think that's definitely true. So historically, we worked, a little bit in a cave, and we're a little quiet. And even when we came out with the work that we did with GE that they're licensing at, it was still not something that people locally could really touch and feel as much. we started working in the self-scheduling place, and that stuff went up in pilots, and did a lot of work around referrals management, and that was out there. So small pieces of the organization started to get to see our work and started to say, hey, this is really, a much better way of doing these things. But it was really in small pockets. This is the first time that in the middle of a crisis, our teams stepped up and said, hey, we can do this. They knocked it out of the park. And I think that's going to lead to one of the things we want to talk about is, how do you come out of this? Bless you.
Thank you.
How do you okay there? You're not going to start coughing and get a fever or anything.
No, I think
there you go. So this gets to the point of, okay, the more we do of these kinds of of developments and quick implementations that work well, the more we get to be in a place where we say, hey, everyone's appropriately focused on this crisis right in front of them. I mean, this is right in front of everyone, and everyone's working to take care of the today problems, the tomorrow problems. The big problems that we look at are, at some point, things are going to change, and we're going to start figuring out how to try to work out of these. So good example is, we've basically closed all of our outpatient offices, and we've gone from seeing 1% of our patients on video, using video visits. We now see over, now it's almost 60%, 55, 60% of our visits are delivered via video right now.
Across the whole system.
Across the organization, yep. So, we were doing 10,000 visits a day. Majority of those got taken out immediately because of rescheduling. Well, now we're trying to bring the schedule back up and do them via video. So huge volume of video visits that didn't exist before. So we needed to quickly move from the old model to a new model, which is great. But as you think about the future, that's not going to go away. This is now kind of an entitlement in a way. People will say, hey, I can have a doctor visit without having to go wait in their, smelly waiting room, without having to go drive to the office and have horrible parking, without having to wait for an hour. People are going to want video visits. So they're not going away. So similarly, there are going to be other things that we're going to have to really, really plan for. And one of the biggest of them is, we're postponing hundreds of thousands of encounters, and those might be doctors, they might be office visits, or they might be imaging studies and referrals. So when we start thinking about how we're going to dig out of this mess, we're going to have hundreds of thousands of those, and there's no way they're going to work the old way, which would have been, call the office to reschedule, right? There'll be, weeks worth of waiting on the phone, and no one's going to do that. And the ones we want, who have a choice, will go to our competitors. So we've got to put in new tools, which we've been working on for a while, self-scheduling tools, chat bots, virtual care platforms, all those which were planned to go in over a period of years, now are going to need to go in over a period of months. And we need to start doing it now, because we can't wait until, the crisis is over. There are hundreds of thousands of scheduling events. How are we going to do it? That will never work. So we're starting to think about doing the planning, building the infrastructure to do that right now.
That's a really important lesson you just shared with us, is this idea that not only are we going to get back to a new state that's not going to be the same as before, but if we don't plan for it ahead of time, we may be caught flat-footed and not be able to respond to the demand in the way that patients want that demand to be responded to, right? And
so it's not only to be able to respond, but it's to think what the world is going to be like that you're going to need to be responding to, right? So, most people who are just looking at the crisis are like, okay, well, these people are going to start calling, and then we'll do the rescheduling. We'll move the people back into the call centers, and then we'll do the rescheduling. Like, that is not going to work. This world is going to be completely different when we get there. The volumes are going to be unimaginable of people needing care and wanting to reschedule things. And they're all going to be scared, and they're all going to be very unhappy, and they're not going to be wanting or tolerating the kind of waits they did before. So we really need to move to newer technologies and newer capabilities to make this stuff happen.
Let's do a quick shift. If I was an innovative group, small group, 20, 30 person group, something like that, I'm not university, I don't have the infrastructure in place, how would I think about deploying new technology in a time of crisis?
So it's a great question, and without all of the resources to do the baseline assessments, we spend a huge amount of time going through the companies who say they do things in the spaces, and everyone's got a real glitzy website and tells you how they understand the problem, and they have all these tremendous metrics of how they've reduced stays, how they've increased your profitability, how they keep people out of the ICU, prevent unexpected, unanticipated returns. So it's really hard. I'm very sympathetic to the smaller groups trying to pick which vendors and which products are real. That has been magnified, I'd say, like 50x in the middle of this crisis. It is amazing how many vendors I'm just getting deluged with. Vendors claiming they've already developed AI solutions to triaging your COVID patients, knowing which ones are going to get sicker, how to put them on the floor, don't let them in the ED, which ones are going to end up in the ICU in the next 30 seconds or 72 hours, ones that say that they can tell from a chest x-ray who's got COVID. And all these things are kind of amazing, because being in the middle of this, I can tell you that none of that is even conceivably possible, the level of precision that they're all talking about. But when you're in a much smaller practice, you don't have the time to do those kinds of validations. So I'm going to say, I think there are a couple of things. One is one of the great tells of how good a vendor is going to be is when you meet with them, you got to kind of get past the initial salesperson speak. But then when you meet with their people who are really principal in the organization, if they start the conversations with, I came from the consumer business, I came from the investing business, I came from the fintech business, and this is the way we do it. So if you guys just catch up to us, everything will be great. You should run away from them shrieking if they're going to be a core part of your patient flow. They might have some useful play if you're looking at doing a new financial modeling or you're trying to grow your business in a different way. But for core pieces of your patient care delivery, you've got to work with vendors who've been in the space and fundamentally understand the science and understand the flows of patient care delivery. So I'm not saying you got to work with one of the old guard companies who's been in the space for a long time, because they move too slowly and they deliver too slowly. But you need to interview these companies very carefully and make sure they understand the underpinnings of what you're working with, because it just doesn't work when they don't really understand it, and they're here to disrupt you, not to transform your business, but they're here to disrupt your business. I'm not sure that coming out of this, people are going to have much appetite or ability to tolerate a whole lot more disruption than we're having right now. So that's one of the things we spend the most time is how much are they able to tolerate the pace of healthcare, and how much can they move us faster without telling us that we just need to go break everything in the store.
Yeah, in a session I gave earlier, there was a great, I think, a great paper in HBR talking about the digital evolution that should be, it should be a way to get to a future state, but it doesn't have to disrupt your current processes. You just simply amplify them and help with where it can, and plug them in. But it's not like a complete disruption, or it shouldn't. If you do that, you're going to get in more trouble than you expect.
Yeah. There's one other point to make in there, Stefano, is also don't get sucked into the allure of all these things have to be incredibly cool, powerful, clinical, apps. There's a tremendous amount of value, and there's a tremendous amount of waste that we have in just the back office activities and in the patient flow activities. As much as many of the smaller practices have become more efficient, there's still huge opportunity. We've taken a huge amount of the cost of running the practice out just by doing things like automating faxing, things like that, and doing OCR and faxing, and silly little mundane things take a huge bite out of it. So look all across the practice. Self-scheduling is obviously incredibly important. More things you can push out to the patients. Looking at things, how can they report their incomes? How can their outcomes? How can they fill things out online? So you can take some of that administrative burden out. Those are, from a practice efficiency standpoint, much better than some really cool algorithm that tells you something right while you're trying to manage a patient.
Yeah, I was just thinking about our current pilot with Luma, which is a clinic referral management tool. The number of calls that has taken off our back office simply because the software reaches out to the patients and connects with them who want an appointment seems banal until you start doing the math, which we're in the process of doing. We looked at a year's worth of data when I calculated the cost savings based on just freeing up our staff from trying to find people to book an appointment. Is all automated.
Right. These days, no one answers the phone anymore, right? So it's like people who were doing robocalls using old technologies like, Televox. They're like, oh, we contact everyone before their appointment. We make sure they're going to show up. I'm like, no, you don't. You leave a voicemail at their home, which they never check, right? No one ever does that stuff, right? So you got to get to people's current technologies. And you free up the front desk staff, and you free them up even more by getting patients to use tablets in the office and not to have to, re-register people all the time. All of those things become huge savings, which improve the patient flow, cost of running the office, and patient satisfaction.
Let's pivot a little bit to leadership. How important has it been to your success to have the government association, the organization behind you at your back, supporting your vision and your ambitions, if you will?
So you can't
alignment. I'm looking for is alignment critical to success.
Yeah. So it absolutely is critical. You can make some progress trying to do this quietly by yourself, but particularly in a big organization, you run into too many barriers and everyone having their own way of doing things and a lot of resistance because this is just the way we do it. We don't really want to change. Many people don't see the reason we need to change. Even if leadership is really espousing, hey, it's time to change, we need to change. The big organizations are so many people that anyone can veto a change that you're trying to put in. So getting that alignment and continuing to drive that through is critically important. I think in smaller practices, it's somewhat easier because there's a much better or a closer relationship between leadership and the people who are doing the work. But the alignment is still critical. If you have a small number of people who are not on board with significant change, it becomes that. I mean, this is all change management 101, right? Knowing who your supporters are, knowing who your detractors are, knowing who's going to be neutral about it, and really doing the work to find the detractors. Because even in a moderate-sized practice, someone who's working to subvert the process will always mess up even the best plans.
Right, and that's absolutely critical. Tell me about. Let's say you've got the leadership to support you, you've got the vision implemented. What recommendation would you have to somebody who's trying to put in place a new technological solution and the challenges they may have in leading that change? How much resource needs to be applied to, and how to apply that resource or those resources to enabling that change and ensuring its success?
So some of the estimates are that the change management activity that goes along with any implementation is around half of the effort. You can't spend the majority of it on your technology, on your stack, on your software, and then leave a little bit for training or a little bit for change management. You've got to do, and using a lot of the lean methodology, working with the people who are in the practice, in the workflows, having them identify where the problems are going to be, having them come up with solutions, being part of the ideation, really gets you a lot further along in the change management because you've got them, on the side of the change instead of obstructing it. I think that's the surest way to have failures or to prolong the time until the thing can be considered successful is underselling the change management in it.
Yeah, there was a company that in their contract they were suggesting to us 2 weeks of support. I'm like, no, that's not gonna work. You're gonna have to stick around longer than 2 weeks until we're gonna be able to ensure that this product works as we go through with it. I think you gave us a really good insight into how somebody working within a healthcare system can work with an organization to create a product that could then be leveraged and sold out and create income to university. That was very well discussed. What I wanted to, just in the last couple of minutes, the idea of, I think you mentioned this idea of the patient journey, understanding the importance of the product-based thinking. It's very different. You described it already, but I think it's worth repeating. It's like we used to look at it this way.
Yeah.
When you think about it from the patient's perspective and their experiences as they go through it, has that been a useful methodology by which to bring everybody on board so they all look at it from the same perspective and looking to get to the same outcome?
So there are two pieces to that. The one which you were just touching on is that the language around it is incredibly important. People who work in our environment, they might be attached to the ways they do things and they might not want to change. But when you start talking about it from the patient's perspective and the patient's experience, well, the reason they work in our environments is because they care about those things, right? There's very little that's more important to them than how the patient does. And so it takes out the us versus them, the I want this and they want that. It gets to, hey, we're all here for the patient to make the patient's experience better, to make their health, more pervasive and to really take care of how they're feeling, not so much how we're feeling. And then if we work together, we can create an experience which is great for the patient and better for us at the same time. So you can start to really get people more. So an example is you think of things, chronic disease management, or if you're thinking about something like hospital at home, which are two big efforts right now, right? The old model would have been, we would have sent someone a blood pressure cuff and a pulse oximeter to just monitor themselves at home and tell them to then go to the EHR portal and enter their data in, right? So you're just sending this thing, they're getting a box, and then they're supposed to figure out how to work it, and then they're supposed to do something, and then they're supposed to enter some vital signs in. And then the doctor is then supposed to go know that happened miraculously, or they get messaged completely out of context that there's some data waiting for them, they're going to go search that. That's the old way of doing it. None of that worked. If you start from, again, the user-centered design, you said, okay, you have a sick person, you got to educate them about their disease, educate them why these pieces are important, and say, okay, now you're going to get this device, and here's how it's going to connect you to your care team, not necessarily your doctor directly, to your care team. And this data, they're going to respond to it, they're going to work with you around it, and if anything important happens, it's going to get to your doctor, and your doctor is going to, tell everyone what to do. So when you create that whole, user journey, and that's part of when you'll be coming to the office, when you don't need to come to the office anymore because we're monitoring you remotely, creates a much better story that's much more efficient for everybody all the way around.
Excuse me, I apologize. Let me ask you a little bit about what, we've got 10 more minutes, and you're going to go back to work, probably your workday is not done yet. What are the top 3 things that you're looking to move forward in the next, say, 2 weeks to get us ready for COVID-19 specific? Because we are now probably, we're not quite past the curve yet. So what are you thinking? What are the top strategic priorities for you as CDHI at UCSF that you're dealing with and trying to push through?
Yeah, so there are a couple pieces there. One is, really right in front of us is the COVID positive patients who aren't in the hospital. How are we going to monitor them? How are we going to track them? How are we going to know when they're recovering versus when they're getting sicker and do need to get into the hospital? And what are the the data points that we can use, and what are the biomarkers we can use to figure out when someone really needs to be hospitalized and is going to benefit from it. So a lot of that is technologies that we already have around patient-reported outcomes. Some of it are things we need to do much better with remote devices and hospital to home that I was just talking about. So getting those pieces up very, very quickly without having the luxury of building a whole new program around it, a whole new product around it, is creating a lot, some significant stress right now. We're probably, to be honest, not going to have the luxury of building it like we would want to build it, because there are already accumulating patients out there who need to be monitored now. So we'll fake it till we make it a little bit for the, first couple of weeks while we're building the longer term solution in the background. and choosing the vendor and choosing exactly what the flows will be like. Going past that is leveraging that experience into much better hospital at home and chronic care management in a more durable way and in a more scalable way. Scale is going to be huge here, because we're going to see far more rapid changes in what the expectations and the needs are in the community than we've probably seen ever in our experience in healthcare anyway.
Specifically, you're referring to chronic care management and pushing that outside into the home, you mean?
Yeah, I mean, so we've talked forever about we're out of capacity. We've got to get these patients out. We're really going to be out of capacity now, and we have to get, we're going to have to deliver more care. So I think if you look at it like care per unit time, we're going to have to be delivering a much higher intensity of care than we've delivered ever. Yet our physical footprint isn't really changing that much. So that's going to be one of the challenges as well. The other challenge that I think everyone's going to be running into is budget. We have no insight yet into what the finances are going to look like or how much federal bailouts will help. But one thing is that all of the patients that we make our money off of haven't been coming to the hospital for the last 2 months, right, or a month and a half. So the budgets are going to be challenging, and in the setting of very challenged finances, we're going to have to be investing significantly to put these new technologies in place. And that was, we were talking before we went on around how do you make the choice to invest in things in the middle of a crisis. And I was relating that I heard a great talk by John Chambers, who used to be the CEO of Cisco, who said that during the dot-com bubble and when it burst and everyone was going crazy in Silicon Valley about, what are we going to do? He used that as an opportunity to go around and make big investments and buy a lot of companies so that when he came out of, he knew that this would eventually unwind. And when he came out of it, Cisco came out as one of the global leaders, and that was what really cemented them as one of the global network leaders in the world. So I think it's important to think of it like that. When you're in the darkest of times and you can't imagine getting any money, you can't imagine how you're going to be able to put new technologies in, those are the times you actually have to be doing it. It's most important to do it so that when you come out with a very solid footing and you're able to accelerate instead of saying, okay, now the problem is really crushing me and I can't do anything about it.
Right, and you don't have the tools with which to manage it.
Exactly.
2 questions we'd like to get to. One, actually, another question we're talking about as we're getting ready in the green room is this idea of platform. And not viewing the EMR as the entry point for technology, but rather to create a middleware solution into which multiple apps can plug into, and the middleware is the only conduit to the EMR for its true data. Would you talk about that a little bit?
Yeah, I think that's exactly right. I think that the EHR, we spent a huge amount of treasure putting our EHRs in, and we've, put a lot of burden on our clinicians to populate the EHRs and the whole care team to populate the EHRs. And they're a critically important workflow engine and a critically important data source, but they're certainly not the totality of the patient experience, and they don't contain all the data. And more, as care is getting more complex, genomic data, things like that are rarely in a meaningful way in the EHR. It's very obvious that you need, systems of record, which is a lot of what the EHR is, but then you need systems of experience and systems of engagement. And those are 3 different layers, and you need all 3 layers for things to work, and they need to be interconnected in a seamless way. So that's to your point of you need integration engines, you need an integration layer. All of the sensors that are out should not be connecting directly to the EHR. They ought to be connecting to integration levels. And then a lot of times you're going to need to run analytics on that data that's acquired by these external sensors to decide what needs to go into the EHR. Spurious data, some data needs to be acted on immediately, and it needs a different methodology of going through or going around the EHR depending on how you have it set up. We would always want any critical piece of data to enter into the EHR and to be there recorded and hopefully kicking off a sequence of care. But sometimes it also needs to go to the provider's mobile immediately. So you need that whole integration level or engagement level where you can where you can act as you would. And a lot of the EHR technology is not built to really support that innately, so you got to build around it.
Yeah. One last question, then I'm going to try to wrap it up and contextualize this for orthopedic surgeons who may be watching this and to understand how does this apply to me. And I think that there's a lot of which applies. But Mike Ryan's asking, are you benchmarking with other academic medical centers on how you're dealing with COVID-19, but especially for technology? Is there communication amongst, I know about the UCs are communicating, but the question is it also outside of UC?
Yeah, we're talking to colleagues around the country, both to get a sense of how they're doing in general with clinical care delivery, and especially in New York, where they're suffering tremendously, to really keep ahead of things, and trying to learn from them as much as we can. We talk to folks, the other UCs and other care providers around how we can share tools, how we can share learnings and protocols that have been developed. We're also sharing, all the way to sharing PPE with them. So if we have more of something, getting it to them if they have more. I think we've been fortunate in the Bay Area. We haven't gotten really creamed yet by this thing. Everyone's hoping it'll stay that way, but everyone trying to hang in there and do everything they can to keep everyone afloat right now is super important. So answer your questions. Yes, we're talking to everyone around the country, finding out what we can learn from them, figuring out where we can help and where we can help others.
Mike, that was, I think, an amazing overview of what the work is that has to be done at your level in organization. I think you gave us insight into the complexity of doing a system-wide deployment of technology and how it can actually be done once you achieve alignment and you have the right methodologies to do it. Some of these new methods that came out of programming and computer science now applied to the way we do business and to turn things around quickly and effectively. You give advice to smaller practices that may not have these very large teams in place to put in place, but they also have smaller challenges. And one suggestion I might add to the group is even if you have a small group, you can identify a person in your team who take lead on these things, become an expert, like I have had the opportunity to do for our department. And Einar Shore as well is also in our group, also has that technology skill, and that allows us to allow one small group. We're a mini CDHI within the department, and other groups can think about doing something analogous. We talked at length about design thinking and its impact on how we can bring people together around the patient experience as opposed to people going to their beliefs and habits, if you will, around project. So with that, I'll call us an end. Can I thank you again, Mike? That was phenomenal, Michael.
It was my pleasure. Hope it was helpful to everyone, and wish everyone the best.
Thank you very much, everybody. Stay safe, wash hands. Don't do what I do, cough your hands. Terrible. Thank you, everybody. Take care now.
Take care. Good to see you. Bye-bye.
We are. Welcome to COVID-19, the Orthopaedic Response. It's a production of DOCSF and the team that supports that, and UCSF. I'm your host, Shauna Butler, and we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to help us address this rapidly responding and dramatic changes to healthcare, to patients, our communities, and specifically to our information and our data. And so for this session, I'm thrilled to have Herb Kelsey join us. The title of our session is Cybersecurity, Keeping Your Eye on the Ball Under Stress. Herb is the CEO and founder of Quantum Vault. Herb, you've got a lot of experience, like 3 decades or so, thinking about architecting our global information systems, thinking about how to keep our information safe, our identities safe, and increasingly, as we have rapidly adopted telehealth and telecare, virtual care, and having so many people go online at this point in time, we're seeing an increased need and demand to understand the hygiene around our data and around our technology. So we've invited you to help us talk about what our cybersecurity needs what we need to do to bring everything up to, we'll call it code. What does our technology stack need to look like in order for us to have safe and secure interactions in this format where we're using more and more telehealth? So how about if I bring your slides up?
Okay, that sounds excellent. Well, Shauna, first of all, thank you and the rest of your team for thinking of me and inviting me. I'm happy to be here doing this. I think the way that I would set it up is, yes, my background is in cybersecurity. I was the first CTO for IBM in cybersecurity, and I actually had the opportunity to be the chief architect at NSA. So this is deep in my DNA, if you will.
Yeah, I just want to say, if we're ever in this geopolitical nightmare and we need to parachute into some part of the world that is under a lot of intense issues, you're the guy we want to have as our flying as our wingman, right?
I would embarrass my daughter, who I think is listening, just to say that she does have a story about, what happens if a black helicopter lands on her soccer field at high school. But hopefully we won't have to deal with anything like that here.
Yeah, but if it does show up, she needs to get in it, right? Because it's coming for her.
Yeah, it's only for her. She needs to get in it. So yeah, I mean, what I think even casually, I think people are understanding that these systems are stressed, and they're stressed both at a practice level within the medical profession, but they're also stressed for your patients as well. And I think we're starting to see more people trying to interact via the internet, via these communication mechanisms. And there's some issues with that. And that's really what I'll cover. So I titled this a crash course in operational security, or OPSEC. So it's not a misprint.
I just have to laugh at the idea that you would call it a crash course. We're trying really hard to make sure our systems don't crash.
Yeah, well, and so what happens is that as things dismantle around you, you actually have to learn and evolve faster than it does. And so if things are crashing around us, then we have to learn faster than that. And that's really, so I'm very comfortable with the terminology if it helps people understand. So, we've got some.
Remember, this is a medical environment. We don't like crashes. Okay,
I understand, but we're going to have. So we don't like crashes, but we also don't like viruses. And
no.
The computer world picked up the idea of computer viruses. So we'll talk a little bit how to defend against that. So maybe I'll redeem myself.
Okay.
So the way that I framed this. And I only have 2 slides, folks, so hopefully there'll be some time for questions. But the way that I framed this is, essentially, what guidance would I give to someone, say, from the State Department, an ambassador who was going into a hostile environment with all their technology? So that's the frame for the talk. I did want to give the audience just a quick piece of background in terms of where I've intersected with the medical community and the government. So I did help define the HIPAA and high-tech standards. I've also had a lot of work with CMS and doing predictive analytics. And so that led me into this kind of frame. And then I'm currently working with the US government. They asked me to help support electronic security for voting. And now with the pandemic, they're asking me to see what I can do to support some of these electronic security activities more broadly. So that's what kind of leads me into this and makes me feel comfortable, at least trying to have a conversation with you about what we can do to better protect ourselves. So here's the slide. It's going to be here for a minute.
I like how it has so many pictures on it.
Yeah, I was trying to find pictures for each of the things that I was talking about, but I figured, since you were telegenic, we would be okay.
Yeah, thank you for
that. I wouldn't have to worry about the pictures. All right, so a crash course in operational security. So taking care of your digital health, taking care of that digital well-being is a combination of the people that you're interacting with, the technology that you have at your disposal, and the processes that you follow. And so what I'm going to try and take you through is a way that, from a personal perspective, you can better secure yourself and what's going on around you. You can also do this in a small practice. Usually, if you're in a very large institution, there are a number of people like me and smarter than me that are running around telling you, no, you can't do this, or yes, you can do this, and telling you to update your phone, that are taking care of it. And so my perspective here is really, what can you do from your personal purview? What can you do from a procedural standpoint? And what can you do with a set of tools? And so that's the background for this. So the first thing that I would want to make sure people understand is that hackers love medical records. And the reason that hackers love medical records is because it's deep background information on patients. It's durable. It has every place you've worked and every place you've lived, and it usually has a lot of just really good content to steal an identity. So the difference is, I could go out onto the internet and get an active credit card for pennies. If I wanted to get a medical file, it would cost me, over $100, $200 on the dark web. So the threat is real because the medical information is so valuable to people that have bad intent. And then the other threat is also important, which is just people wanting to be malicious and destructive. So that's the frame. So the first bullet is around privacy. So I'll take each of these four. So the first thing I would say is that in any of your interactions electronically, you have to realize that privacy is going to be a concern. And so a simple step that you can take that will work on your phone, on your home computer, on your office computer, is to use a virtual private network. And what that does is it makes sure that any interaction that you have between the parties is fully encrypted and can't be looked in on. And one of the products that I like a lot is Larva. I'm going to be pitching products because I wanted to be practical about giving you guidance. So at least this is a starting point for you. I have no other interest than helping you go into a hostile environment and be safe.
So when you said a VPN, are you talking about an individual practice or an individual person, or both?
So it can be both. And so the thing to realize, and I get to this in a little bit, but the thing to realize is that each one of us that's touching a network, a hospital network, our practices network, whether it's a patient or a doctor or a nurse, is an on-ramp. So it's very simple. Hacking threats usually originate from one person clicking on one email, and then it's the term computer virus. It then spreads from there. And so again, Larva is free. It's something that you can put on your phone. I use it on my phone when I go to Europe. It's something that you can use on the machines in your practice. So yeah, it's something that you can go and add to your phone right now, type of thing. And that's really the level of guidance that I'm trying to give everyone out there in this community. These are things you can go do, and these are things that will help.
On that, I was just say, one of the things that we've heard so much is all these hospital systems being hacked and data being pulled out. So right. The VPN is really your protective layer, so that all the people who are interacting with your system, you're keeping your system safe.
Yeah, it's one of. So people do ask me at times, give me the answer, give me the one thing that will help. It doesn't work that way. It's people, it's processes, it's technology. And so I'm talking here about a piece of technology. In a minute, I'm going to be talking about a piece of process that's important for you to be able to to understand as a concept to thwart hackers. So it's not just one thing, it's multiple layers.
Okay.
So next one, if you're exchanging data, almost every PC or Mac, there's something called zip. Zip the files. If someone's going to exchange information, if I'm going to exchange my patient information with you, I should not just send it to you in an email. I should zip it first. I should put a password on it. You're going to hear this pretty consistently. Put a password on it. So you zip that file. It's now encrypted, which means no one can unlock it without the password. But here's the point about separate channels, and this is the concept. Don't send the information along and then put the password in the same email. Put them in two separate emails, because what a hacker loves is when they intercept something and you've laid everything out for them. You've got the data file, it's encrypted, but you also have the password there, and you've made it easy for them. Hackers don't like things that are difficult. And so if you have the patient send the files encrypted and then send you the password afterward, you've made it much, much more difficult. Again, from a privacy perspective, again, and I'm just thinking again, individuals going to an environment, what can I do? I tell people use WhatsApp. It's fully encrypted end to end. It's got a lot of great features. If you are doing something, quote, less formal, more casually, it's excellent. If you need something that's HIPAA compliant, I put a number of options down below there. The link is there, and these are each HIPAA compliant options for chats. But if you just need something quick, you can put WhatsApp on your phone, and it's excellent. All right, so moving on. The idea of identity, which means, do I absolutely know who I'm dealing with? And it turns out that identity is one of the most challenging parts of cybersecurity, and where I've spent a majority of my career and time. But I wanted to point out a couple of things. When you're video conferencing or setting up these video conferences, it's happening so that patients can interact with their doctors, but it's also happening so patients can interact with patients. And sometimes, that's an end-of-life situation or a fraught situation and emotional, and nobody wants that interrupted. So there's a term out there called Zoom bombing, where hackers have been able to interact with families and people in ways that are just inappropriate. And there's FBI guidance out there on how to deal with it, but I'll keep this really simple so you don't have to read the 4 or 5 pages. Use a password on your video conferencing. The reason hackers are able to get there is they're able to scan for all the open conferences. They look for the ones that don't have passwords on it, and they Zoom bomb those. And so I would just urge everyone to simply use the password on your Zoom call, on your video connection. The other thing that I want to go into there in terms of conferencing is, I know that typically a lot of hospitals and areas don't want electronics, but I'm assuming they're making exceptions in certain cases. But there's also the concern about what happens on the network. And so if you've got a patient or a family member who's saying, they won't let me do this, they won't let me do this, one of the things to explain to them is simply ask or tell the hospital that I'm going to use my personal phone connection. I'm not going to get on your Wi-Fi. I'm not going to use up your Wi-Fi network, and I'm not going to add my phone to your system. and they may very well get more comfortable with what you're doing. From an identity standpoint, I would just say one of the things to also understand is that, at least in the US mail can handle US secret data. And so if you're going to send something, I know it seems archaic, but if you're not sure, have them send it in the mail. It's actually very well protected. And then this is also the research that I'm doing at Quantum Vault, the research that the government is interested in how to secure things over the internet. But,
I actually had a question on that. So the security is one piece of it, but also the reliability. And I want to go back to that point where you were talking about having a sensitive conversation. And we're going to be increasingly doing that, whether it's end-of-life care, giving somebody a bad diagnosis.
Yes.
There's going to be a lot of those. There's nothing worse than being in a very sensitive conversation and the line going down.
Yeah.
So you don't want somebody coming in uninterrupted, and you also want to have the stability. So how do you keep the line secure from the standpoint of, when you need to have this sensitive conversation, that what are the things that you can do to protect, to make sure that the call or the line doesn't drop?
Yeah, so if in a meeting setting, I'd say, wow, we have to take that offline, because there are so many facets of that. I would say the simplest thing is don't move.
Okay.
In other words, if you're doing this office, if the patient and the family members are spread out and it's distant, once you get a good connection, don't physically move, because that will change your relationship to your Wi-Fi, or change the relationship to your reception. And that's typically what happens. So that's my shortest answer.
Okay. Like I said, we're having a lot of those, and that's just a really simple thing that if you can avoid something that really is a simple thing, how crazy is that in a moment of really sensitive information, then all of a sudden you have a connection drop. So
yeah, well, I mean,
don't move.
Yeah, your inclination is to pace and be worried and fidget. Don't move. Don't move around the house. Okay. Don't move around the office, and you've got a higher likelihood. All right, okay. 2 more bullets. See, Sean, I told you the slide would last, didn't I? Yeah. Okay.
It's durable. Right. I give you that.
Right. It's a durable slide, right? Okay, so business continuity. So this is kind of at the practice level, and it goes back to my comment that everyone is an on-ramp into your system. So a couple of things that you can do. If you're interacting with your patients via email, give them guidelines. Tell them that you're not going to ask them for their password. Tell them that you're not going to ask them for for their social security number in the email. Give them some practice guidelines so that they can avoid the scams that are out there, and that's the below, or the link below. But just establish some guidelines where some of you have probably seen this from like Apple or insurance companies, where they say, we will never ask you for your password. So establish some guidelines in that way. All right, next one is important, just computer virus protection. The one that I would really recommend, if you're not using anything, or even if you are, is something called PCmatic. It's a gentleman that I know, but he's been well respected within the DoD, and it's an important difference. Most virus protections try and understand what the threats are and build a vaccine, a computer vaccine, if you will, for it. PCmatic is the complete opposite, and what they do is they whitelist all the programs that they know are safe. And so in terms of protecting your system, it's extremely good at it. And so again, it's small fee, great protection in a small office, great protection in your office, because remember, or in your home, because remember, we're at home doing these things, and if a patient sends you something with the virus in it and you click on it, your machine's infected. So, it's just the hygiene that you need. Then, specifically for practices, in thinking through this, I'm concerned about people getting ransomware attacks. Here in the US, the city of Atlanta was held hostage for several days because someone sent ransomware to one of their people, and it spread out in the system. And what ransomware does is it takes all the files on your computer, it encrypts them with a code that you do not have. And then you get an email saying, if you want your files back, you have to pay us in some form. It's usually Bitcoin, or we're just going to let your files be destroyed. And it's rampant, and I'm concerned that it's going to hit this community. And so there's a product out there called AppGuard. It's based on technology that that was produced to support embassies in the State Department while I was at NSA, but it's available to the public, and it is the best assurance against ransomware that I'm aware of. And so at least if you have that awareness, but I think it's important to think about this through the lens of how do you continue your business if in fact you're being attacked. All right, so last formal point is disinformation control. So the concern here is an article from yesterday or 2 days ago where the title of coronavirus pandemic unleashes unprecedented number of online scams. I mean, it's hackers don't waste an opportunity to exploit a situation, and this is a perfect one because nobody knows who to listen to is really where I see it taking place. And so what I would say is, as professionals in your community, as professionals in your personal community, I'm sure that you're getting questions about what do I do and what do I pay attention to, and is a scarf really better than a mask, or how long should whatever that is. I know you're being asked as a resource. What I would suggest, because disinformation is the cornerstone of hacking, it just is for you to actively, and pick whichever ones you want, but actively endorse credible sources of information. So tell people where they can go, tell people who they should listen to, convey your stature, convey their respect for you, and transfer that to somebody credible like the CDC or the World Health Organization and so on. So whatever you can do to help people know where the credible sources, especially since they're online almost 7/24 now and being inundated, will help separate the bad information from the credible information. So that's my one slide. I am happy to take questions. What I would say is that my email is on the slide. I think it's going to get copied to the chat screen. And what I would offer to this community of almost 5,000 people is I will certainly do my best to address any questions that you send my way, as for as long as I can. That's it. So Sean, if there are any questions, I'll be happy to try and address them.
Yeah, there are a lot of questions. So here's a simple yes or no, a short one. This is from Richard Santori, and he wants to know, we use Nord for our VPN. Is this a company that you have a favorable view of?
So I would have to take that offline. I'm familiar with Nord, so my answer is no. But it doesn't mean stop using them, because you asked a yes or no question. So no, I do not.
Okay. Richard, if you want to have a follow-up on that, please go ahead, and Herb can address that. And then from John Macy, he wants to know best security for using Mac, not a PC, Mac systems, especially now that we're using telemed and particularly more often from home.
So great question. So Mac specific, any VPN that you can find, any credible VPN that you can find that will run on a Mac is great. PCmatic, I know, runs on a Mac, and so I can suggest that. The Quantum Vault stuff would run on a Mac. I can't remember all of them, but I tried to give you the frame of what it was. And so if you can find your equivalent on the Mac, you'll be fine.
Okay. And Herb, I was just going to ask you if you can move a little bit more over into the center of the screen. I think when I pulled your slides down.
When you pull me over, I move. All right.
Exactly. No, I think we'd like to see all of your beautiful smile.
I didn't move. That's my practice.
No, I was going to say you were great. So in just going at the conceptual level, let's talk about from the standpoint of if you have, in your practice, it is so vitally important to business continuance to make sure that your systems are safe, correct?
Yes.
Yeah.
It's critical.
So, and I want you to just name it out there. So if anybody's thinking, I don't think I need to prioritize that in all the budget of the things that I need to have. I mean, I've already got a bunch of overhead. Why do you need to prioritize keeping your data systems secure?
If you don't keep your data systems secure, you can't help the very people that you are trying to help. You are out of business. You have lost your ability to function. You've lost their patient records. You have exposed them, every one of your patients, to identity theft for the rest of their lives. And so that's the thing that I would say is, cannot be cavalier about your data hygiene, because any mistake on your part has, in that regard, has long-lasting effect on every one of your patients and shuts down your ability to do the work you're trying to do now.
So your whole business enterprise really is at risk. I mean, the more I spend time with this, the more I think about it is on a very personal level. What would life be like if I lost my phone? And I just kind of look at that and I think it would just be easier to start life over again. It's your ability to operate.
Right. So it's not losing your phone. As a hacker, if I have your medical records, I can own your house in 3 months. If I have your medical records, I can set up a second mortgage on your home. You never know. And I take the money and you're responsible. You're evicted. As a hacker, I mean, so it's losing your phone, it's losing your house, it's losing your car. It's real. And then, not to mention just the the personal ordeal of everybody knowing, very private things about you. Those have been exposed as well. And so it's just, to me, it's elevated and it's important. But I mentioned the first point. It's important for you to be able to continue your practice, because what the city of Atlanta found and others found is that once you're hit with a ransomware attack, you're done.
Yeah.
You don't get to continue.
Yeah, you really are. I mean, you're just paralyzed.
Yes.
So now that we've made, it's very clear why you need to prioritize that within the structure of your practice. What vendor do you need? What type of personnel do you need internal? What can be outsourced? What would a business organization for a practice? What would the personnel look like to make sure that you've got the talent and the resources that you need to keep your information and your data and your communications secure? So
again, whoever's asking that or has that concern, email me. I'll try and be brief here. There are certifications that we set up out of NSA. One of them is called CISP. CISSP. It's a computer cybersecurity certification. So, depending on the size of your practice, you want to look for somebody who's certified. There are some other network certifications, but there is a cybersecurity certification that you would look for. So you would want an individual such as that on your staff. You want somebody with an IT background on your staff that understands how to protect Macs, PCs, networks, and individual devices. And, I think in email, I could probably come up with 2 or 3, key questions. Have you worked with this? Have you installed this type of thing into an environment to kind of, but those are the types of skills that you want to protect you and the certifications that would apply.
Okay. And if, heaven forbid, you end up with a ransomware threat, Mike Ryan is asking, what do you recommend if you do get a ransomware threat?
Pay them. It's easier. I mean, in other words, there's a demarcation point, right? What I've advocated here today are steps that you can take where you don't face that inflection point. But if you're at that inflection point, pay them, and keep your business open, keep your medical records, just pay them, because from a technology standpoint, it is a perfect storm, and it's really not recoverable. So you pay them.
I was going to say, that's what I have seen. And then there are insurance policies or special riders, I understand, on business continuity that are starting to cover this. Is that something that you recommend putting as part of your business plan?
I mean, I would, if we're in this crisis moment, I would say practice the hygiene that I've described.
Mm-hmm.
Once we're out of a crisis moment, I think that prudent planning, it's not that hard. The 4 points that I put up there are really the 4 points that are critical. I know a lot of professionals who do make it more complicated. I think because I've been doing this for so long, my choice is to help make it simpler.
Mm-hmm.
And so, but again, I would demarcate during the crisis, fix everything that you can. After it, plan for the next one. I just see a question down here. Someone's asking, problem with WhatsApp is need to use cell number. I think all I would say is, again, I was just trying to find ways for people to be able to communicate safely in multiple modalities. If that modality isn't correct for you, I respect that. But I was trying to give very general advice. If I'm a patient and you're my doctor and we can only connect via cell phone, then, and you want that to be secure, it's a way to do it.
Yeah. And just on that topic, there increasingly, as we've gone to open notes, as our healthcare professionals are increasingly showing up in social media channels and being more available to the public as well as to their own patients, many of them have said, look, just by giving my patients their phone number, sometimes that psychological security of knowing if I needed to reach them,
that's right,
then it actually decreases. So many of the colleagues that I have who have been sharing their phone numbers pretty readily, they haven't seen that it's been abused. And of course, it only takes one person to abuse it to make it.
That's right. Well, so for instance, on WhatsApp, so let's say, and I mean, there are other products out there like Signal, but on WhatsApp, you can block people. I mean, so it's like if you find that a particular person or family member is, for whatever reason, abusing the privilege, you can block them. And so there are some niceties to it. But again, my frame was,
if it works for you.
Cool. Oh, and the frame was, if I've got an hour to talk to somebody who's about to go into an ambassador who's about to head off to a hostile environment, Mr. and Ms. Ambassador, here are the 10 things that you need to pay attention to. Let's get your phone set up. Let's get your laptop set up and go. And you'll be much safer than if we hadn't had this discussion.
So we've got a question from Alonzo Sexton, who's asking, what video chat app do you find the best for the mix of security and quality?
Okay, so again, these very specific questions are challenging. I like WhatsApp because it lets you go international and it's fully encrypted. But again, you can do the same thing with FaceTime. So it really depends on, what your connection points are. Is it Mac to Mac? Is it Mac to cell phone? Is it cell phone to cell phone? But again, I would just say WhatsApp works if you need something that is that's HIPAA compliant. I tried to provide that from text messaging. but whatever mode or whatever product you pick, use the password settings, right? Because Zoom is great. It's just people are opting for convenience, and that's the biggest problem that we have with the internet. Everyone thinks it's safe, and it's not, and everybody's going to learn how unsafe it is. And I've been railing against that in my professional capacity for 20 years, that the populace does not understand that the most dangerous thing they interact with every day is the internet. And if you don't learn how to compose or conduct yourself on the internet, you're going to be burned. And that's what's happening right now, is people are finding out how fragile it is, that it was never built for security, that it is the most invasive thing that you can work with. And if you don't take certain steps, you've got a problem. And so again, back to the video chat, pick whichever one. The best one's going to be how you use it, and the best one's going to be if you send the link to your video chat in one email, and then the password to your video chat in a separate email, and then you're good.
So Herb, I want to tell you, I love the security guys. I love the IT guys, but you always put the fear of God in me after I talk with you. So from the standpoint of I love the internet, and I just need to go safely about the internet. So
you need to go safely about the internet. Look, it's the difference between driving down the highway with your kids and your dogs running around your car without seatbelts, with the windows open, doing 100 miles an hour, doing the bird box thing with the windows blacked out. That's all. And so the reason that you have the fear of God is because you're not following the practices that are a little bit inconvenient. If you follow the practices, you're fine.
I was going to say, from the standpoint of, I don't find it so much inconvenient. I sometimes find it intimidating, because I'm not sure I know how to navigate my way around. And I'm always afraid if I click something, I'm going to lose a bunch of things. So I think part of this, in addition to hygiene, we need to develop a set of competencies. And as we have more robust opportunities, it's sometimes, the complexity of checking these different things, and then things don't work. So we're all learning together. Yeah, we're learning together, and really grateful to have somebody with so many decades of experience to help us navigate those things. And like I said,
you can say I'm old. Go ahead. Yeah. It's fine.
No, you're wise. You're wise. You're wise. And okay, I will say, as we're going into these new uncharted territories, I am so glad I got you in, being my wingman on all of this. So
you have my email. This community has my email. I will do my best to catch up. I will do my part on election security. I'll do my part on identity, and Quantum Vault is kind of the pinnacle for me of my life's work. So hopefully I'll be able to get that done. But I am here and ready to try and address specific questions at this email address.
Well, thank you again. Really appreciate you joining us for this segment of the COVID-19 orthopedic response. And we'll see you online safely. Bye, Herb.
Yes. Bye-bye. Thank you all.
Excellent. Welcome to COVID-19, the Orthopedic Response, a production of the Digital Orthopedics Conference San Francisco team and UCSF Department of Orthopedic Surgery. I am your host, Stefano Bidi. I'm an orthopedic surgeon, and I'm also the chair and founder of the Digital Orthopedics Conference. And we're thrilled to be joined by the American Academy of Orthopedic Surgeons as a global convener to address and rapidly respond to the dramatic changes to healthcare patients in our communities that we're seeing. Now, we're grateful to have a global audience joining us for this discussion, but I'm particularly pleased to welcome back I almost doctorized you, Dennis Boyle, who is the senior leader of design for health practice at IDEO, the famed design firm, an adjunct professor at the Stanford D School, the design school, as well as Dr. Talia Butler, pediatrician and medical director at IDEO. And we want to acknowledge also Delphine Wang, who's a Kaiser Permanente and San Francisco General Hospital ER doc, who also works with IDEO and contributed to this, as well as all their team. So just to reframe it, what we did, which we we hope we might even be a first for a virtual conference. Well, yesterday, we crowdsourced several problems that people were having managing COVID. And then you guys took those ideas and did a design sprint. Now, Dennis, what's a design sprint?
A design sprint in this case is trying to go as far down the path of designing something, especially from a conceptual standpoint, as one can in the time you have. So we had about 24 hours. So we're coming back
Amazing.
with we had 4 designers and Talia and myself contributing. So there's 6 of us trying to move a rugby scrum down the field, if you will. So we're ready to show and tell what we came up with.
Awesome. I'm going to share that screen down there, and I say we have one of the most talented design teams in the world contributing to us and coming back with our 24-hour design sprint solutions that we can potentially conceive about. And I guess the big idea here is to show what design people can do in the context of healthcare and the value of bringing the design community into the fold to help solve the COVID-19 problem. So take it away, Dennis.
All right. So we're just a bit of about IDEO. We're an innovation and design consulting firm, 800 people worldwide in 9 different locations. And we look at this as an Apollo 13 moment for designers, innovators. There's that scene where there's this big box of stuff by the engineers on the ground were trying to solve the problem that Apollo 13 astronauts had by one of their modules was not functioning. They had to make the landing module do for life support for 3 or 4 days. And so there's some rough parallels here, but this is an Apollo 13 moment for the world. How can we make things work right now on the ground? So we had this open ask yesterday. We had an idea design team standing by for a design sprint, 24 hours. We crowdsourced from the 4,000 plus people from the audience. What were some of their biggest challenges that a design team might tackle? And here we are 24 hours later to show and tell what we have come up with as a team. And I'll flip over to Talia.
Great. Thank you, Dennis. So often when we do this, first of all, 24 hours is very unusual time frame. It'll take weeks or months, but we wanted to give this a try, and we know how serious this pandemic is. But we wanted to show you a little bit of our process before we get deliverable. So at the beginning, we pick a question. You all helped us do that yesterday. We do brainstorming, and we'll tell you a little bit about how we do that in our special IDEO way. Then we vote, we pick the topics we want to build out a little bit more with prototyping and testing. And then ultimately we would do some experimenting, and iterative design is what we do. Lots of processes. And that image is an example of how we might do this over and over and over again. So the other thing that's important to think about for human-centered design or design thinking, for those of you who are new to this idea, is that we always start with the people. We want to know what is desirable. And that's why we started yesterday by asking you, what are the problems you want to solve? From there, we'll often build into the viability and the feasibility, and that's where we find innovation. But we always start with the people. That's the big part of human-centered design. So yesterday, you helped us pick a question. We used the chat bot. We used the ask a question feature. People voted. This is a screenshot of that for those of you who weren't here. And this is where we started. Washing your hands and not touching your face are 2 very effective infection prevention measures. What solutions can IDEO come up with that can help remind people throughout the day to wash their hands and not touch their faces? So from there, we brought that into a little bit of a different framing. We like to rephrase our questions using how might we statements, or HMW. How might we helps us think optimistically with the how question, generatively with the might question, and collaborative with the we question. It doesn't point fingers, and we find that this framing can be very helpful, something you can take with you. So in this case, how might we remind people throughout the day to wash their hands and not touch their face? So from there, we brought our group of designers in. We had Ridma, who is a game designer, May, who's an interaction designer, Doan and Ross are both industrial designers. And this is a screenshot of us on our Zoom call yesterday, right after our session, getting together and making our plans for a quick sprint.
Well, Talia mentioned kind of guidelines or rules. These are some things that we put up on our walls, and there's deferred judgment. So don't judge ideas when you're trying to come up with them. Encourage wild ideas. Try to push the limits. Just standard ideas aren't always going to work in situations like this. Build on the ideas of others, so you're working as a team. One conversation at a time, so everybody can hear the ideas. Stay focused on the topic. Be visual. Make a little bit of a sketch on a sticky note or a piece of paper, and then that'll help explain it. And then go for as many ideas in the time that you have. You can see here, we're normally together and we're all on top of each other putting up notes on boards. Well, we can't do that these days, but there's some remarkable pieces of software out there that are just getting better every day because everybody's trying to do this at once. This is a piece of software called Mural that our design team is getting better at every day. You can see we did some warm-up brainstorming sessions, household objects, or communication channels, just to kind of like start the creative energy flowing. And we zoomed out, and you can see the extent of the kind of the quantity of the brainstorming ideas. Each little post-it note, a virtual post-it note, is a concept of some sort. And in the cases below, you can see that people were writing on actual post-it notes, holding it up to their camera on their laptops, and the moderator is taking pictures of them. And so there's a kind of a combination of virtual and actual post-it notes images on the boards. So what sometimes this happens that the original question is evolved by the design team to be even more topical or more important. So what we came up with together as a team is how might we reinforce hygiene habits and social distancing for public safety. So combining these two things together because they're so at the top of everyone's list for advice around how to behave in this day and moment.
And just to show you a little bit more of our process, here we have our team. I'm holding up a Post-it, which is why you can't see my face, but we've got lots of visual Post-its, people doing sketches either in Sharpie and by hand or on their computers. And those little green dots is how we help narrow what we want to build next. We come up with a lot of ideas, and we know some of those ideas are going to be terrible, but sometimes those terrible ideas are what make us think of something good. And then we choose what we want to build up next. Another technique we have is looking outside for inspiration and looking to analogous fields. So changing behavior, washing your hands more, it's kind of like brushing your teeth. So what are things we use to help determine how long we should brush our teeth for? There are different cues like music. We also can be inspired by little bells we put on our pets or cowbells so we know when they're moving. Might help us remember where our hands are and why we're moving them. And then from there, we jump right into concepts. So everybody at home can do this. Take a piece of paper and a pencil, and we talk about drawing stick figures all the time. This is a little bit hard to see, but this is a sketch of an idea of a soap that would allow you to see when your hands are clean and when they're dirty. And you could add something to the soap so that it's a certain color and it would encourage hand washing. And then I'll jump through another few concepts. This one is one we didn't build out any further, but it's a tattoo that when it's wet, it would be clear. But if you haven't washed your hands in an hour, it would get darker and darker, and it would be a visual reminder. So lots of different ways that people can help remember. And the next two are early stage shots of what has gotten built out a little bit more. So this is another hand washing concept. And this is an app to help us think about social distancing. So last night, this is where we got to. We had all these ideas. We talked about them a little bit more, and then the team took a break, had some dinner, and you can see here that we even took more Post-its and tried to build on ideas so that this morning when the team picked up again, they would have more ideas to create further progress.
And just another reminder of this process starts with people, and we start to layer on technical factors and business factors as we go. But at first, it's really got to work for people in one form or another. Again, this process, if you go to another diagram, it diverges during the inspire, understand phase, and then it converges to try to get to fewer concepts. And then you diverge again with fewer concepts with a little bit of visualizing and prototyping. And after this point, you would begin to refine and develop. Typically, this phase typically lasts weeks or in some cases months. But we're trying to push it for a matter of hours here. This was a little session we had this morning with a group of 16 or 18 people. Here I'm drinking my coffee here. But we put up these concepts in front of them and got feedback. All the little sticky notes that you see on the concepts were what their impressions were as well. We're all kind of users in this current atmosphere of how to modify and promote healthy behaviors during this pandemic. So we took that and fed that back to the design team. The design team was listening in some cases, and a couple of very interesting kind of questions came out, as they always do. What if you can incentivize people to go to non-chronic places like Pokemon Go? What if directed towards areas that are safest with the fewest people and the widest streets? When is it good to go outside? Is a conversation that happens every day? How might we leverage some of these and build these things into the concepts that are being developed? So one concept that came up and was developed to a little higher fidelity was what we call the Bubble app. That's a mobile application that helps you social distance. It's a couple of concepts here, but everybody travels with a smartphone these days. This is an application that helps understand how to keep people at least 6 feet apart and give you feedback and interaction if you are or are not in this. The next screen is what the app might look like. Avoid these certain streets which have high foot traffic when you're planning an outing, trying to go outside. It might remind you in the case to wear a mask or wear gloves or wash before and wash after. The people, we think of this as people are about to burst your bubble when you are too close. And it's recording all along as you go along, because there's quite a bit of technology built into smartphones as they exist, and we believe this could be implemented with some Bluetooth and other types of technology that's possible. And then when you get home, the screenshot tells you how far you've walked, how many people came inside the 6 foot bubble, and it could contribute data to your city's safe distancing kind of initiative, or helping kind of anonymize data to get out there to see how a population is doing, and then there's possibly a strong forcing function that occurs that this will not, you can't turn this off on your phone until you've clicked done. You've finished the hand washing for 20 seconds. You've wiped down your phone surfaces and door. You've clicked off a little checklist of things that you should do once you have returned to your home from an outing. So after 24 hours, a client or the team will ask what are next steps to make the plan here. A quick little list of understanding if and how it is valuable to, through this concept is valuable, making a quick little prototype, a little click-through prototype on the phone itself. We would interview extreme users, people who were very paranoid about breaking the rules, and those that on the other extreme, those that weren't, they were kind of laissez-faire. So to try to understand if this, where this would, how to make this appeal to more people in the population. Is data privacy a concern? Is there a way we can make this feel comfortable for users? Who might we partner with this to create more value and accelerate bringing this application to market, considering a local government or maybe a state government or map software people or public health departments? Who's sponsoring this and who's keeping this going? And we begin to practice iterative design, where we take all this feedback and update the design, start making pilots and go out for higher numbers and test with higher numbers as we try to quickly move this into a position where it could be released on app stores or so that's that. Maybe Talia, flip to the next one.
Yes. So after you've gone out, your app reminded you to wash your hands. We went for a little bit of a different style here, and now we're thinking about how do I make sure I am washing my hands well. So we used HMW, or how might we provide clarity of how well your hands are washed. So this is a product that could be attached to an existing sink or faucet, kind of like those old wrist bracelets that we had in the 90s, or the modern Apple Watch could be made of silicone or rubber. And it uses UV light to highlight any remaining dirt or particles on your hands. So just to see it in action a little bit, it might use a sensor or proximity sensor to turn on your faucet. Once you start washing your hands, the music plays and there's an auditory cue to say 20 seconds, maybe you sing happy birthday. But there's also lots of other memes going around for how to remember 20 seconds. And then after you're done, it shines the light, and the light would allow you to see, are there any spots that you missed? And it would also reinforce any good habits. So if you can't see any dirt, you did a great job. This helps keep people mindful about the process of washing your hands, engaged. It helps make the invisible visible. And it does it in a way that's kind of fun and joyful, and not so serious all the time. So next steps for something like this would be to interview users again to help understand hand washing behaviors. Then, the quick and dirty version would be to hack existing products and try to make a workable prototype. We'd experiment with different features, and then we'd look into partnerships. So do any light companies want to add a feature like this, or fixture companies that we could partner with to help us refine and produce the design?
I remember just on this last one, an idea that was kind of the team came up with is that maybe this kind of software, the timing software, could exist on a smartwatch or something like that, that would give you some of this function by helping with a song or a countdown timer, because it senses you washing your hands. So it's kind of an addendum.
Right. Because your phone is in proximity almost every time. So just you're activated, you have to worry about finding.
Yeah.
It's brilliant, guys. I can't wait for the bonus feature, because that was so much fun.
So a couple of ideas just came up right near the end that you sometimes can't help yourself with. And we have a practice we call the parking lot, just to put them over here because we're working on a couple of main things. But the whole idea of using your watch or some Fitbits or some of the things you're already wearing that give you visual or audible or vibrational feedback. The thought was if when you raise your hand above your neck, the likelihood is that you're about to touch your face. I mean, there's other things that you could be doing, but it'll give you a bit of feedback here, whether it's auditory, you can adjust it to make it just vibrate so you're not hearing a blaring siren every moment, but it will help you change your habits and be more aware of when your hands are approaching your face. So that appealed to everybody on the team and wanted to put that out forward.
And this is another idea that people on the team were excited about because we know PPE is in such high demand, and the bottom line is we don't have enough of it. And what do we do with what we have until we have enough of it? So this was inspired actually by a special type of goggles that downhill racers might use when their face gets full of mud. They can take off a screen, kind of a plastic bike racers. Thank you, Dennis.
Yeah.
And this is kind of an N95 with lots of layers of a surgical mask on top of it. So you could keep your own N95 clean, but if you were seeing a patient that was on droplet precautions, you could just rip off one layer of the mask. So this is, again, how might we quickly iterate to apply our learnings and improve existing products rather than creating something entirely new.
All right. Well, yeah. This is our one thing that there's many sayings and quotes that drive us, but this is certainly at the very top where to predict the future, you invent it. So we try to live this every day. And again, this has been a inspiring process, and we hope you feel the same way. And thank Stefano and his team for the opportunity here to present this.
I thought that was brilliant. I don't think it's been done before to have a design sprint inside a virtual conference triggered by requests from the community with an output that is so creative and so just, wow, I loved it. I love this. Just real quick, these ideas are now out in the community. If somebody wants to take of these and iterate on them, it's okay.
Yeah, they're open source.
Open source now. That was absolutely brilliant.
4,491 people have just seen them. So
we're excited about that. I have one question in the queue, but I want to just ask you a couple of questions so that people understand the process a little bit better. Those who have come to DOCSF previously, you've by definition worked with IDEO. Dennis, actually, I should probably worth mentioning, within a week or a few days that I came up with this concept of maybe doing digital orthopedics conference, I happened to hear Dennis speak at a conference at Stanford. I was so impressed. I went up and said, listen, I got this crazy idea. What do you think? And he offered to support this thought process and encouraged me to move forward, and has been generous with his time and effort and his team to come to every single DOCSF we've ever had, and also provide sessions for our team to go through a design thinking process. And what you're seeing today is the power of the design thinking community to support us clinicians in our ability to address challenges that we're having, whether it's COVID-19 driven or otherwise. And in the session with Michael Blum, you can also hear how design thinking has enabled the University of California, San Francisco to change completely their internal culture and how they handle challenges that need quick responses. So the reason I say that because we focused, or at least my attention is focused on the result. I'd like to go back a little bit, how you build a team to do a sprint like this. As you mentioned earlier, Talia, normally you have more than just designers in the team. Want to talk a little bit about that, you or Dennis, about who needs to be in the room? What's that look like?
I'll let Talia add too, but what we try to do is put together teams that have a number of different disciplines on them. In this case, having some visual designers, an interaction designer, which was May, the visual designers were Doan and Roth, and then Redeema is a play lab designer, toy designer to bring some of that kind of lively energy around making things usable and playful. How would you add to that, Talia?
Yeah, I think we always make our teams of people from different disciplines and different backgrounds. And in addition to that, this is really a co-design process. So we always design with the people we're designing for. So you can, other terms of that are participatory design or the co-design process. And we love to design either with our clients and or with our users. So in this case, we talked about the people we might interview, but in addition, perhaps surgeons who are scrubbing their hands very often, they would be interesting users to understand hand washing procedures. Yeah. And similarly, people who live on the streets who don't have an opportunity to wash their hands very much, what could we learn from them? So we always try to learn from everyone, and we bring people along for the process so that you can see the divergence and the convergence and help us decide what the best ideas are so that our designers can bring them to the next level.
Thank you for the explanation. And then you iterate by having this really large set of ideas that are open. People are very no blame environment. That no idea is too silly, too stupid, right? And then the team, how did then go from all those ideas, including the crazy ones, down to the ones that maybe have more legs to them? What's that look like?
Talia, you want to take that one?
Sure. So, we love to come up with the crazy ideas, like you said. And then when we're in the office, we take little stickers like we're children, and we put them on the Post-its that we like the most. And then those ideas that have the most stickers on it, that's where we start building out a little bit more. And again, we kind of do this diverging and converging process. So we'll take one idea, and we might build 3 examples of it. And of those 3 examples, we like one the best. So then we'll, iterate on that a little bit more. It's somewhat of a democratic process, but when we're working with the client, we also have to understand what are the constraints. So, if we want to design something that involves UV light, how much does a UV light bulb cost?
Right.
And so
I just add to that the clients oftentimes in the room, and they're helping vote to have this convergence process, or we take ideas out from quick little sketches or quick little models that demonstrate the process and show them to this range of users that Talia mentioned, where people are very engaged, they're professionals, or they're very disengaged, and they're quite far away from the problem. Well, I think you might be.
I'm sorry, I cut myself out. I'll do it again. I apologize. I'm sorry. Try to get my anyway. In a question from Alonzo Sexton: in the healthcare world, are there any general barriers that you have found as major limits to progressing from design stage to implementation? So very much a healthcare question in here.
Well, I mean, we look at constraints as kind of good to have guidelines, but of course, any healthcare product or service or system is quite highly regulated. So we have to work with the FDA and all sorts of other regulatory bodies. At this moment, some of these things are being shortcutted because there's such a great need. Talia, what else might you add there?
Yeah, I think the regulatory side of things can sometimes be a barrier to faster implementation, but safety is real, and it's really important when you're doing something and you could affect a person's life in a serious way. And so we definitely have to account for that regulatory and safety factors. And the other thing we think about is we know there's a lot of stakeholders in the healthcare system, right? So there's patients, there's doctors, there's nurses, there's other healthcare providers, there's hospitals, there's insurers, there's the companies that are providing all of the healthcare goods. And so thinking about what is the perspective of all of those different stakeholders when you're trying to bring a process or implement something new can be very relevant. And that's part of why someone like me, a doctor, is on the team at IDEO to help understand some of that at a deeper level and earlier on.
And I'd just add to that too, there's no substitute for testing and more testing. Even in accelerated projects, more than any other category we work in, there's much less room for error if people's health is at stake. And so you've got to build these virtual tools, software tools, processes, experiences in clinics or in other places or products. You've got to build prototypes and test them with enough people that you can give yourself and pass all the hurdles that need to be passed so that you're not releasing something out there that is dangerous.
I'm going to rephrase one of these questions a little bit from Jeffrey Blander. I think what he's trying to get at is how do we get there are some great ideas that are being published on the internet. There are people at home using 3D printers coming up with clever ideas. How do ideas like that get out into the community and get used and get into the hands who could use them? What kind of pathway do you see evolving, or should designers, thinkers, inventors have as they create concepts that they think would be helpful to the healthcare community? What's that path look like?
Well, there's a lot being produced. I mean, you have to get it out in some way in front of people if you're kind of an independent inventor. There's a lot. Yesterday's talk, we went over how many things are coming online in the PPE space, for instance, or in the ventilator space, for instance. People are going open source with their ideas. You need to get from the open source to somebody that can produce the products or services. And so I think we're in that big phase right now. All the big corporations are starting to line up to try to do their part. The auto companies and the medical products companies. I think we're going to see remarkable innovation and things happen that we've never seen before. But there's a lot. There's some unknowns.
Just to build on that a little bit, I think open source is big right now, and that helps speed up innovation. But really, like Dennis said, getting the ideas into the right person's hands, right? So we at IDEO, like Dennis talked about yesterday, have been doing a face mask project, face shield, and we made one prototype or a few prototypes. We gave it to some doctors. They tried it out. They gave us feedback, and then we bring it back. And that's how you get your ideas going. Give it to, assuming it's safe, you give it to one person to try. And if they like it, hopefully it has its own legs. But I think that's another interesting point, that we need innovation, not just in the products and the services, but in the supply chain. So we need people thinking about that as well.
Yeah, I mentioned the Emergency Design Collective yesterday's session. That if you go back and look at that, but that's a UCSF-based innovation collaboration with designers all over the world, over 100 or 200 people part of this. They're already published 3 or 4 different things in the space of PPE and blood donation and others. Take a look at that Emergency Design Collective, started by Dr. Amanda Salmon of UCSF, trauma surgeon. But yeah, they've anticipated that what we're seeing now. And my phone's lighting up right and left, where the CDC is starting to promote all people wearing masks. But there's the big challenge of if that's the case, are all people taking masks away from healthcare providers? So they're promoting making masks yourself, or doing do-it-yourself kind of home masks. So you're going to see all this come to light in the next day or two here.
Yeah, there's a couple of notes from Lou Sean, who's watching and participating in our questions. He himself works with several universities, BME design programs, himself as an inventor, and was asking a little bit about could there be a COVID design challenge, a group out there, maybe even sponsored by the IDEO, where brings together some of the design firms to solve some of these COVID problems, kind of like we did today. Sounds like an interesting idea. I don't know if that's feasible.
I just repeat that the Emergency Design Collective is already doing that, and we're participating in 2 or 3 or 4 of those projects. And they've got other firms like Frog and other firms kind of part of it. And there's individuals. So I'd look at that as one suggestion at first.
Terrific idea. So, so Lou, I think we'll direct you there, and hopefully you'll be able to get involved. It sounds like you yourself are integrated in some of those design schools and can help about that. And Mike Ryan has a question that I would have asked myself. He's obviously with us at DOCSF. And what's the best way for us to continue taking some of these design sprint ideas and moving ahead and revisit them in DOCSF 21? I mean, I do have a thought, actually, if I can share with you publicly. Perhaps we can.
You're the boss.
Yeah, well, I know, but it's like this. We have already sort of mentioned it, is that one of the themes for DOCSF 2021, Digital Orthopedics Conference, is sort of come up with a roadmap for development for what we'll need in orthopedics. That roadmap a year ago would look very different. It'll look next year, but we could probably use some of these concepts, ideas, processes that you just outlined at DOCSF to help ideate and streamline and think through some what we need to, where we need to go for the next say 5 years.
I could completely agree, and I think you're in a position, a remarkable position of leadership, Stefano, in that by the time of DOCSF 21 in January, we need to be better prepared for this pandemics. We just are woefully unprepared. So when there's some time to think a little bit more out of the emergency kinds of thinking, that could be a great part of your next effort, it seems to us.
Outstanding. Well, I think we'll close this session. We're going to call it a day. Thank you so much for participating. It's been a first potentially worldwide. Who knows? Maybe, but it's definitely an innovative idea that we had. You guys were amazing. Your designers are amazing. Those drawings, those concept drawings, were so good. I learned so much. Thank you both for participating. Big thanks also to Delphine and the rest of the team back at IDEO that spent so many hours showing us what can be done, what the design community can contribute to COVID-19 response.
Yeah,
Thank you.
Yeah, we get to stand on the shoulders of giants, as they say. And again, it's been an honor to be part of you put this whole function together in the last week. It's just remarkable to see how well it's come off and how much it's added to the world. So thanks again for inviting us.
And on that, I want to acknowledge there's a whole team behind me who volunteered their time as well. I thank you. I'll let them know. Thank you.
Including your spouse.
Oh, yes. I grabbed everybody here. Shauna's
Nancy,
long hours, Nancy and Mike and Christina and Guido, one of my fellows who got stuck here from Italy, couldn't go home. He couldn't come to work. We had no surgery for him to do. So I said, hey, why don't you help us out? So Giulio Santi, it's been amazing. Okay, great, folks. Thank you so much. And we'll see you soon. Thanks. Bye-bye. Welcome to the wrap-up session for COVID-19, the orthopedic response, production of DOCSF, Digital Orthopedics Conference San Francisco team, and UCSF Department of Orthopedic Surgery. I'm one of the co-hosts, Stefano Bini. I'm a professor of orthopedic surgery at UCSF, and I'm joined here by my co-host.
Hi, I'm Shauna Butler. I'm a nurse economist and the host of the podcast See You Now, focused health innovation that's driven by nurses.
Awesome. And we want to acknowledge the American Academy of Orthopedic Surgery, who joined us as a global convener and allowed us to address and basically respond to this dramatic changes that are happening to our healthcare system, to our patients, with a global audience that was able to join us for our discussion. I think we cleared 4,500 people registered, Shauna.
Yeah. Well, and you mentioned that our patients and our healthcare providers, but it's really been our communities. There's nobody that hasn't been untouched by this. And that was one of the fun things about putting this together, is that we really did have a lot of perspectives. While we came through the lens of orthopedic care, I think anybody watching along with this can benefit from the perspective, because we started out really understanding the clinical understanding. What is this virus? What's the epidemiology of it? What does it look like from an anesthesia perspective? So we had our clinical team come together and help us think about it. And I would venture to say it wouldn't matter what specialty you're in. This type of information, the general public, policymakers, designers, interested members of the community, I don't think that there was anything in there that anybody across the globe wouldn't find useful.
Right, exactly. Everything we talked about, like you said, we started out with the clinical perspective on this, and the context, because we like to get down to the nuts and bolts of deploying technology into healthcare. When you do that, you kind of have to have a use case, and to keep it cohesive, we use orthopedics and musculoskeletal care, right? So for anybody watching this as a recap, just to get a sense of what the conference was about and what elements of it could maybe be of interest to them, let's just quickly go over the 2 days and how we structured it. So you mentioned that we started out with a clinical perspective. We had professors talking to us about their research and what we know about the virus and how it propagates and the impact it has in the clinical environment and physicians. And then we went to a whole new tack.
Yeah, all of the new technology. And from the standpoint of, we got a really steep learning curve. We got a lot of new learners, a lot of things that they got to learn. We got a lot of new teachers. So Carol Clove with Elemental Health was helping us to learn communication and micro-learning as a service. And what was interesting is there are a lot of things that we're learning, and we are learning what we need to learn. So, and coming together as a global learning network and sharing best practices in real time, I thought that that was a really important piece to understand. And all the different, I mean, her point where we were talking about, we're setting up these field hospitals. So every single piece of how you interview somebody, how you walk them through a space, new ways of intubating, changing central lines. So that micro learning, little bits and pieces, and how can we learn what we need to know in the moment. I thought that was a really important, there was a lot of technologies though. Right, exactly. So we went from the clinical, we'll come back in a minute to the middle piece there. We talked with the idea and the design thinking piece. But like you mentioned, Elemental Health, we also had Get Well Loop. I gave a quick talk about an overview about where we can use technology to impact the patient journey. And we focused on Thursday on physical therapy and teletherapy, telerehabilitation. Yeah. And then we went into a very really practical stuff just around scheduling. Exactly. And then we went into the clinical, the session in New York City. And then, of course, we heard from the American Academy of Orthopedic Surgery and everything they're doing to support the orthopedic community. Yeah, and it was really nice to hear the administrative perspective and the leadership. And what really stood out to me is the stress that's placed on the system, the stress that's placed on the people, the stress that's placed on the community, and stress in ways that first of all, I don't think that we would have imagined it until you have this come through and you see the cascade of childcare, scheduling, putting together teams in different ways. But what really stood out was the role of leadership, being physically, visibly available, consistent, supportive, providing up-to-date information, being honest about that information, what we know, what we don't know, and being consistent and reliable. So visible, physically present, consistent, and giving information at a regularly scheduled time that was accurate. What we know, what we don't know.
And to that point, having the academy and the president academy on the program to show that leadership, to show that where they have collected their information, the work they're doing at the government level to support our clinicians and physicians, I think was illustrative of exactly what you're talking about.
Yeah. And
let's go back a second to the session with IDEO as well, because that kicked off on Thursday, and that was also very novel and very different.
Yeah. So to encapsulate that, we had IDEO with us to do a 24-hour design sprint where we crowdsourced from our audience attendee, 4,500 people from around the globe, who shared with us the problems that they were seeing and charged the design team to come up with some approaches to think about what they would do. So I have to say, Stefano, I feel like you and I attended two different conferences because we were back and forth and hosting these different sessions. So I only captured, bits and pieces of yours, and I think you only captured bits and pieces of mine. So I'm kind of checking in with you. I launched them to see what they were going to do. You got to see what they come up with. So could you fill me in on what this amazing came up with?
I know what you mean. It was one of the funnest sessions to watch what they come up with. First of all, we're dealing with IDEO. So they took some of the brightest and sharpest minds in the space, put them to work for 24 hours. And literally there were 6 or 7 people full-time. Then they had 16 others who reviewed their ideas and helped them sharpen them as insane designers. I don't know how they came up with these gorgeous drawings of their ideas and showed us really clever thoughts about one I particularly liked was a sticker they didn't fully develop. It was a little sticker you put on your skin. As the day goes by and you haven't washed your hands, it becomes brighter and brighter. It was a clever idea. They also had a sensor that you wear, that you put around a faucet, that if you put your hands underneath it, it tells you if they're dirty or not, and then it knows you're under it. So it gives you music for 20 seconds until you're done with it. And it has a UV light so you can see whether or not you still have dirt on your hands. And then they came up with an app they called the Bubble, and it knows if somebody's within 6 feet around you. And then if that's the case, it bursts your bubble, and you can tell how many people burst your bubble during the course of the day. Because the problem they were asked to solve is how do you keep people from not washing their hands?
How do you keep everybody at a safe distance?
And keep it in a safe distance.
Yeah. So that was a really fun thing to. So the problem they decided to address was hand hygiene and social distancing.
Yeah.
Yeah, and I think that was the other thing that we heard a lot about was, while it's physically distant, it's socially connected. How do we keep ourselves physically apart but virtually together and emotionally connected?
Yeah. And that's sort of, and like you said earlier, we jumped around a bit. New York, we finished that New York piece that was so moving, as you mentioned, the 2 physicians in New York who, one administrator, both orthopedic surgeons, one administrator, one more of a clinician, managing a huge residency program, and the impact that it's had on them was it was very, very, very reflective.
Monumental.
Yeah.
Yeah. And
we closed.
I was just going to say, one of the things that I found really interesting about the Academy is, you did mention what they were doing clinically, but the other part that they really focused on is each one of these clinicians, they represent small businesses. So it's not just taking care of the patient and the clinical part of it, but those communities that count on the care, they count on the business that it generates, the jobs that are there. And so managing a 3rd and 4th magnitude of order out, the families that are impacted. So it's beyond the clinical part. It really is thinking about the fabric of the community, making sure that those services are still available, those jobs are still available. And that was I was glad to see that there was multiple facets that they were addressing as far as how the Academy is supporting the members.
Yeah, thank you for that. Great summary. Moving on to today, second day of the conference, we reversed orders a bit. We started out with the technology companies, didn't we?
Yep. So Molly McCarthy, you got to spend time with Molly and learning all about chatbots. Yes. What did you? And it was interesting because we'd had this conversation earlier about I have a little bit of an idea about a chatbot. This is like chatbot on steroids, right?
Right. In fact, chatbots came out a couple of times during the course of the day. We also heard from Michael Blum and what they did with chatbots at UCSF. And bottom line is these are technologies that are readily available and quickly implementable.
Yeah.
Microsoft went into several hospitals and quickly got them up and running. UCSF deployed their chatbot in a matter of a week. And with Seattle and Microsoft, it was a very useful tool for the city to understand what the spread of the disease was. In San Francisco, the way to use it was to allow people to be screened at the door through a chatbot interface instead of doing it by paper, and they eliminated lines of their staff coming to the hospital. So super cool ways to use both these tools. And then
I thought that the other point that she made that was so good is one of the things that we're trying to do with all of this right now is to reduce the stress on the system. So there were a couple of pieces there, which was the symptom checker. So it took over a lot of the triage, the back end data, seeing who was asking for that. So it gave them some geolocation, which then allows them to deploy communication. So there's an analytics component that went into, I mean, the front end is, I need to, for an individual, I want to have the personal comfort and satisfaction. Am I safe? And then at the system wide, let me remove some of that workload, to this technology that can help it. And then at the aggregated level, where are we seeing where the next the little pocket of outbreaks so that we can plan an epidemiologic standpoint. So a lot of, when we think about the chatbot, we're thinking about the clinician and the patient having this micro interaction, but boy, there's a macro level of services that are happening with these.
And then we had Carlin, who wound up going last, but that video will be available, talking about the use of Zoom for telehealth and televisits. That was a great session as well. And you led that one, I think. Yeah, so video visits. And, what she's been doing, she's been doing this for 4 or 5 years. And because she's got so much experience, she's really a leader in helping us to the nuts and bolts of what do you need to have in the way of the technology, your room setup, your workflow. And then also looking at it's a reversal. So there is an etiquette. We're going into people's homes as opposed to them coming into our place. Right. There's some new opportunities there, and then there are also some limitations. So thinking as we, she, like I said, she's been on the leading edge of that. So my question to her was, okay, everybody's catching up to you. Where are you going to take us next? So that was a fun thing to think about. We don't have these opportunities very often where we can make a stepwise change in how we do things. And from there, we moved into another technology, two pieces of technology. Well, one of them is a little more tech. One is a platform, well, both platforms anyhow. The digital surgical scheduling tool. And what we saw in some of those slides from Sai Fahimi from the docspera was the massive drop in surgical bookings, and they have a huge footprint in the United States. At the same time, on the other side, the cancellations, and how by having a technological platform, we can rapidly identify those patients and manage them and rebook them, reschedule them, find the phantom cases for them, find them a place to sit as a case so that we don't lose track of them. There were also other things you mentioned, but that was a key message. And then we went on to Jamie Edwards from CloudBreak.
Yeah, and that was super fun just to, so his role has really been, how do you use this to democratize care? And oftentimes we think about democratizing care as in the geographic location, access through geography. But he's really been a pioneer in access through language barriers. Yes. So, from the standpoint of their platform really enabling 40 to 50 languages. And oftentimes we think about, okay, so Russian needs to be able to do it. Well, what we're learning is that any one location, any one facility, they need 40 languages supported. So he, again, went through very nuts and bolts of how do you put this together. They have 85,000 interactions per month. So this is a well-established group who knows how to do this. And I think in this particular moment where the physical distancing, high levels of isolation, people on travel restrictions, can't get to your loved one. So this tool is so important right now to help everybody cope with the restrictions and the constraints that we have in delivering care.
Absolutely. So that kind of encapsulated the end of our technology segment. We just wanted to show that there are tools available to everybody trying to address the COVID crisis.
Well, Bronwyn, and that was the other thing too that I wanted to really call out is, what I really wanted to call out was the technologies and the platforms and the experience and the protocols. These are not new. These groups have had 10 years of experience doing it. We just have been slow to adopt that. And I think the message that I want to share there is that there's already a lot of unknowns. But what's great is that you've got a group of people who have a lot of experience doing this. So while it feels unfamiliar to you, you're in really good hands. And a lot of things have been already solved. And so it's just, and they're there ready to jump in and support.
Right, exactly. And Richard's company actually is from Europe, and they've been doing this. I think the background was a 30-year history of optimizing the protocols so that the outcome is predictable. And they figured out a way over the last decade, really, to how to bring this to the online experience and be effective, right? So good point. Yeah, that was Joint Academy. So then we changed track a little bit and went into the sort of clinical practice. How has this impacted private practice groups, university groups, in the way they in the way they behave, really, the way they handle their entire day-to-day business. And we saw some massive changes from Jamie Caluet's perspective down in Los Angeles, Vonda Wright in Georgia, and Ted Vail here at UCSF.
You mentioned that it was clinical practice. As I was listening to those conversations, I heard more about the practice management, the organization. So from the standpoint of, just thinking about, from Jamie, from his perspective, he runs a private practice and a clinic that has a geographic footprint. So he really walked us through the entire experience of how patients would walk through the door, how they were checking temperatures, how they brought them into the rooms, how they created the welcoming in the reception area, and thinking about their staff. How many people needed to be on site? How many days did they need to be open? So there were just a lot of organizational practice management pieces that he gave us granular detail and thinking about. And then also going back to the very tough questions around, as we furloughed people versus laying off, thinking about what the financial implications, what loans are available, what the recovery package is available. And so he gave us very practical insights as a business owner and also an employer. And I think each one, while we're thinking about how do we clinically manage things, how do we economically manage things? And what I loved about both he and Vonda was thinking about new opportunities, but then also as we get a handle on this, as we break the transmission chain and then we re-engage, what are these things that we have learned in this unusual moment that we're going to take into our future practice? So, and then also to dig in right now and to say, while we're not doing a bunch of surgeries, this gives us an opportunity to really look at our business practices, our internal workflows, our culture, our internal culture. So this is a great moment that you don't normally get.
Correct. It's a sad moment in some ways, but also an opportunity, if you will. And I think that we also heard from Dr. Vail, the chairman of UCSF, and he walked us through the timeline of the experience that happened at one of the largest and most renowned university academic centers and the impact it had. We talked about residency program. We talked about surgical volumes. It was also a really insightful perspective and was well appreciated. And having looked at the impact that COVID's had on these clinical practices, you mentioned, we had to adjust. I don't know if you had a chance to hear parts of the BTS leadership section with Gianfranco Di Maria, who is in Italy, in Milan, and he is the lead of the European division or Italian division for BTS, which is a consulting firm. and their perspective on what they've been seeing in Italy in terms of what happens from a leader's perspective, the way leaders have to change the way they manage their teams, how they have to be empathic, how they have to move away from being the tough leader and looking outwards of the organization to look instead inwards of the organization to address the needs, and how it's important for that leader to be seen and to be visible as much as it's important for the employees to feel seen. You talked at length about the issue of what happens when people work from home, and showed us a timeline from first you're very busy, you're busier than you thought you were, then you're living at home with your kids and family trying to create work, and then the work is harder to quantify. So you don't get that feedback of creating work and how that changes your mindset about the work you're doing, moving into a stage of despair, following which there's a disengagement. And something he brought up, we didn't really hear from anybody else, is that they're thinking in Italy that when there is a recovery from COVID, the impact on not just the economy, but the psyche of the population will be that they may not want to engage. The some matter the world has changed, and yes, and now we're in televisits. People may not be ready. They might be fearful. They may not have the assets that requires the risk taking. It was a really phenomenal session.
Well, and then also I had the opportunity to talk with Shoshana Ungerleider in really addressing the pandemic of fear and anxiety. So much of what we're called upon to do as the helping professions, the caring professions, this is not what we were prepared for. And the fear and anxiety for ourselves, for our families, for our patients, for our communities, for our systems, for our profession. And we're taught to be tough, that we don't cry, that we're strong, we don't ask for help. And if we do ask for help, it's a sign of weakness. And so addressing the fact that we are doing things in a compressed way in the hardest environment, and we need to be checking in with each other. And to your point about the leaders leading in different ways, and there wasn't a single session, not a single one, where the word communication did not come up.
Yeah.
The vital importance of communicating, checking in with ourselves, checking in with other people, checking in with our teammates, with our family, with our neighbors.
But it's different communication. It's not communication we normally would do, right?
No,
it's a variation.
It's different communication. It's communicating in different ways. It is being vulnerable. It is being able to say, I am struggling. This is really hard. And then also for people to be able to say, if you're not struggling, I'm worried about you. And so, and then also just the new types of communication that we have to have with the people that we're caring for, because of the fact that we're isolated. And that was really interesting, is that we work better in teams. We crave that. And so we're, as professionals, missing the camaraderie. We're missing the support that we feel. We're worried about our colleagues. Then we're having to interact with patients in dramatically different ways, where we're the only human connection that they have. And then we got to interact with their loved ones in ways that they can't be there physically, they can't be there telephonically. So she really hit on the fact that this is the psychology and the emotional well-being is as important as our physical safety, and making sure that we keep ourselves safe from picking up the virus. But it was.
No, I'd like to say, let's give a quick shout out to our organization.
Yeah.
And their foundation, Endwell Foundation.
Yeah, it's the Endwell Project. Yeah.
If anybody's interested in that, they should go take a look. It's phenomenal work.
Yeah, founder of that. So.
And from there, we completely switched gears. We went to Michael Blum, the Chief Technology Innovation Officer at UCSF. And if you're interested in how to get stuff done in a big system, he laid out what you can do if you have built an infrastructure that can be called into play in a moment of crisis. Because what was interesting, one of his points was that one of the reasons that UCSF has been able to pivot so quickly is that for 5 or 6 years, they've been building a digital health infrastructure as part of their vision going forward. So when the time came, something that had been a bit of a backwater, and he acknowledged it, suddenly was able to go and quickly deploy and implement telehealth visits. We're 50% across the entire system within 1 week, tens of thousands of visits. They were able to.
It's amazing what you can do when you have to do it, right?
When you have to do it. But his point was, if the infrastructure hadn't been there and they were trying to get that done now, they wouldn't be able to roll out so quickly. And he also pointed out, if you're not a big university system, you're a small system, you can still deploy these technologies and be very successful at them. He cautioned to not believe too much the hype that's up on the websites, because some of these, especially around AI, it's not really, they can do the things that they really say they do. So he did caution a little bit. I thought that was fair. On the other hand, acknowledging that absolutely either from small groups or large groups can deploy. And he recommended that if you are a little behind in this, you have a small window, because his perspective is that when this eventually comes out the other side, business as usual will not be sufficient to meet the need. And people have moved away. So if you're coming back with the same care model, when the entire population has moved away from that care model, the product you provide will no longer be what people are looking for. And then you'll be doing catch up. So he cautioned people who are sitting back to don't do that, to embrace technology, to build the infrastructure necessary.
Yeah, that was what I was hearing multiple times. Nobody said it specifically, but the data point for me was it was a shout out to early adopters and innovators. So we get told a lot of times, innovation's expensive. When's my ROI? Well, those people who were the early adopters who embraced the newer ways of doing, worked out the different bugs, made the investment in the infrastructure when people said, we don't have enough to support it. Boy, when the time came, they were the ones who were the most prepared. So as I'm listening to that, I'm thinking, how many times when people say, well, I don't know that I want to be the early adopter.
Right.
I don't know what
Tell me about that.
I'm thinking to myself, all those people who were, it's paid off in spades. So I think that goes back to those groups that run Innovation Works. I think that this was the boost that a lot of innovators needed to hear, because oftentimes they get, there's a lot of pushback. I don't know if there's a market for that. What's the ROI? How long is it going to take?
Exactly.
So,
and especially for those of us at Digital Orthopedics Conference, like, we're here, we've got to get going, and we have our success, but I think we feel that the message is now being heard loud and clear. Yeah. And with that, though, we also are cognizant aware that if you deploy new technology, there are risks there as well. And we wanted to bring this out and make it very clear. Yes, deploy. Yes, get out there. Yes, embrace. But, and the but
do it
was
safely. Yeah.
Yeah.
And that was what Herb said. He said, the internet is, every time I talk to these security guys, I always walk away scared to death. Like, oh my gosh, I don't have the right settings on my phone or my computer. I'm incredibly vulnerable. And, I said, but he said, it's, the internet is a safe place if you know how to use your seatbelt. You don't fly down a highway with your kids and your pets unsecured, the windows down, doing things unsafely. He said it's the same thing. So
it's a great visual. I like that.
Yeah, exactly. So, we didn't used to have car seats. We didn't use to have seatbelts. We digitized without thinking about putting security in place. So this is that moment to, at the same time, while we're implementing these things, to think about what could possibly go wrong and start building in those safety features. And like you said, just like, it's hygiene. It's really putting in the people, the process, the products, having all those things in place.
And that was the second, kind of the last talk that we need to talk about, because we have already covered IDEO and the phenomenal resolution of that whole hackathon, the design-a-thon, I think it's called. And that's it. That was our 2 days. That was Design Sprint, which thankfully they defined for us, for those of us who weren't so clear on that concept. But listen, it was an amazing effort, and we'd like to acknowledge some of our co-workers.
We have an amazing team. An amazing team.
Amazing team, right? Everybody volunteered their time. This combined effort, we started on the 18th of March, I believe, which was the day after the conference you're involved with Singularity University. That was sort of a lit up a light bulb. Hey, we might be able to reach our community with a similar message, a similar vision. And then you came on board.
I don't even think it's a mission or a vision. Everybody's jumping in to help. We've at what moment in time has the entire globe had the same problem at the same time with everybody coming together to help figure it out. And so it comes from a place of generosity and caring. And like I said, if we didn't have hard problems, smart people would get bored.
True. But I do want to acknowledge our team, and then we'll acknowledge Academy as well. But yourself, you've definitely been working with us very long hours as well. Called into work my poor wife, Catherine, who's been working tirelessly as well, along with Nancy, that manage our team and manage our internal communications.
Has a last name. It's Nancy Lynch.
Nancy Lynch, yes, thank you. We're now so close. It's amazing we call each other, talk to each other. Michael Ryan, who is our board of directors. He's the chair of the board of advisors for DOCSF. Yourself, you're the director of experience at DOCSF. Christina Portillo, who's the director of the whole event. She's worked with us as well. We had one of my fellows, Dr. Giulio Santi, who has been working on the tech side along with Christina. And am I forgetting anyone? Then with the Academy. So the Academy jumped in, and they saw what we were trying to do and decided that they would help broadcast the message so that we can get more people the information that we were bringing to the table.
Yeah, and just the generosity of all the people that we reached out to come and spend their time figuring out a new technology, putting their trust in us to make this work, and then also to a really engaged audience. To think that we've had people from all over the world joining us at all times of the day, and then to see these videos that have been created already. A lot of different replays, and glad to see that, because there's great information there, and it was designed to be very tactical, very in the moment. And I suggest that you watch it now, because what we've learned is that what we presented today could be very different in 3 weeks.
Well, I don't know about that. Some of the leadership lessons will be applicable. The technology will still be there. The clinical side may change those first few lectures, but I think the rest of it may be. And so I just want to say, like Christina Portillo, I didn't say her last name. I'm bad about that. I also want to say that I reached out to a lot of colleagues, a lot of academic centers, a lot of friends around the world who also spread it through their associations. Just from the top of my head, the Australian Orthopaedic Association, the New Zealand Orthopaedic Association, New Zealand, India, Latin America. Oh gosh, all the Latin American countries got on very early. We got ECHA from Europe. The NHS innovation team got involved. We're super grateful. If I forgot anybody, I apologize. ARN.
The American Association of Perioperative Nurses, the American Nurses Association. We had support and outreach, the Johnson & Johnson folks.
Stryker. Zimmer Biomet, Smith & Nephew, a lot of our traditional sponsors all gave us a shout out as well. So to everyone who participated, contributed, forwarded the messaging, got us to 4,500, thank you.
You know what? We've got 3 questions here.
No kidding. Wow. Didn't think about look at the question thing. Oh, well, let's take it.
I love this. Did Dr. Beatty ever learn how to cover his cough?
That would be my wife.
You got it. You nailed it. All right. The picture behind me, Richard Bordeaux. He is a remarkable painter. He's one of my absolute favorites. He is based in Highlands, North Carolina, and he does these things that are absolutely larger than life. I own several of them, and he likes to say that I am his patroness. So,
awesome.
And what other question do we have in here?
If we covered anything, if we do this again, we'll get to AI. I think that's the one area that was kind of too big to swallow in one fell swoop. We want to work primarily on tele and practice and implementation, and also the COVID disease itself. And then we want to filling out the time. That's my take. What are your thoughts, Sean? I think you didn't get to.
I think that the AI is a huge piece. I know that we're focused on the clinical and the technical. I don't think that we can spend enough time right now on the emotional and mental well-being. And I will tell you, one of my wish and my concern is we need to take care of each other really well. What we are seeing is difficult I think the thing that really struck home with everybody was Luigi Zagra, when he shared with the number of colleagues that we've lost in a short period of time. And without having these opportunities to respect, to have bereavement, to be close when we need to be physically close and emotionally close. Like I said, my wish and my hope is that we take really good care of ourselves, take really good care of each other, to protect our families, our society, our professions. I think if we're not really thoughtful about this, we might get the practice management right. We'll definitely come up with a vaccine. But if we've lost people's souls and their desire to want to help and to serve, I'm not sure what we've won if we lose really good people in the process. So I hope, the AI, the technology, but at the end of the day, it's all about being human.
And with that, I just keep remembering, sorry, remember people we forgot to thank. I forgot to thank Total Joint Orthopedics, OrthoGrid. I just can't, there's so many companies that support us as well. So thank everybody. Thank you for that note, Shauna. And with that, we're going to close out the COVID-19 DOCSF Virtual Summit, and look forward to seeing you online. We do have a podcast. That's going to come out more often, more quickly. These sessions are all available both on YouTube and on this same site. And we'll have links to that.
Come take a listen to See You Now. We've got a new series that we just launched today, COVID-19, the nurse response. And we're looking for those stories for the people who are in the midst to learn what they're learning right now that can help all of us. And like I said, just stay home, stay connected.
Thank you.
Thanks.
Bye-bye.